Good morning, everybody. Welcome. We're so excited to see you all here today. I hope you've enjoyed your stay so far here in the Washington, D.C. area. And for everybody online, welcome. We're so glad to have you here today with us. We have a packed program. It's really interesting. When I first began planning this in about January, February, I sent a message out to our doctors and said, hey, anybody interested in doing something live this year? And I tell you what, we have 17 presenters, so let's give it up for our presenters today. They were all willing to jump in. We are going to have some that are going to be virtual, but we have a lot of them in person that you'll be able to mingle and interact with as we go through the day or the days. So we're really super excited about that. So I do want to start off with just a few housekeeping things for the people that are in the room. On your tables, you'll see that you have these cute little frames. There's also some markers on there. You can put your name on it. You can do whatever you want with it so that people at your table know who you are. So enjoy that. And of course, we have lots of good treats and stuff for you to munch on during the day. We will have a nice lunch a little bit later out in the lobby. We're also going to have our wonderful dinner this evening with a keynote speaker that we'll pick up out in the lobby, but we'll bring in here so we can listen to our keynote speaker. And we have all these wonderful tables out here. I saw you guys already mingling out there with the pharmas. There is so many great things happening in the HypoPARA world. So go out there on your breaks. Before we start this evening, they'll be open as well for you guys to be able to talk. We have Ashley Kirk here they've done the clinical trials from Physicians East. They've done them for TransCon, Calcilytics, Amulet, so they're a wealth of knowledge for anybody that's interested in that. So there's a few of those housekeeping things. Again, some of our presenters are going to be virtual, so for you guys in the room, you'll pay attention to the screen here, and they'll come up on the screen. Other than our first presentation, we will have opportunity for Q&A afterwards so that we'll run around and let you guys ask some questions to the doctors. And then tomorrow, we're going to have a panel with 4 doctors that you can ask questions that you would want to ask. So we're really excited about that. Let's see. So anybody online, if you're having any trouble getting online, please look at our website. You'll be able to see the information there. If not, Michelle will be monitoring her email this morning. It's mrays@hypopara.org, and you'll be able to get connected that way. But no matter what, again, everything's recorded, so you'll be able to see these things for forever. Also, for people at the table, you'll see a little card on there. It says Voices of HypoPARA. This is super important. We'd really like to get as many people as we can to be able to sign up and do the survey for Voices of HypoPARA. We want to hear what your experience is like as a patient. So please take some time. It'll be open for a couple of weeks, but please take some time. For you guys online, it is on the website, so you can take a look at that as well. All right, so doing an event like this takes a lot of people to pull it together, and there's a special group of people that I really want to recognize before we get started, and I turn it over to Bob. Early on, we couldn't decide if we were going to do hybrid, if we're going to do in-person, if we're going to do what we were going to do. And we were able to find these fantastic production crew, which you guys see has done an amazing setup here, right? So we really want to thank John Dudley and his crew for such an amazing job. Yep, very good. And then we also have Calcilytics is here with us. So anybody from Calcilytics in here? They're back there. Yeah, welcome to them. Ascendus was also a sponsor. They're back there. Thank you so much. We also have Amulet in the house, and they helped sponsor this event as well. MBX is here. We'll be able to hear from them for the first time this year, so welcome. And Takeda was also a sponsor this year, so we want to recognize them for their sponsorship. We also have, like I said, Physicians East. Ashley Kirk is here to be able to help talk about clinical trials. So we're really excited about what today is going to bring over the next couple of days for you. So we talked about being the change, right? And what does that mean? So as we go through the next 2 days, I want you to think about yourself, but also think about the greater good in the community. When you think about where we were to where we are today in development, it's pretty darn amazing, right? So I really want you to think about that. I want you to think about how can you be a part of the change? How can you be the change? And again, we'll talk about that a little bit more. But before we move on, I did want to introduce to you our president, Mr. Bob Sanders, and he wants to share a few words before we start.
Thanks, Patty, and gosh, I can't believe it's been 4 years since the last time we all met in person, 2019. So I'll just wrote a few things down. So anyways, yeah, welcome to the 2023 International HypoPARAthyroidism Conference. Seeing these new and familiar faces just swells my heart with joy. You know, being able to connect is what this is all about. Again, like Patty, I want to thank our sponsors, the ones that make all this possible. I want to thank Finn for helping us get the word out on the social media campaign and really grow in the community. It's amazing to see how many new members we see every day. I see new members pop up on the website and connect through the website as well, through social media, right? These are all people that I'm not going to say they're lost, but you know, now they're found. I also want to thank the HPA Medical Advisory Board and the speakers here today, tomorrow, for their continued commitment to the HPA mission. Again, my name is Bob Sanders. I serve as president for the HypoPARAthyroidism Association. And we drive change by, sorry, I lost my place. Anyways, I just want to acknowledge another individual person, which is Patty Keating, for putting this event together. She's been working tirelessly since, like she said, February, putting this together. And I'm honored to be here with the rest of the board. Michelle Reyes for all the hard work she puts into it, and Deb Murphy, and many of you known her for a very, very long time. Loretta out running the registration. Unfortunately, Barry Vapnik is not here. She's been running the social media campaign. We cannot do this without the support of the board and everyone else. So real quick, Patty asked me to kind of share a few things. You know, and since 1995, HPA has been committed to raising awareness for the hypoparathyroidism community and has advocated for better treatment options for patients and their families. This all started when my father, James Sanders, enrolled in the early PTH 1 through 34 trials at the NIH in the 90s. Sorry if I get emotional. After doctors realized that this was a genetic condition in our family, they decided to enroll the rest of us children. This put us at the Children's Inn, and I don't know if anyone's familiar with the Children's Inn at the NIH, but we're literally living in a community. We have our own separate rooms, our own suites, but we share community sites, you know, so we share the living rooms, the kitchen, the dining rooms, and because of that, we all started forming these bonds with all these families, with children with other rare diseases around the world. And if you knew my father, he always put the needs of others above his own. He was always in the service of God and in his fellow men. You know, throughout the years, we remained in contact with many of those families, and some of them who are no longer with us. I truly believe that he was inspired to organize the HypoPARathyroidism Association based on our experiences at the inn. He did this with Julie Hunsaker, who's no longer here. She passed away in 2020 from pancreatic cancer. And then Lorraine Bolton and my mom. The four of them started this organization from the ground up. And it all started by just a little monthly newsletter connecting all the patients that were in that original trial and staying in contact with them. And building on those relationships, he brought together a so-called medical advisory board, connecting even more patients and more doctors together, and advocated for change every day, always putting the needs of this community at the forefront. HPA was instrumental in getting the first PTH replacement therapy to market with Natpara, and today we continue to work with industry leaders, researchers, doctors, and regulators to bring the next therapy to market. As many of you know, hypoparathyroidism is a rare endocrine disorder. affecting the lives of approximately 1 out of every 2,000 people. The impact of hypoparathyroidism on those living with the condition cannot be overstated. It has led to significant physical, emotional, financial challenges for patients and their families. However, despite the impact of the condition, there is still a considerable awareness or lack of awareness and understanding of this disorder. At this year's conference, we've chosen the theme, Be the Change, like my father, to highlight the critical role that we, including our sponsors, organizers, and attendees here, online and in person, play a role in driving positive change for those impacted by hypoparathyroidism. Being the change means taking action to create a better future. It means using our skills, resources, and expertise to drive positive change for those in need. It means being a champion for those who cannot be championed for themselves. Our sponsors work tirelessly to bring forth new and exciting treatment options, some of which you will learn about over the next 2 days. Caregivers sacrifice themselves for those who may or may not be able to care for themselves. Patients who participate in clinical trials and studies that get the industry and the researchers the necessary information to move the ball forward. Patients and caregivers are telling their stories for the world to hear, stories that let members know they are not alone in this fight and give hope for a better tomorrow. Those same stories are the driving force that affects change in policy and treatment standards today. So please never stop telling those stories. They're important. Our doctors take the time to learn about hypoparathyroidism, and educate their patients. They also take that information they learn and educate other fellow doctors, industry leaders, and researchers worldwide. Together, we all play a critical role in improving the lives of everybody affected by hypoparathyroidism, and we are excited for the future. Over the next few days, let us think about how to be the change. For those impacted by hypoparathyroidism, we will be hearing from doctors and experts, industry leaders, and some of them who are patients themselves. Topics covered will be clinical trials, clinical updates and opportunities, current and future treatment options, and medical devices, and mental health. We'll then close the conference to discuss the importance of advocacy, education, research, and offer practical tips on getting involved in this vital work. We will continue to share our stories, successes, challenges, to come together as a community to drive positive change for those impacted by hypoparathyroidism. So let us explore how we could all be the change for those impacted by hypoparathyroidism. Together with our sponsors, our generous sponsors, support, and our organizers, hard work, we could create a better future for all. And I want to thank all of you for taking the time out and attending this conference with us today, and explore the theme of being the change. Thanks.
All right, thank you, Bob, for that wonderful message. All right, so we're going to move on to our first presenter, and again, for you guys in the room, it is going to direct your attention over here. Dr. Shobak, Dr. Dolores Shobak, is from UCSF Health in San Francisco, California. She's actually going to be doing 2 presentations for us. Today, she wanted to just kind of give an overview because she said there's so much going on in the hypopara world, so many different things that are happening with the task force that she wanted to give us an overview to really kick off the conference. So enjoy.
Good morning, ladies and gentlemen. My name is Dolores Shobak, and I'm an endocrinologist from the University of California, San Francisco, and the San Francisco VA Medical Center, and I'm really delighted to be able to speak to you this morning. I so wish that I were there at your conference. I know this is always a great conference, and I really, really enjoy meeting you and talking with you and working together on this very important topic. So my charge this morning is to talk to you about work that's gone on over the last almost 3 years to put together the second international workshop on hypoparathyroidism. I'm going to share with you over the next 30 minutes or so some of the highlights from 4 task force reports and the guidelines that came out just this past year from the work of this important international workshop. So before I speak, I want to tell you that I do have a couple of disclosures. I serve as an investigator on the Pathway trial, and I hope to be an investigator on the Calypso trial with the new PTHRP analog, and have been a member of the steering committee for the Paradigm registry. So this second international workshop, as I said, worked over about a 2.5 year period. It was led by Dr. Aliyah Khan, who'll be speaking to you today, and also by Dr. John Bilezikian, who many of you know. And this workshop put together 4 task forces on this disease. The first was the one on epidemiology and financial burden. The second was on etiology and pathophysiology. The third was on genetics and diagnosis, and the fourth was on management of the condition. And then finally, there's also an important paper on guidelines led by Dr. Khan and her co-authors. Why is this so important, and why did I ask to speak to you about this? Well, I think it's so important for us who work in this field and for you who are contributing knowledge every day to this field, and it's very, very important, is that this task force put out several very strong scientific papers that were peer-reviewed, that really covered the condition of hypoparathyroidism in its totality, I think. And I think this is going to help all of us as we work together and go forward. Because when you publish strong papers, the message is out there and it's respected and it's strong. It gives update in a field, and this really matters because it focuses the attention of people on a given disorder so that people can work on it, think about it, and then treat their patients hopefully in a more up-to-date and efficient way. And then just by having new papers that come out, your healthcare providers may get to see a new paper on your condition and learn more. So I think for all of these reasons, these are important papers. And this makes the disease, if you will, more visible to both the public and to the medical profession. And maybe a science writer will come and write a paper, an article about this, and again, raise disease visibility. And then for you, new papers come out and you might share those with your providers. So these are amazing resources, these papers. So the first one, as I said, put out by the Task Force on Epidemiology and Financial Burden, was led by Dr. Bjorn Stotir, as well as Dr. Clark, who's the senior author here, and some of the other international members of this task force. Why is this paper important? Well, it covers both the prevalence of the disease, the incidence, the mortality, the healthcare burden of having hypoparathyroidism, and some of the complications of hypopara. And then, importantly, because funding agencies like the NIH, they look at papers like this, and this paper gives us a research agenda. So where can we do work that will help this field? There's a very important table. I won't go into it in detail because we're going to cover so many different areas this morning in a short time, but it really goes through all the different cohorts across the world that have over 500 patients in them, and tells us what are some of the predictors, if you will, for the development of permanent hypoparathyroidism around the world. So it's establishing an incidence, if you will, of the disease, and that's very, very important. This is a really important table that's in that paper. It's on kidney complications. And I know this table has a lot of information in it, and the numbers and the words are in very small print. But I will just tell you a few things about how we look at a table like this, okay? So first of all, let's start over here on your right, where I've put some definitions in here. So kidney complications, another word for kidney is renal, okay? And so CKD is an abbreviation we use, and it stands for chronic kidney disease. And chronic kidney disease has 5 different stages. Stage 1, your kidneys are perfect, okay, and progressing all the way across to stage 5, where you're preparing for dialysis or on dialysis. So it's a spectrum. It's the different stages of chronic kidney disease, and each one is a progression along the way. Nephrolithiasis, that word means kidney stones, okay? So we all know what those are, but that's the technical word. Nephrocalcinosis, again, means calcium. Calcinosis is calcium, and nephro is kidney. So calcium deposits in the kidney. We want to try to avoid that because that can damage kidney function. And then finally, hypercalciuria, high levels of calcium in the urine. So these are like 4 parameters that we look at as physicians, for example, to kind of know what's happening with your kidneys. Okay, so one of the very important tables in this paper from the first task force is summarizing across the world all this important data on kidney complications. So let me explain it even a little bit more. So if we start over here on your left, where I've put this yellow arrow, we're first looking at single center studies, okay? And here's one out of Boston. And so what this table tells us is this study out of Boston, patients in it, 41% had chronic kidney disease, 30% had kidney stones by imaging, a quarter of them had high urinary calcium. So this is stacking up all the data from all these different countries, 6 different countries, where they've looked at kidney complications in hypopara. Then if we take a look down here, we're looking at population studies. And again, you can see 5 or 6 different countries. And let's just take the first study, which came out of Denmark. You can see the N means almost 700 patients with hypopara were included. And then they give us this statistic called the hazard ratio. And that means the risk of having something, the hazard of having something. It's a statistical point. But what it's telling us in this Danish study is that the risk of having chronic kidney disease, if you have hypopara, compared to the normal population of Denmark, is about 3 times that rate, okay? And the same with kidney stones. The rate of kidney stones here is about 4 times the rate versus the general population. And so, you know, we're not going to go into every number that's in this table. That would take way too much time, and you're not interested. But what I'm trying to say is that in this one little table, you've got the world experience summarized with the kidney complications of hypoparathyroidism. And so that's very valuable. You know, a healthcare provider can sit down, look carefully at this table, and learn so much information about the kidney in hypopara. So this paper from Task Force 1 has other really key information, and I think all of us are interested in the different topics that are covered here. So what they summarize with respect to mortality is that the results are mixed. We don't really know that hypopara across the world increases mortality. The studies don't agree. The healthcare burden, in contrast, is real. Hospitalizations, ER visits, almost 80% of patients experience those. Interference with daily life, 50%. Household activities not performed, almost everybody. And then a change in employment in about 20% of people. So this is really, it seems so simple, doesn't it? But it's really useful information because it tells us really what it's like to live with hypopara. The kidney data we've just gone over a minute ago. The bone information that's summarized here basically tell us that if you make sophisticated measurements of bone structure and bone mass, we can find changes. But fractures are likely not increased, again, if we look across all the studies in the world. Cardiovascular complications, most of the studies, but not all, will say that hypopara doesn't raise the risk, but not all are in agreement. In terms of cataract risk, it is greater, but the duration of the hypopara and the age when it was diagnosed are critically important. And they appear at a younger age and so forth, okay? Basal ganglia calcifications, yes, that's part of the picture. Infections, 1 or 2 studies say it might be increased. Cancers don't seem to be increased. That's great news. That's good news. Neuropsych issues, yes, greater rate of depression and bipolar disease and anxiety. So all of this kind of information is summarized in that one task force report. So again, very important, very useful. Okay, so that second task force, we're going to take them one by one. So the second task force looked at etiology and pathophysiology. So etiology means the cause, And pathophysiology means how does it happen? How does it come about? Tell us how it comes about. So what I like about this particular paper is that we were able to include 4 really top endocrine surgeons in this task force. And one of the first things they proposed, and it's so straightforward and simple, but so important, they said, let's make a consistent definition of what chronic hypopara is. And that was proposed, and it was adopted by the entire workshop and became part of the guidelines. And so that definition is a low serum calcium and a low PTH persisting 12 months after surgery. So that's really, really important, a basic definition that we all agree on, and we do. Table 1 talks about non-surgical causes of hypopara. Table 2 in this paper talks about the views of surgeons. Again, we had a strong surgical voice here. The views of surgeons on different stages of low blood calcium that they see and how they're recommending to their colleagues to treat it. Table 3 looks at some of the symptoms that the surgeon should, use to recognize hypopara, and risk factors for the disease in their patients. So what I like about this paper is that we have a very strong group of endocrine surgeons speaking directly to their colleagues. And I won't read all of this to you, but this is a direct quote from this paper where they are saying, here is our definition, here's the blood calcium to look for after surgery, even if there are no symptoms, okay? And they remind you that it's usually transient. And they talk about the monitoring that should occur in the first 6 hours after surgery. So I think that's critically important because, again, in one place, surgeons talking to other surgeons about how to take care of people in the immediate post-op period. And they're also saying treatment needs to be instituted if people have symptoms of hypopara, and what that treatment should be, calcium salts and activated vitamin D, given to them prior to discharge. This paper also talks quite a bit about some innovations that are being done by our surgical colleagues to reduce the risk of this happening in other people. One of those things is doing what's called autotransplantation. In other words, if a parathyroid gland is removed inadvertently during an operation, to get it back into that patient pronto. Okay, and so they're encouraging that, which makes perfect sense, but it's important that that be emphasized. They're also developing ways and testing ways to identify the glands in real time, like right there in the OR, and protecting them and preserving them and not taking them out of the neck. Okay, and they're also looking at techniques where you can inject a dye into the vein and then see whether the tissue in the neck is actually a parathyroid gland and whether it's viable or not. And then they're using fluorescent properties of tissues like the parathyroid to try to preserve those glands in the neck. So lots of surgical innovations coming because they're listening to the fact that this is an important complication that we're all trying to prevent. And another thing about this paper is that it covers some of the very interesting work on bone involvement in hypoparathyroidism done by Dr. Rubin, whom you're going to hear from, and Dr. Dempster, Dr. Belazikian, and all of those investigators from Columbia University. So it talks quite a bit about the bone. And as you know, we often do DEXA scanning to check for bone mass and look for osteoporosis. And this is just a reminder to you that often the bone density in hypopara is higher than normal. It's not often in the osteoporosis range. But this work from Dr. Rubin and her colleagues show that the structure of that bone, we call it the microarchitecture, the fine detail of it, is different from people who have normal parathyroid hormone levels. And the levels of bone markers, we call them, bone turnover markers, those are often low, signifying the fact that normal levels of parathyroid hormone, those are critically important for maintaining the level of bone turnover and bone integrity. And then this is just, I always am impressed with this picture, but this is a picture of a CT scan at the microscopic level of a bone biopsy from a control patient over here on your right, and then a patient with hypoparathyroidism. And you can see structurally this bone is very dense from the patient with hypopara and much more open and biochemically active in the control patient. So this is just telling you that at the structural level, the bone looks different. And then there's a nice discussion of the causes of non-surgical hypopara in this patient, in this paper. So again, I think a very, very interesting and important paper in the topic. So Task Force 3, we're moving right along here, hopefully, talks about genetics and diagnosis. And I think you can recognize the authors here, Dr. Monstad, Dr. Roscoe, Dr. Brandy, Dr. Gaffney, and so forth. So many contributors who often speak at the Hypopara Association meetings contributed to this task force report. So again, stepping back for a moment and just talking about what is in this paper and why is it important. Well, there are several tables, and the first one talks about what's the probability of developing hypopara after a surgery. So it summarizes, again, statistics from all over the world, and that's very powerful and very important because then surgeons can look and compare their success or lack of success with what's going on. How is the field evolving? How are things getting better? This second table is an amazing resource. It summarizes all the different genetic causes of hypoparathyroidism. To me, it's the most complete, the most useful table with the most current information that I've ever seen on this topic. So very valuable. And I said here, for all endocrinologists to have a look at. Because if you are seeing patients with non-surgical hypopara, and every time I've come to this meeting, I've met with several of you, we need a resource to go to look up this information because it doesn't come in the office every single day, and we need a good place, a good resource. And this is an excellent resource for any of you to look at who are trying to understand why you have non-surgical hypopara. And then this table 3 gives us some detailed information on calcium sensing receptor antibodies. This is more important for researchers, but the reason I tell you about it is that I want to assure you that we are looking for biomarkers in different forms of this disease, and this is potentially one of those biomarkers. So this paper also has a bunch of really valuable recommendations. The first is when you do obtain that parathyroid hormone level after a total thyroidectomy, what we can do with that level is predict who will not develop permanent hypopara. So that can be very reassuring for the patient. So say 6 to 12 hours after a total thyroidectomy, if you have a parathyroid hormone level that's above 10 picograms, for example, okay, the chance of getting permanent hypopara, it's very, 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 very low, okay? So often you will not need any kind of long-term treatment. But if the values are less than 10 picograms per mil, 12 to 24 hours after surgery, you do have a significant chance. It's less than 50%, but it's real, of having long-term hypopara. Why is this important? You might say, gee, that's such a fine point. But doctors like guidance, and they like it spelled out, and they like it based on evidence. And as I've put over here, this is a strong recommendation because they've got good quality evidence. There's a lot of studies that support this simple concept of that number, that PTH value. So that's a very important recommendation. As simple as it sounds, it's very valuable to have out there. Who do they recommend to have genetic testing? That was another important recommendation of this task force. So they said it should be done in people who have a positive family history or have other features of different forms of hypopara, like that table I mentioned to you, or who are younger than 40 years old. So if any of you haven't had genetic testing and you have non-surgical, these are the recommendations now from the most up-to-date task force report on genetic testing. They recommend air gene testing if there are any features of autoimmune hypopara. And then they give us a definition for what has been called idiopathic hypopara. And sometimes when I talk to patients who are non-surgical, they say, well, I was told I have idiopathic. I don't know what that really means. So when we do all of the testing that we can do, up to the limits of what we can do, if the testing is all negative, then we can call that situation idiopathic. And then again, this task force agreed with the surgeon's definition, which is 12 months of hypocalcemia and low PTH levels after surgery. And again, healthcare providers, doctors, we like the guidance spelled out, evidence-based, make it simple, make it straightforward so that we can do what we need to do. So that's why all this is so, I think, very, very important for the field. The final task force paper was led by Dr. Kahn, and you can see many authors on this paper. And this is about how to manage hypoparathyroidism. So really, really important, because that comes into play every single day of our lives with this condition. So this paper focuses on different strategies and advice for healthcare providers. The first table looks at the different complications and the symptoms, and they cover everything. They cover all kinds of hypopara, post-surgical, non-surgical, and even in children, and put together the complications and symptoms. Again, the one-stop shop where you can find all this information. Then the second table, which is terrific and is big and very, very helpful, puts together all the different studies that have been published on parathyroid hormone therapy and hypopara. It lists every single one and how many patients were in it, and so on and so forth. So again, if your doctor is wanting to read one paper on the management of hypopara, this is that paper, okay? Because it's just got everything very nicely put together. And then this final table here, table 3, looks at the findings where they compared parathyroid hormone therapy and conventional therapy in this disease. And the comparisons are on quality of life, depression, reduction in calcium and calcitriol treatment, adverse events, discontinuations, and so forth. So it's a side-by-side comparison of the two different types of therapy. So a really, really valuable, really important paper on management. Again, the one-stop shop. Finally, turning now to this 5th paper, which was basically the guidelines. It's a summary statement for evaluating and managing hypoparathyroidism, and it also put forward the guidelines from this second international workshop. So you can see that Dr. Kahn led this, Dr. Belazikian, Dr. Clark, who many of you know, and Dr. Monstad and Dr. Guyot. Okay, so guidelines, those are very, very important because what a guideline does is it takes all the evidence in a field from the beginning of time almost, and it benchmarks that evidence against the standards that we use to judge, treatment efficacy and safety and recommendations in all other areas of medicine, like comparing it to the management of heart attacks and hypertension and so forth. So standing up to those benchmarks, those high standards for evidence, for example, is a tough thing to do, okay? And we don't always have the highest level of evidence in a condition like hypopara. But what we did in these guidelines was to include what's considered expert opinion when we don't have all of that high level or large amount of evidence from randomized trials. So guidelines do that benchmarking, and that's really, really important. This paper included authors from all over the world, which is really important because we need to work together, and we need to, bring everybody into the fold in terms of giving advice and managing people with this condition. And this paper has 7 really important recommendations, and we'll go over them in a moment. These were the strongest, and so they made they separated out those 7. And then they have, and I think those are very valuable ones as well, what they call ungraded recommendations, because the evidence wasn't quite there for these others, but they're still important because we have to make decisions on how to manage those different aspects of hypopara every single day. So we've got a lot of good advice in this guideline paper. So what are those 7, what I call main or key recommendations? The first is something very basic, and I've mentioned it before. How should we diagnose hypoparathyroidism? They couldn't grade this recommendation, but it's critically important, right? That's the first step. Are we all making the diagnosis correctly? So we need a low ionized calcium or a low total albumin adjusted calcium. Okay, so a calcium and albumin need to be done. And then the person needs to have an undetectable, a low, or an inappropriately normal PTH measured twice, at least 2 weeks apart. So that's, again, a basic definition. It sounds so simple, but we need to agree so that we're talking about the same thing. So number 1 recommendation is, how are we going to agree on the diagnosis? The second important recommendation is, how can we reduce the risk? How can we mitigate the risk of this happening to other people? So the recommendation is, if a parathyroid gland is removed inadvertently, you don't want it to be removed, okay, reimplant that gland right away, okay, and avoid removing things that aren't supposed to come out of the surgical field, okay. The third recommendation, and this one was graded because there was enough evidence, and I've already mentioned some of it to you already, get that PTH, get that calcium 12 to 24 hours after the big thyroid operation. And I mentioned to you already the cutoff of 10 picograms per mil. If that level is below that, you have a good chance of having problems initially with calcium and then potentially down the road, and this may progress. If it's over 10, the risk of having chronic post-surgical hypopara is much lower. So this is a very important recommendation that went straight into the guidelines. Then they looked at, and I didn't put this table in there, but when you take a look at this paper, you'll see it, some of the signs and symptoms by surveying articles and endocrinologists around the world, some of the most common symptoms and signs of hypopara, and that was graded as well. Now, their 5th recommendation relates to monitoring people with chronic hypopara. What's optimal? Okay, and you can see over here, all of these were not very high quality evidence, just didn't have a lot of data. But at any rate, expert opinion tells us that for new patients, measuring kidney function by the creatinine, measuring the estimated glomerular filtration rate, again, part of kidney function, the blood calcium level, the magnesium, the phosphorus, the albumin. That needs to be measured, obviously, in a new diagnosis, and then every 3 to 12 months for patients who are stable and are in clinical follow-up. The vitamin D at the outset, and then every 6 to 12 months, making sure that that 25 hydroxy vitamin D level is in a good range, at least, in my own personal opinion, at least 30. Okay, and then a 24-hour urine for creatinine and calcium at the beginning, and then every 6 to 24 months, depending on the situation with the patient. In the text, it says we should do a baseline assessment for kidney stones and kidney calcifications, and you can do that by renal ultrasound or kidney ultrasound or kidney CT scanning. So that should be done at baseline. And then if you're making a change, if you're making a change in the calcium supplements or the calcitriol supplements or the PTH for that matter, then you want to monitor the serum calcium within either a couple of days of that change or, within a week or so. So these are just some very basic monitoring recommendations for patients with this diagnosis. So how should patients with hypopara be managed? And this was also a graded recommendation, but still on the low quality side because we have few randomized trials that guide us here, but we're able to grade this recommendation. So the first line therapy is treatment with conventional therapy, which is calcium supplements and calcitriol. And they made a comment on this recommendation that if conventional therapy isn't working or is thought to be unsatisfactory, then you consider the use of parathyroid hormone. And this is very valuable because we don't have a tremendous number of trials here, but we know that if people are not doing well, this is a place where you would consider parathyroid hormone replacement. And that's going to be important when we're dealing with insurance coverage of the new parathyroid hormone preparations that likely are to come to the clinic. And then they made 9 more specific recommendations about all kinds of different medication, like our supplementation, like magnesium supplements, vitamin D, looking at the phosphorus. All of them are important. I'm not going to go into each one here today, but I just tell you that this is a very thorough paper on management of hypopara and guidance to the clinician who's trying to manage this. The 7th important recommendation that I'm going to tell you about is a series of recommendations, if you will, about pregnancy and lactation. And first time, this is so important. This is the first time really pregnancy and lactation is front, right, and center in a set of guidelines about hypopara. And that's a very, very good thing. So in women with hypopara who become pregnant, they propose that we try to have a serum calcium in the mid to low normal range throughout the pregnancy. This is really, really important. You want really good control of the calcium during pregnancy. And you want to see that the phosphorus, the magnesium, and the vitamin D are also normal during pregnancy. Then it's recommended that calcium be measured every 3 to 4 weeks during pregnancy and during nursing. And you may also more carefully monitor for any symptoms of low blood calcium, that's hypocalcemia, or high blood calcium, hypercalcemia. Finally, doctors taking care of these women should work closely with the obstetrician and the pediatrician to make sure also that the baby is carefully watched for a low blood calcium or a high blood calcium. And then finally, we are not approved to use thiazide diuretics or parathyroid hormone or parathyroid hormone analogs during pregnancy. So what we've reviewed over the last 30 or 40 minutes are 5 really important papers from this international workshop that took place during the pandemic. As I described to you, this workshop established 4 task forces in different areas and took a really refreshed view, a modern view, if you will, of the disease. There were working groups of healthcare professionals from all over the world. There were patient advocates involved, and there were members of the HypoPARA Association. You can see the picture of Deb Murphy up there smiling over here, and Bob Sanders, who were authors and participants in the work of this task force. And what I find so very important is that this task force, this effort, brought together a whole group of international investigators, including surgeons, really important, and including junior investigators, so we can get our younger colleagues interested in working in this field. And one thing I haven't emphasized, but I will now, is to tell you that the most respected academic group that works on evidence-based medicine, that basically developed the field of evidence-based medicine. Dr. Gordon Guyot and his team were involved from the beginning all the way through to make sure that the guidelines that were developed were high quality, were evidence-based, and of the best possible caliber. And that's so very important, because they're will be respected by everyone. And then, importantly, these guidelines were endorsed by 65 different endocrine societies from around the world. And I've just included a picture of Dr. Guyot over here, and our friend and colleague, Dr. Aliyah Khan, who led this effort. And with that, I will stop. Thank you so much for your attention, and wish I could be there to answer your questions directly. But I had wanted to present these papers from a very high-level view, so that you knew that this was really valuable information that's now out there for all of our physicians and our healthcare providers, and for us as and for you as patients to read and learn from. So thank you again, and enjoy this wonderful meeting.
All right, thank you. Thank you to Dr. Shobak, right? All right, so we will be starting back up at 10 o'clock for everybody online. And for people in here, there are some seats available at the tables for people that are standing if you want to kind of move in. But everybody, please come back to your seats at 10 a.m. Thank you. All right, we ready to get started? If you can hear my voice, clap once. If you can hear my voice, clap twice. Thank you. All right. Okay. And we're online? Okay. We're ready to get started, and we're really excited because we have our local team here who just got to drive right on in this morning from NIH. So we're really excited. We're going to have all of them speak over the next hour or so. But I did want to really thank Dr. Kelly Roscoe, Dr. Gaffney, Dr. Hartley, and Dr. Lionicus. Yes. All right. Very good. So welcome to the NIH team.
Great, thank you, and thank you so much for having us here. I think I can speak for us all that we love being able to be here and speak to you all. So it's great to see everyone in person, and I'm glad some people can join online. So as was mentioned, all four of us from the NIH are going to speak today, and we thought we would each give you our parts of the talk, and then we're going to stay up here as a panel at the end and have plenty of time for questions, so that you can sort of ask all of us at the same time at the end. So I am going to speak about autosomal dominant hypocalcemia type 1 and go over some of the mechanism and the natural history of this disorder. And these are my disclosures. So first, I will start telling you a bit about normal parathyroid gland function, just to go over the basics there. And then we're going to talk a little bit about what is ADH1, the characteristics of ADH1 patients, and some complications that are specific to ADH1. So hypoparathyroidism, as many of you know, the main function of parathyroid hormone, or PTH, is to bring up your calcium in the blood. So there are 4 parathyroid glands, typically 4, that are located behind the thyroid, as you can see here. And I'm so sorry, I don't have a pointer, so you probably, what? Yeah, it just doesn't come out on the screen. I don't know if you see it. So there are 4 parathyroids located here behind the thyroid. And when the setting of low blood calcium, the parathyroid glands increase PTH secretion. And this acts in a couple main ways. First, PTH causes the release of calcium from the bone. And the bone is like a really large storage repository for calcium in our bodies. So that signal from PTH to give some calcium from the bone helps to keep our blood calcium in the normal range. Additionally, PTH acts at the kidney, and it tells the kidney to hold on to calcium and keep that calcium out of the urine. So again, sort of keeping more calcium to bring the blood calcium up. Also at the kidney, parathyroid hormone acts to increase the production of active vitamin D. So there's vitamin D and there's active 1,25-dihydroxyvitamin D, or calcitriol, as I'm sure you are all aware of. So parathyroid hormone increases the calcitriol production. And calcitriol goes to the intestine, where it increases calcium absorption from your food. So by all those ways together, parathyroid hormone is going to increase blood calcium levels to help keep them in the normal range. So how does the parathyroid gland sense calcium? Well, it does that through the calcium sensing receptor, or CASR. And this is just a picture of the receptor, because some of you might have heard of these parts of the receptor. And essentially, it's a large protein. There's an extracellular part, that means outside the cell. And that's the part that is, okay, that's the part that's going to sense calcium at the top there. Then there's a transmembrane part, which kind of goes through the cell membrane. And then there's the inside the cell part, or intracellular. And that is the part that actually signals through what we call a G protein. So we call this a G protein coupled receptor. And it's that signal that signals to this cell to increase or decrease PTH production. So this is a calcium sensing receptor, and we'll talk more about that as we go on, especially in ADH1. So the calcium sensing receptor is located in many cells throughout the body, but we really focus on the parathyroids and the kidneys. And in those two organs, the calcium sensing receptor is located in much higher numbers. So in the parathyroid cells, it's going to be sensing low calcium and then increasing PTH production and release. On the kidney cells, when it senses a high calcium, it signals that release of calcium into the urine. So if you can imagine here, the cell being sort of like a factory, there's this machine inside that's producing parathyroid hormone. And there's a really narrow range from 8.5 to 10.5 that we consider this normal serum calcium. We don't want to go too low. Obviously, you all know that. We also don't want to go too high. So really, the body needs to keep us in a range. And the calcium sensing receptor is here, detecting calcium and telling this machinery to produce PTH. So let's think of the calcium sensing receptor sort of like a thermostat in your house, right? So when it's cold out, the thermostat is sort of saying it's cold, turn on the heater and make heat. And in is really same analogy, you can imagine the calcium being low and the calcium sensing receptor detecting that low calcium and telling the parathyroid cell to make PTH. That PTH obviously then goes to the bone and the kidney and the 125 to the intestine, as we've all spoken about already, to bring up your calcium. So when blood calcium is low, the calcium sensing receptor is sort of turned down in activity and PTH production increases. Again, bringing up calcium. When the blood calcium is high, the calcium sensing receptor is activated, and that is going to decrease PTH production. As you can see here, the machine is sort of shut off by this signal. And you're not going to have this signal to increase blood calcium, so your calcium is going to start coming down. And about the calcium sensing receptor in the kidney, when this calcium is high, the calcium sensing receptor is going to tell the kidney to get rid of calcium by putting it in the urine. And so therefore, these people are going to have increased urine calcium when your calcium sensing receptor is sensing it. So now let's transition to talk about autosomal dominant hypocalcemia type 1 or ADH1. So ADH1 is a rare genetic hypoparathyroidism. The prevalence is about 1 in 70,000 people. And this is because of a change in the calcium sensing receptor, and that's causing it to be stuck in that activated state. So the body is really being tricked into thinking that the calcium is higher than it really is. So that's where this analogy of, the thermostat really comes in here. So imagining that it's freezing in your house, but the thermostat is sensing that it's 80 degrees and it just doesn't turn the heat on. And that's really what's going on in the parathyroid glands of these patients. So the blood calcium is low, but this activated calcium sensing receptor is reading that it's high, and therefore it's preventing PTH from being produced. And that's why patients stay in that hypocalcemic range. Similarly, things are happening in the kidney where these overactive calcium sensing receptors are sensing all this high calcium, even though it's not there, and they're excreting even more calcium in the urine. So patients have low blood calcium, but high urine calcium, and they're losing calcium in this method too. So in autosomal dominant hypocalcemia type 1, this calcium sensing receptor is signaling there's plenty of calcium, but patients have low blood calcium, low parathyroid hormone, high blood phosphate, and high urine calcium. And to summarize with this broken thermostat analogy, in ADH1, the set point is wrong and the receptor is too active, signaling that there's too much calcium when there's not enough, and thus PTH is not released. But what's important to remember for these patients is that these patients have developed normal parathyroid glands from birth, and the parathyroid glands are capable of making PTH. So it's not a problem with the gland can't make PTH. So there's no destruction of the parathyroid glands. They haven't been removed. They're there. They're just receiving the wrong signal. So finally, I'm going to go over some of the characteristics of patients with ADH1. And this sort of comes about from a recent study that we had done a few years ago. We noticed that there are a lot of gaps in knowledge about ADH1, and this is because it's a very rare disease. So there's many case reports and case series which talk about one patient here or two patients there or one family. But we felt there was a real need to tie all of this together to look at, a larger number of patients and see what was really going on with these patients. So we did a large literature search where we used all of these following terms of, ADH1, genetic hypoparathyroidism, et cetera. We searched for papers from 1996 to 2021. Then we collected data from each study. And with these search, we found about 70 papers. And we then went through each of these papers, pulled out as much patient data as we could, and collected that together to get a larger number of patients that we could look at all together. So we found that we had information about symptom onset in 183 patients. We had initial laboratory values in 90 patients. And we had information on the outcomes after treatment in about 58 patients. So first, let's talk about the inheritance of this. So we found that 78% of cases were inherited in a familial fashion. ADH1 is autosomal dominant. This means that it's autosomal means that it is on the normal chromosomes, not the sex chromosomes. So it doesn't have to do with X and Y and transmit differently if you're a man or a woman. It's just the regular chromosomes. And if you're dominant, means that if you have the gene, you are affected. And as you'll see when we go through, there's a really wide range of what symptoms look like in affected people. But the fact that you have one copy means that you have it, even if you have another normal copy from the other parent. And that was what autosomal dominant means. So each time a child is born, there's going to be a 50% chance that the child inherits this disease from their parent because of that autosomal dominant pattern. Then again, each time one of these children has another child, there's a 50% chance that that's going to get inherited. So 19% of the cases are found to be from de novo variants. And in these cases, the parents do not have ADH1. The siblings are not at risk for ADH1. The patient has acquired that change in their DNA just before or just after conception. So the patient is sort of the first person in this family to have this disorder. But then the patient then has a 50% chance of passing this down in the future because it will now follow that autosomal dominant pattern. And then for 3% of the cases, there was some type of unknown. They never found the genetics behind them. So how are patients diagnosed? Well, 70% of the patients were diagnosed because they had a symptom. Some type of low calcium symptom made them come to medical care. 24% of the patients were diagnosed because of family screening. And I will say it was striking to me as I did this study to see that, the inheritance, 78% of cases were actually familial, but only 24% were detected because of familial screening. And this could be for a couple reasons. One reason could be because, as I said, there's really variable what we call penetrance. So some people are severely affected. Some people barely know that they have this problem, and so it might have not been known as it was passed down. And the other reason is because the parents, one of the parent might have had idiopathic hypoparathyroidism, and thus, they didn't think the children were at risk, and no one thought to check the children or look at the children. So I think with this knowledge and with the increase in genetic testing over recent years, we can probably make this number better and sort of detect some of these children before they present with symptoms. And then 6% of the people had an incidental finding, which means they really went to the doctor for some kind of basic lab work and were found to have low calcium, even though they had absolutely no symptoms, and that was a surprise finding for them. The age of diagnosis varied widely. So the age of diagnosis of low calcium or hypocalcemia in general ranged from birth to age 66, with a median age of diagnosis of age 6. And that range for the actual diagnosis of ADH1 itself ranged even further, going all the way up to age 77, with a median age of diagnosis of age 25. So you can see many of these patients really weren't diagnosed until a little later in life. And then as far as the initial or presenting symptoms, 27% of the patients were initially asymptomatic, 33% of them had moderate symptoms, and 39% had severe symptoms, which would be seizure, laryngospasm, etc. And of note, the most frequent initial symptom was actually seizure in 38% of patients. And again, this is striking because seizures are very severe, and we really want to try to get these patients before they come to having a seizure, which could be life-threatening. And then the median age of diagnosis, as you would expect, was younger at 1.3 years in these more severe patients. But in these other less severe cases, it was 14 years. So you can see the severity changing really when they were diagnosed. Again, as you might expect, the more severe patients did have a lower mean blood calcium. You can see those more severe patients here in the dark blue. Their blood calcium was significantly lower than the asymptomatic in green or the moderately symptomatic light blue patients here. So urine calcium is an important feature that I do want to spend a little bit of time about. This graph shows in categories 1 and 2 patients with idiopathic hypoparathyroidism, and in columns 3 and 4, those are patients with activating variants in the calcium sensing receptor with ADH1. And you can see that this is before any treatment, that these idiopathic patients have low blood calcium and their urine calciums are pretty low. But because of that activation of the calcium sensing receptor in the kidney, these patients with ADH1 have a really high urine calcium despite the fact that they haven't been treated and their blood calcium levels are low. And you can see in this paper too that these patients are treated and as their blood calcium goes up, which is on, it's not going to show up, on this x-axis here, is their blood calcium going up with treatment. Their urine calcium is going up quite dramatically as they get treated. So why does this all matter? Well, we worry about complications in the kidney, as you've already heard about. So we found that complications in ADH1 patients increased as hypercalciuria increased. So this is the percent of treated patients who experienced complications. Before treatment, there were 34% of them having complications, but after treatment, 66% of patients were having complications. And these complications included kidney calcifications, which I just wanted to mention can come in 2 forms here. Kidney stones, which is called nephrolithiasis. And these are these stones that are located right in the tubes where the urine flows. And then nephrocalcinosis, which is actually calcification of the kidney tissue itself. And they would be the top 3 circles in that diagram of tissue calcification in the kidneys. So as far as complications, we define those as kidney stones, nephrolithiasis, kidney insufficiency, any type of brain calcification, although we don't think that these are quite clinically relevant, but we wanted to make sure we included them. And we found that in the patients who had normal urine calciums, there was 47% had complications. But in the patients that had high urine calciums, 88% of those patients had complications. So again, showing us that this urine calcium value really matters and is something that we have to monitor and to make sure that we follow and try to keep down to avoid complications in these patients. So sort of to summarize, in hypoparathyroid patients, urine calcium should be monitored, especially while on treatment and especially in patients with ADH1. High urine calcium can be associated with a greater chance of calcification, specifically kidney and brain calcifications. The majority of ADH1 patients have a variant in this gene inherited from a parent, and in most cases that is diagnosed because they present with symptoms. ADH1 patients have a wide spectrum of symptoms that range from asymptomatic to presenting with severe seizures. ADH1 can be diagnosed early in childhood or late in adulthood, and that's likely because of this large spectrum of symptoms. And the average calcium levels are lower in patients that have more initial severe symptoms. Treatment with calcium and calcitriol only cured symptoms in 69% of patients, which is data I really didn't have time to present today. Urine calcium tends to increase while on treatment, and these patients with the higher urine calcium levels generally had more complications than patients with a normal urine calcium. So importantly, this showed us that ADH1 patients could benefit from novel therapies, especially if those therapies don't increase urine calcium. And with that, I am going to move on to Dr. Gaffney, who's going to tell you a little bit about what we have been up to at the NIH for this.
Thanks, Dr. Roscoe, for a really great update. We wanted to give you a little bit more at the beginning because we know we're one of the earlier talks, but everybody here is going to hear more, and some things will be more personal for you. Just waiting for my slides to show up, sorry. But it's great to see everybody. It's been years since we've been together in person, seeing a lot of old friends, people who have been at the NIH, since I was a fellow back in the 90s, so it's really great to be together again. Okay, here are my disclosures. So I think everybody here knows conventional treatment of ADH, which Dr. Roscoe just discussed, calcium in multiple divided doses during the day, vitamin D with or without calcitriol. Some patients also need extra magnesium. But treatment is problematic because, as you heard, we still are targeting the blood calcium levels below the normal range, so patients often still have symptoms. And this increase in urine calcium can lead to these calcium deposits in the kidney. I won't go over this slide again. Dr. Roscoe just discussed it in detail, but the bottom line is when patients with ADH1 tend to have higher urine calcium even before treatment, and then when you take calcium and calcitriol, the urine calcium will go even higher. So we're constantly walking this treatment tightrope where we want to keep the blood calcium high enough so the patient's not having a lot of symptoms, but we also need to keep the urine calcium down to prevent those complications. So there are some additional strategies to reduce urine calcium, and I'm sure you're all familiar with this. Drink lots of water. We tell all of our patients to drink lots of water, so hopefully you all have water on your table. We're not inspecting, but reduce your salt intake. So we don't have the salty snacks out, it's candy from Halloween, but, and then some patients are treated with thiazide diuretics to reduce urine calcium. This is not that well studied in either hypoparathyroidism or ADH and can lead to other electrolyte problems. So if you're taking hydrochlorothiazide, you have to be mindful of several other things, especially the low salt intake. So what about using parathyroid hormone in patients with autosomal dominant hypocalcemia? We're all familiar that there's two flavors of parathyroid hormone that have been out there approved by the FDA, PTH 1 to 34, which is also called teriparatide and was approved for osteoporosis. And then there's TransCon PTH, which you're going to hear more about during this meeting, that's still under investigation, not FDA approved yet. And then the full-length PTH 1 to 84, this refers to the number of amino acids in the molecule. Parathyroid hormone is an 84 amino acid hormone, but the first 34 amino acids is really where the biological activity resides. So that's why you can use either the small fragment or the full-length fragment. And this PTH 1 to 84 is intact parathyroid hormone, which, as I'm sure many of you know, was approved by the FDA and patients were receiving it, but it was discontinued due to some formulation issues. So the thing about patients with autosomal dominant hypocalcemia is that PTH therapy has not really been well studied in this specific patient population. It's really only been studied in small groups of patients with ADH, and both through intermittent injections and continuous pump therapy. But in fact, patients with ADH were specifically excluded from most of the large studies that led to FDA approval of parathyroid hormone for the treatment of hypoparathyroidism. And while short-acting PTH injections can manage blood calcium, they don't completely normalize 24-hour urine patterns and can still have unintended effects on the kidney and the bone. And so, for example, this is the baseline kidney ultrasound on one of my patients with ADH1, an activating variant of the calcium sensing receptor, who was on a PTH study. So this is his kidney ultrasound before PTH therapy, and it's a little hard, I don't have a pointer to appreciate it. The white stuff in the middle is normal, and then the black area around it, it should be black. There's no nephrocalcinosis or calcium deposits, but you can see after 1 year of parathyroid hormone in this adult man with ADH1 that he did develop calcium deposits even though he was on PTH. Probably the longest known exposure to PTH in somebody with autosomal dominant hypocalcemia is this woman who at 20 years of age, she had been already treated 14 years continuously with PTH 1 to 34 injections twice a day. But despite this treatment, her urine calcium remained elevated. And while she had no calcium deposits when she was 6, she had extensive nephrocalcinosis by age 19. Her bone turnover was higher than normal during this treatment, and her spine and hip bone density became quite increased on treatment, while her forearm bone density became decreased. And so this is just a picture to show you that twice daily PTH injections can have these unintended effects on the skeleton. This is the head CT of this woman when she was 18, and her skull is quite thickened, and there are these patchy areas of increased and decreased bone, sort of these black areas where there's less bone, and then these very white areas where there's more bone. And just to give you a comparison, this is the head CT of an adult man with ADH1 who's not been treated with PTH. So clearly, this is not really a physiologic replacement the way it's been done with this PTH 1 to 34 twice daily, but maybe using longer acting PTH analogs will better replicate the typical 24-hour profile, and you won't have these effects on bone. But specifically in patients with ADH, PTH therapy won't affect this overactive receptor in the kidney. So better treatments for ADH are needed, and I like to show this timeline for parathyroids in general. Parathyroids were first identified in the late 1800s in Europe, and really these were the last anatomical structures to be found because they're so small. And back in the early 20s, up in Canada, the same group that was developing insulin, they gave parathyroid extract to a dog who'd had the parathyroids removed. PTH was then isolated in the 50s, and as you heard earlier, in the 1990s, we were using PTH 1 to 34 extensively in studies at the NIH. PTH 1 to 34 was approved for osteoporosis in 2002, and then 1 to 84 was approved for hypoparathyroidism in 2015, only to be recalled in 2019. But what about ADH? So the calcium sensing receptor was identified in 1992, and it was within a couple of years we were recognizing that variants in this receptor were the cause of ADH. And then in 2000, a class of drugs called calcilytics came on to the scene. So what is a calcilytic? These are a class of drugs that turn down the calcium sensing receptor, essentially resetting the thermostat. And they make the parathyroid cells and the kidney cells less sensitive to the blood calcium levels. And this results in an increase in PTH secretion and less calcium lost in the urine. And the drug was actually developed as a treatment for osteoporosis because you guys know hypoparathyroidism is a rare disease. So people want to develop drugs for common diseases because that's how companies make money, right? So anyway, this was developed and it was given to over 1,200 women with osteoporosis. And what they saw was that this class of drugs increased the blood calcium and the parathyroid hormone levels in these women, but it didn't help with the osteoporosis, so it was sort of abandoned as a treatment for a common disease. But the safety profile was very good. So what we looked into was the repurposing of these existing drugs for this specific disorder, ADH. So again, how would a calcilytic work in a patient who has ADH, who has this activating variant? So again, you saw this picture, this calcium sensing receptor is stuck in the active state, telling the parathyroids there's lots of calcium around, don't make PTH. And so when you add this calcilytic and you reset this receptor, now it detects that the blood calcium level is low and is able to start producing PTH appropriately. And then the blood calcium level responds by going up. And similarly, you have the same issue in the kidney where this activated receptor is telling the kidneys lots of calcium around, pee it all out into the urine. But when we apply this calcilytic, now we're resetting the signal so the receptors in the kidney can respond appropriately and decrease the amount of calcium in the urine. So there have been some animal models of ADH1, and these animals have been treated with calcilytics and saw an improvement in blood calcium and a decrease in urine calcium. And so we were very excited about the prospect of doing this. And back in 2014, we did a small study at the NIH in collaboration with a pharmaceutical company. And this was the first administration of a calcilytic to an individual with ADH1 in 2014. And this small study of giving the IV calcilytic to 5 individuals with ADH1 suggested that this class of medicine might work in people. So we were very excited. We wrote a new protocol. We were going to do higher doses for longer duration. But then, as happens in business, that pharmaceutical company was purchased by another pharmaceutical company who was no longer interested in pursuing this drug development. So basically, we at the NIH, especially Dr. Michael Collins, who many of you know, talked to anybody who would listen, who had a pharmaceutical company, and said, hey, we've got this great idea for a drug with this disease. Would you be interested? And finally, we developed a partnership with BridgeBio and subsequently Calcilytics Therapeutics to develop this oral calcilytic called encaleret. And that led to this phase 2 study, with which many of you are aware of because we've been presenting a lot of information lately. It's a phase 2b open label study divided into 4 periods. The first 2 periods were brief inpatient stays where the doses were adjusted and escalated, where we were trying to figure out the best dose. And then a 24-week outpatient period in period 3. And this recently was just, the results up through period 3 was just published in the New England Journal of Medicine in September, which is really exciting to see our hypoparathyroidism research in such a prominent journal. And then a long-term extension phase with data out to 12 months and even longer. And our main goals were to see, is this drug going to be safe? And then to figure out the best dose that will increase and stabilize PTH levels, increase and stabilize blood calcium levels, decrease urine calcium, decrease and stabilize blood phosphorus, and increase and stabilize blood magnesium without taking any oral supplements. So the goal was, can we use this drug, no magnesium, no calcium, no calcitriol? These are the baseline characteristics of our patients. We had 13 patients with a mean age of 39. 62% were women, and their labs were consistent with what you might expect. They had low calcium and low PTH. They had highish phosphate and lowish magnesium. They had inappropriately elevated urine calcium, and about 3/4 had kidney calcifications on ultrasound. And their kidney function varied from mild to moderate, renal function decreased to normal. And they were all on calcium and calcitriol supplements in divided doses throughout the day, and there were 9 different calcium sensing receptor variants in this population. And then September 28th, 2020, we gave the first dose of this oral calcilytic to an individual with ADH1, and you can see members of our team there. And this patient, who's in her 20s, I've been taking care of her since she was 5 years old, so this was pretty exciting for all of us. So I'm going to just show you a few graphs with the results of this data. They're all structured pretty much the same. The first 4 points on the left are from that period 3 24-week period, and then on the right you see 12 additional months of treatment. So this is going to be treatment over 18 months. You can see in the top graph that the parathyroid hormone, which was very low at baseline, pretty much immediately went into the normal range and stayed in the normal range over this 18-month period. So as Dr. Roscoe said, people with ADH1 have normally developed parathyroid glands. They're just getting the wrong signal. And more importantly, the blood calcium level shown here, which was very low at baseline, almost immediately went into the normal range and was maintained over 18 months. And this corresponded to a decrease from an elevated urine calcium also into the normal range that was maintained over 18 months. And there was no progression of renal calcifications on ultrasound seen at the end of that 24-week period or again a year later. Blood phosphate is shown at the top, and that decreased and stayed in the mid-normal range, and blood magnesium in the bottom increased and stayed in the mid-normal range. And what was really interesting about these 13 people was that their dose requirements were really, really different. So what you're seeing here is a line for each patient of what their dose requirements were over that 18-month period. And the dose was given twice a day. So the total milligram dose that you see on the side is the total dose for day, which we divided into 2. But the requirements were really different. So one patient required 5 milligrams twice a day, and another required 180 or 190 milligrams twice a day. But once we got them to the dose that worked for them to keep that calcium in the normal range, they really didn't change much. And again, we were not targeting the calcium to the low normal. We were targeting calcium to, just the regular normal range. Bone turnover is still an open question. Remember, patients with hypoparathyroidism of all types have low bone turnover because PTH is what's needed to turn bone around to make it be kind of broken down and built back up again. So it's not unexpected that bone turnover markers would increase when the parathyroid hormone level goes high. In most cases, these stayed within the normal range, but there were a few patients who really bounced around and were above the normal range, and we're continuing to monitor that. But importantly, when we looked at bone density by DEXA scan, we really didn't see significant short-term effects on bone density at screening compared to period 3, and then even a year later. Encaleret was very well tolerated with no serious adverse events reported. So what I'm saying here, no serious adverse events. No patients during this entire study have had to go to the hospital for an IV calcium infusion. Nobody's had to be admitted to the hospital overnight because they had a gastrointestinal illness and they couldn't keep their medications down. Nobody. And this was during COVID. We did this whole thing during COVID. Patients had COVID. Nobody had to go to the hospital. It was amazing, really. The only little treatment related adverse events was some transient drops in blood phosphorus or transient increases in blood calcium while we were adjusting the dose. But again, nothing severe, and they were all asymptomatic events. So what's next? You're going to hear a little bit more about some other studies that Dr. Hartley's doing, but Many of you are probably aware that there's now this multi-center international phase 3 study underway. It's called the Calibrate study. At the bottom, it lists a lot of the sites where this will be taking place. There's a lot of sites in the United States. You're going to hear more about this tomorrow from Dr. Mary Scott Roberts at Calcilytics. Now, I'm a pediatric endocrinologist, so of course, I really want to see trials in children and pregnant women. And just to sort of end on that, this is one of my patients who's enrolled in the Encaleret study. You can see how low her calcium level was in period 2, where we were adjusting the dose, but once she got into period 3, her calcium levels have pretty much stayed within the normal range. In contrast, I also take care of her son, who's on calcium and calcitriol. And he really bounces around a lot. And even just this past week, he had a gastrointestinal illness, vomiting, unable to keep his meds down, having to go to the ER, getting IV calcium. And I'm still waiting for my nurse to text me his labs from today because I'm still adjusting his medications now a week later. So to conclude, I think you know about the calcium sensing receptor and the issues with conventional treatment, and that PTH wasn't well studied in ADH1, but that these calcilytics may become an effective oral therapy for patients with ADH1, and ongoing studies in adults and future studies in children are necessary. And really, this is some of our group, but the most important people in this are you guys, the people who participate in these clinical trials that help not only you, but future generations, particularly in the genetic conditions. So I just want to thank everybody very much. And I'm going to throw it now to Dr. Hartley, who's going to talk a little bit more.
Thank you all for coming and inviting me here. I'm just going to wait for my slides to show up. Okay. Oh, how do I go back? Okay. Hi, so I'm Iris Hartley. I'm a endocrinologist, adult endocrinologist at the NIH, and I'm going to introduce to you a study that we are currently recruiting for and working on, where we're going to explore the use of calcilytics as a potential treatment for post-surgical hypoparathyroidism. Dr. Gaffney just talked about using calcilytics in ADH1, but we're going to explore whether this could work in other forms of hypoparathyroidism. Here are my disclosures. Okay, so I first want to introduce a kind of visual analogy to the way calcium works in the body. And I think that it's very hard to understand calcium balance, and I'm a very visual person, so I just want to share this analogy to you guys as a way of thinking about how calcium is balanced in the body. So I call this my bucket analogy. So there's a bucket full of water. There are faucets at the top pouring the water in, and there are holes at the bottom. It's a leaky bucket, so there's holes at the bottom allowing the water to come out. So in the analogy, the calcium that's coming, the water is calcium, and it comes into the body through only one way, through your diet and absorption by your gut. That's the only way you can get calcium into your body. It only leaves in one way as well, and that's through leaky kidneys and leaving through your urine. So there's only one way in and one way out, and the level of the water in this bucket is your blood calcium level, okay? So if you increased your dietary calcium, your blood calcium might increase, and if you were able to increase urinary excretion, your blood calcium might decrease. Okay. So this example, this first bucket, I'm going to show you a bunch of different ones, is representative of a person with functional parathyroid. So they have good gut absorption because they have high levels of calcitriol made by production by PTH, supports calcitriol production, so they're absorbing all the calcium they need, so there's good intake, and they have a normal level of urinary calcium excretion, and their blood calcium is normal, so it's right up to the top. Okay. That's in contrast to the situation in hypoparathyroidism. So in hypoparathyroidism, your calcitriol is low, You can't raise it because your PTH is low. And so you can't really absorb, even if you're eating a normal amount of calcium, you can't absorb all of that calcium in your diet. So the calcium in is low. The other thing that happens in hypoparathyroidism, the parathyroids are really important at the kidneys to hold on to calcium. And so the kidneys are more leaky than they would be in somebody with functional parathyroid. So you can see there's 3 holes there instead of 2 holes in somebody who has functional, your kidneys are a little bit more leaky, so they lose more urinary calcium. So both of those things combined result in what we see in hypoparathyroidism, a very low blood calcium level. So as many of you, I'm sure all of you are aware, experiencing low blood calcium can be very unpleasant. People are very symptomatic. There's numbness, tingling, and when very severe, there's a risk of tetany and seizures. So there are 2 different methods that you could use to increase this blood calcium, or increase the water in the bucket. The first thing you could do is just pour as much water as you can into that bucket to fill it, right? If you just, dumped as much water as you could into that bucket, you could get the level to raise no matter what, if there's a leak in it, right? That's one way you could raise it. The other way is by repairing the bucket and making it not leaky, right? Those are the 2 potential ways of raising blood calcium. So the first way is what we do with what we call conventional therapy with calcium and calcitriol. So we increase calcium intake and we increase calcitriol, and calcitriol is important for the absorption of calcium. And both of those things result in a really high level of absorption of calcium, and you're basically dumping calcium into the system, which is great because people feel better, their blood calcium goes up, and I think that's one positive. But the negative is you can see that the leaky kidneys are dumping all of that calcium into your urine. And we know that the side effects of that are kidney stones, nephrocalcinosis, and kidney injury. So this is obviously not an ideal situation either. And so that's why we have that very careful balance that Dr. Gaffney mentioned in all patients with hypoparathyroidism, where we're trying to maintain a blood calcium level that's just high enough that patients aren't having unacceptable symptoms, but low enough that their urinary calcium is not so high that their kidneys are at risk. So that's what we currently are doing. But we want to consider, what if we target something else? We don't just dump calcium into the system, we target the leaky kidneys themselves. And so what would that look like? So if you plug these leaky kidneys and make it so that they're not losing calcium into their urine, what happens? So 2 things happens. One is that you have decreased the amount of calcium that can be excreted, and so the urine calcium goes down. And the other thing that happens is, you have the same intake of calcium coming in, and so the level of the blood calcium potentially could increase. So Dr. Gaffney presented these with a prettier slide, but there are current strategies to target urinary calcium and reduce urinary calcium losses. And the main 2 right now are to decrease salt. So salt takes calcium with it when you pee it out. So if you have a low salt diet, that will decrease urinary sodium and also decrease urinary calcium. So that's one strategy. Thiazide diuretics, though not well studied in hypoparathyroidism, can be effective in some patients with mild hypercalciuria to decrease the amount of urinary calcium. It works, it's more effective in conjunction with a low salt diet, but it does cause low potassium in some patients, and particularly if you have a baseline low blood pressure, it does decrease blood pressure, so that can be problematic. You can also decrease your risk of having calcifications by increasing fluid and water, although the amount of calcium in your urine is still the same, but the risks are much less because you've diluted that calcium. So in my study, we are wanting to think about this new strategy, targeting the calcium sensing receptor in the kidney. As Dr. Gaffney mentioned and Dr. Roscoe mentioned, the calcium sensing receptors are found in both the parathyroids and the kidney. And calcilytics work by turning down this calcium sensing receptor. And they really make the parathyroids in the kidneys try to target a higher calcium level. And so if you give a calcilytic, the parathyroids in the kidneys want to increase their calcium, and it does it the way they know how. So parathyroids increase PTH, and the kidneys hold on to all the calcium and prevent it from being lost. So it's kind of like a plug in the leaky kidneys. In clinical trials, calcilytics have been used in postmenopausal women. They increase the blood calcium, increase PTH, and decrease urinary calcium. And Dr. Gaffney just presented in autosomal dominant hypocalcemia, where they have overactive calcium sensing receptors. This basically reverses their problem and does the same thing. It increases blood calcium, increases PTH, and decreases urinary calcium. But up to this point, it's only been given, or all calcilytics have only been given to patients with intact parathyroid glands. So the question still stands, would it work in people who don't have parathyroid glands with post-surgical hypoparathyroidism or other diseases where their parathyroid glands are not functional? So I think this is particularly relevant because post-surgical hypoparathyroidism is the most common cause of hypoparathyroidism. 3 out of every 4 patients who have hypoparathyroidism have it due to a previous surgery. And post-surgical hypoparathyroidism is a rare consequence of neck surgery. You can see these parathyroid glands are right on the back of the thyroid. Some of them are actually embedded in the thyroid. So you can imagine if you're removing like the thyroid, it can be potentially difficult to not damage these tiny organs. So what do we need to consider when thinking if calcilytics would work without parathyroid glands in the neck? Because we mentioned in ADH1, they have parathyroid glands. They're just not working properly. In post-surgical hypoparathyroidism, patients have little to no parathyroid tissue. So we don't think that if you stimulate parathyroid tissue that's not there, it probably will not produce extra PTH, right? Because the parathyroid tissue is just not there. So I think PTH is unlikely to increase in people with post-surgical hypoparathyroidism. Obviously, if somebody has a little bit of tissue, it's possible that it could increase, and we're really interested in knowing the answer to that. But I think that that is probably not going to be the main effect of calcilytics in these patients. We believe that the main action will probably be on the calcium sensing receptors that are found in the kidney. And giving calcilytics to people with post-surgical hypoparathyroidism will be kind of like plugging the leak of the kidney to decrease urinary calcium losses. In animal models of animals who had parathyroidectomies, calcilytics have been shown to increase blood calcium and decrease the urinary calcium. So that brings me to the study that is currently ongoing at the NIH, where we're going to look at the use of encaleret, which is the calcilytic used in those ADH1 patients that were just presented, in people with post-surgical hypoparathyroidism. Sorry, can you click the next slide? I don't know what happened, sorry. So this is the study design. It's a very small proof of principle design. We just want to make sure that this works before we do something that involves dose finding and long-term treatment. This involves up to 15 adults with post-surgical hypoparathyroidism. We're enrolling up to 10 people who had surgery greater than 1 year ago and up to 5 with surgery less than 1 year ago. And the reason I'm including those patients who more recently developed hypoparathyroidism is because, one, I think that is the most symptomatic year often for patients. I think that is a really important time that we should try to offer therapy to patients. And the other reason is, there's an open question. If somebody has a slightly injured parathyroid, would stimulating it help increase their ability to produce PTH? Participants have to be in generally good health and not be on either PTH or another investigational drug, just because we want this to be a very clean study where we really truly find whether this drug works. And the study is located at the NIH Clinical Center, not far from here in Bethesda, Maryland, and travel and lodging costs will all be paid. So this is the design of the study. It starts with a screening visit. This is an outpatient visit at the NIH just to assess eligibility. Patients will have to stay at an overnight near the NIH, and that's really just to do a 24-hour urine. Otherwise, it's just a one-day visit with blood work, kidney ultrasound, and EKG. That will be followed either directly after or whenever is convenient by an admission visit. It's a Saturday to Saturday overnight stay at the NIH Clinical Center, and participants will be given oral encaleret twice a day for 5 days. After they're done with after those 5 days, we'll stop encaleret before they go home, and during the admission, they'll get frequent blood and urinary sampling, 24-hour urines, and EKGs. Once they leave the NIH, we have one lab follow-up just to make sure that going back to their regular therapy, that there were no changes or any concerns. And we'll be calling several times afterwards to make sure everybody feels okay. So what potential risks does encaleret have, given what we know and our experience with it in other patients? So there's the possibility, if we start encaleret, that patients may develop a high blood calcium. And that, in some ways, is a desired outcome because we are hoping to show that encaleret will increase blood calcium. It's also possible that patients will have a low calcium if encaleret doesn't work, right? Because we might be giving them encaleret and it just doesn't work. And there's this very unlikely possibility because low phosphate was something that occurred transiently and asymptomatically in the ADH1 patients. That is also a possible risk, although I think it's very unlikely because the cause of that low phosphate was due to very high PTH levels, which I don't expect in this population. And there were no other specific safety signals in both the osteoporosis or ADH1 studies. And to make sure that this is done safely, this is why during this study we're having patients be inpatient, where they can get immediate either extra calcium, we can stop the drug, we can give them fluids, and we're frequently monitoring and making adjustments to the calcium or calcitriol when needed. Our primary objective is to try to determine if encaleret can increase blood calcium while decreasing urinary calcium in post-surgical hypoparathyroid patients. We would also like to determine how many patients we can get to achieve both a normal blood and normal urinary calcium together. And we also have a lot of exploratory objectives to try to see if this study can teach us more about how the body uses calcium, what the role of the calcium sensing receptor is in adjusting calcium levels. There's possibility that it could cause an increase in PTH, an increase in calcitriol production even without PTH, that it could affect bone turnover, and have an impact on other mineral-related measures. So again, this is my bucket theory, and our hope is that encaleret will be like that final bucket where encaleret will prevent the leakiness of kidneys and increase calcium while decreasing blood calcium while decreasing urinary calcium. So as a summary, the treatment of hypoparathyroidism with calcium and calcitriol can require a trade-off between blood and urinary calcium. Calcilytics, by decreasing urinary calcium loss, may allow for higher blood calcium levels without raising the urinary calcium. And they also have the potential to provide an exciting new oral therapy for people with post-surgical hypoparathyroidism. And we're currently recruiting, so thank you so much. And I'm going to pass the baton to Dr. Lionakis, who's going to talk about his work at in APESED.
Well, thank you very much to the organizers and especially Rachel for including me in this program. So I'm an infectious disease trained physician and I'm an immunologist. So I've learned a lot of endocrinology through the last decade with this disease, but this is a disease that is an autoimmune disease. That means our own body attacks its own, and that includes the parathyroid. There are a couple of important differences compared to the diseases we just heard. As opposed to ADH1, there is no parathyroid gland in these patients that can be boosted in order to produce more. And as opposed to the surgical hypoparathyroidism, the cause of the disease here is immune cells that are otherwise built in our bodies to fight infections. In this particular case, don't distinguish between our own self and outside invaders, and as a result, the disease actually is caused by our own body attacking it. And in this particular case, as opposed to what we just heard earlier, this is a syndrome. So it causes parathyroid decrease in about 75% of the patients, but patients who suffer from APS1 or otherwise called APSED can suffer from over 30 different disease manifestations that include both endocrine tissues and non-endocrine tissues. So I'll give you a short version of a journey that started about 10 years ago that has led us now to understand the disease and offer an immune-based therapy in this particular set of disease that calms down that inflammation that is otherwise attacking these patients' own body to offer treatment for them. Now, we heard earlier about autosomal dominant disease. This is a recessive syndrome. It means you have to have two different mutations, typically inherited from both of your parents who are otherwise asymptomatic, or as we heard from Kelly earlier, you can also have de novo development of some of these mutations. What's very interesting about this syndrome is it causes a lot of autoimmunity in many parts of the body, and also it causes a mucosal fungal infection, which was really the reason why I initially got very interested in it as an immunologist and an infectious disease expert. And this is a disease that has a very characteristic classic called triad of manifestations, which includes this fungal infection called candidiasis, parathyroid deficiency in about 75–80% of the patients, and adrenal insufficiency. So quite characteristic. This is called a classic triad. Having two out of these three clinically is used to make a diagnosis. Now, in very, very simple terms, we all make cells in our bone marrow that are called lymphocytes. They then go to the thymus in order to get educated to respond to bacterial, fungal, viral challenges, and that's why we all get protected from infections. But at the same time, those T cells, they need to learn that any cell in our body should not be subject to attack like a virus or a bacterium. And that gene that's defective in these patients called AIR is exactly what it does in all of us. It makes our immune system recognize those what we call self-reactive T cells that inadvertently develop in all of us in order to not get out of the thymus, go in the parathyroid or in the adrenal or in any other gland, infiltrate and cause tissue injury. So these patients don't have this proof-free mechanism, if you will, and as a result of that, they develop lymphocytic infiltration in many organs, including the parathyroid, that causes tissue destruction and the symptoms that they develop. Now, this is the NIH Clinical Center, where when about 10 years ago, I decided to start studying this disease, we took an approach that we felt at the time and paid off 10 years down the line of understanding every aspect of this disease. So as opposed to me only focusing, let's say, on the fungal susceptibility and not learn anything else about the disease, we assembled a team of physicians and scientists that spans 10 different NIH institutes, so that when the patients come, they get evaluated as a whole and not only on what their primary or secondary complaint at that given time might be. This is the team from my group through the years that have worked clinically or at the bench, and what I'm showing you today is going to be their work. What this means is that patients typically come at NIH for an entire week, where they undergo a very systematic clinical evaluation that includes the same physicians through the last decade. They all undergo whole genome sequencing, and they have a very uniform clinical, laboratory, and imaging workup that is tailored to the common and uncommon components of this syndrome, including parathyroid. And then when we do procedures for them, we try to understand clinically how to help them, but also made use of those to understand at the research level how this disease might manifest it, which has led to the insights that I'm going to share you in the next 10 minutes. So we've seen now close to 200 patients. We heard earlier ADH1 being in about 70,000 patients. It's probably individuals in this country. It's probably around the same for APS1, so still a rare disease, but probably a few thousands of these individuals in the United States. And what was very apparent as we were going through this very systematic approach is you can see on the very left side, hypoparathyroidism being at the top, candida and enamel hypoplasia, but you can also see these bars that marked in black that highlight diseases that these patients suffer in high frequencies that they were poorly understood or poorly recognized in the past. from enteritis. This is very important because about 80% of the patients cannot actually absorb even calcium and calcitriol when they develop hypoparathyroidism, hepatitis, stomach, lung, skin, and salivary gland inflammation. The classic triad is depicted on the left. We developed what we now call an adjunct triad on the basis of our workup that we feel that if it's combined with a classic triad can actually lead to earlier diagnosis. And we've actually seen that now in more than one data sets. This is the first data set where when we combine these adjunct triads with the classic triad, patients can be diagnosed 4 or 5 years earlier. So about half of the time that it would usually take until they reach an endocrinologist. Endocrinologists are quite savvy to realize that this is APS1. Non-endocrinologists, not so much. So what that literally has led into about half of the patients potentially could have been diagnosed before presenting with life-threatening endocrinopathies, including hypocalcemic seizures we heard earlier. This has implications from both non-endocrinological colleagues being able to recognize this disease early, and it has major implications for management from calcium monitoring to ACTH stimulation testing to what I'll show you in a minute. If we can treat the disease, already established disease, can we actually intervene early to prevent the development of the disease? Now, I'm going to end on how we now can treat effectively in an immunological manner of this disease by summarizing here a paper we published 2 years ago that actually gave us a window of looking into this particular interferon axis that I'll elaborate in a minute, through actually the lens of why these patients develop mucosal Candida infections, the fungal disease that is very characteristic in them. And that work was based on the premise that, as I mentioned earlier, these T cells that we all eliminate when they react to our own, in these patients, they go out, they identify areas in endocrine glands, in non-endocrine glands, and they cause disease. It turns out that one of the major features of what these lymphocytes make is an interferon called interferon gamma. Interferon gamma is an important molecule in our immune system that when it's produced in normal amounts, it protects all of us from viral and bacterial infections. In this particular disease, there is an excess production of interferon gamma, which actually is the reason why these mice in this particular slide and patients develop mucosal fungal disease. That opened the window of looking at whether that excess interferon gamma that is produced by air knockout deficient cells is true for also other organs. And here is data showing interferon gamma excess production in T cells from mouse pancreas, salivary glands, and lungs. We've now looked at 8 different tissues, including endocrine tissues, ovaries, and parathyroid and thyroid disease glands. And for a simple depiction of how this important molecule acts, interferon gamma binds on its receptor. There are 2 molecules called JAK1, JAK2, just immediately after that. They're actually the target of FDA-approved drugs that are called JAK inhibitors. Downstream of that, you see a molecule called STAT1 that gets phosphorylated when you have activation of this signaling. And then molecules downstream of that are acting to protect against viral infections in the normal state, but in this particular case, when you have excess interferon gamma, autoimmunity can ensue. So what this shows on the right, it's a busy slide, shows that all of that interferon gamma axis gets fully activated in multiple tissues in mice that suffer from this syndrome. So can we use the JAK1, JAK2 inhibitors that are right there in the center underneath interferon gamma to change the history of this disease initially in mice? The answer is yes. On the right, you see a Kaplan-Meier graph of survival of mice that will not be treated, or they all succumb to the autoimmunity, and you look at ruxolitinib-treated mice, all survive. That is because they don't get autoimmunity anymore. So you see all of these purple collections of immune cells that are the lymphocytes that infiltrate in organs of mice that don't have air. And on the right side of the lungs and the salivary glands, you see no lymphocytic infiltration. That applies to all tissues, and that's because these lymphocytes that are marked here in brown are not present anymore. So an elimination of these lymphocytes that cause the autoimmune tissue destruction. Now, mice are mice, humans are far more important. So we head to humans, and when we looked in the serum of patients, this is about 110 patients now with APOSET, interferon gamma excess is actually the most highly upregulated signature in the blood of these patients. We've now gone to develop methods in the lab to evaluate this pathway, not in mice, but in humans. All of the brown that you see on the left panels is stomach, on the right is lung for interferon gamma, for STAT1 and CXCL9. All of this brown doesn't belong in healthy tissues. It's abundant in patient tissues that have autoimmunity. We've now looked at 12 different tissues that correspond to autoimmune manifestations in these patients. So as in mice, APS1 patients also feature excess interferon gamma. So 5 years ago, we started treating these patients, initially off-label, now, as I'll show you in a minute, in a phase 2 IRB-approved protocol. This is patient 1 who had alopecia restoration. Her Sjogren's syndrome resolved. This woman had so severe enteritis that would require 15 laxatives a week to have a bowel movement, had rectal prolapse because of that, and required surgical intervention twice, went to have normal bowel movements, and had full restoration of her autoimmune manifestations. Patient 2, highlights from him, had a lot of Candida episodes, 3, as you see here, per year, complete elimination of those while he was on ruxolitinib. In his case, he had severe gastritis. When a gastroenterologist goes and does an endoscopy, on the left side, you see the outline of the red blood vessels. This is because the stomach mucosa is so thin from the inflammation that you can see the outline of the vessels. On the right side, you see the normal pink-looking epithelium because of the inflammation being gone. Related to endocrine signals that we've seen, actually one of the patients who was not always very compliant with his thyroid replacement, and as a result of that, he would have elevations in TSH before having ruxolitinib when he wouldn't be compliant. Ended up actually self-stopping levothyroxine, and for the 3 years now that he's been on ruxolitinib, his TSH is normal. And the most recent patient actually we've treated had no menses for several years, has normal menstrual periods now with a hormone called antimalarian hormone that is produced by ovaries, was absent and now increasing every time that we measure it. And last but not least, these patients have severe enteritis. I mentioned earlier about the constipation, but many of them have 12, 15 bowel movements a day. That complicates their hypoparathyroidism treatment. Many times they have to go to the hospital. As Rachel mentioned earlier, for a GI illness, these patients actually, many times it's the norm for them that every month or every 2 months they will go because they just cannot absorb. So that leads to very erratic calcium or calcitriol or PTH dosing. So when they get into ruxolitinib treatment, you can see here, besides the alopecia restoration, this boy had the restoration of his bowel movements, doubling his weight, normal levels of calcium, calcitriol in his particular case. So what we've seen now in the first 10 patients that we've treated is a remission in 14 autoimmune manifestations, from Candida to alopecia to nail dystrophy, gastritis, enteritis, pneumonitis, hepatitis, arthritis, salivary gland inflammation, thyroiditis, urticaria, pernicious anemia, exocrine pancreatic insufficiency, and primary ovarian failure, which is very encouraging and promising to us. It has really changed the life of these individuals. That has led us to now have a formal IRB-approved phase 2 clinical trial that has enrolled already 5 patients with a total target of 17. And while we have now, I think, shown, at least in these first patients, that all of them respond when they have already established disease, the important next question that comes directly to hypoparathyroidism here, because hypoparathyroidism, when it develops in these patients, you wouldn't expect it to resolve. The same thing with adrenal insufficiency. You see the intact PTH levels or cortisol levels be completely undetectable. But can we prevent the disease? That's an important question that we don't have an answer yet, but we are actually starting to try to answer this. So this is a boy we just saw at NIH 2 weeks ago from Philadelphia, a 2-year-old boy with air deficiency, has had this APOSET rash, has Candida and hepatitis developing way before any endocrinopathy. And while his intact PTH has been now monitoring, monitored and was normal up to maybe 3 months ago in the 30s, the last 3 months has been in the 8 to 12 range repeatedly, indicating that in the next few months, this boy is probably going to develop autoimmune hypoparathyroidism. Now, if we would wait for that to develop and then come later and try to treat it, it's likely this is going to be not reversible, but we might have a window of opportunity while this is still operational as a parathyroid gland to reverse it. So we are going to start preemptive ruxolitinib in this patient. There's another patient we have who has glucose intolerance, so doesn't yet have diabetes, but in the next few months is going to develop autoimmune diabetes, who we are doing the same, in hopes of understanding whether we can treat disease when it's well established, but also take care of disease before it develops, especially for some of these endocrinopathies that you wouldn't expect to be reversed at that time. With that, I'd like to thank you, and I'll be happy to take any questions along with everybody else.
So if you have any questions, if you just want to raise your hand, we'll run around and give you a mic. Okay, here we go.
Hi, Dr. Gaffney, you had spoken about the Enclair range of dosing being highly variable. I was curious if there's a correlation between severity of symptoms and dosing needed.
That's a really great question. So we did not see any correlation between the dose requirement and the symptoms, or even the dose of calcium and calcitriol that they were requiring before they went into the study. We couldn't really see any relationship. What was definitely suggestive was, I told you it was 13 different patients with 9 different calcium sensing receptor variants. And so the patients who had the same calcium sensing receptor variant needed around the same dose. So it may be more related to the genetics. What we don't know for sure, though, is all of the patients where we had more than one person with the same variant, they were related. So a father and a daughter, or a cousin and cousins, or sisters. So there could have been another genetic reason why they needed similar doses, but we highly suspect it's related to the actual variant that is determining what kind of dose. And so with this larger phase 3 international study, we're hoping to enroll unrelated people who have the same variant, and that will help answer that question, as well as some laboratory studies in cells that might give us more information about that.
Thank you. Who else has questions?
This question is for Dr. Leonagis. I'm a physician. So my question is, do you see a correlation in these JAK overexpression in other urticarial or mastocytosis diseases, or like histiocytosis diseases? Because we have a whole lot of them in the endocrine space, right? Where you have people with one autoimmune disease, and then they have all these other sort of urticarial complaints. That's kind of part one of my question. The second part is, do you think these likely represent variants of the AIR mutation?
Great questions. So I do not know the answer to the first question because we haven't studied those patients. As you might know, JAK inhibitors recently got FDA labels for atopic dermatitis. So in one of the patients who had autoimmune urticaria, we also saw complete remission. So in disease where there is an autoimmune urticaria, whether it's come from air deficiency or from other etiologies, there might be a role for those. I would say for other autoimmune endocrinopathies, APS2, APS3 perhaps, there might be common pathways that could be applicable, but unless we do the studies, I think it will be difficult to be for sure. I think the key message here, if I can say, is that these are diseases, APS1 for sure, and I suspect others, that there might be ways to actually act in a personalized manner and a treatment mechanism approach, and not only replace what is missing, which is an important element as well, but I think there's a window here where some of those diseases might be treated with something that addresses the problem as a whole, and hopefully early on. Now, I don't know if those patients would likely not have AIR biallelic variants, because then they would be expected to have this. But now there are patients who have been reported to have monoallelic AR variants, so being heterozygous for certain variants that cause a little bit more abnormality than what you would expect of 50% for a heterozygous, without getting into too technical details, dominant negative mutations. And some of them have been reported now to just cause one disease, like vitiligo or pernicious anemia, or urticaria. So I think if there is a cohort of those, it would be useful to see whether they may carry variants in AR or other genes that might influence the phenotypic expression.
There was a question up front.
Hi, my name's John. Just curious, post-surgical hypoparathyroidism, it doesn't necessarily manifest itself till some time after surgery. And so it seems to me you could have damaged parathyroids. There's something left where they stop entirely. Is there a way of discerning what the status of the parathyroid is, whether it's, because it's some people it's severe, others it's not severe?
Yeah, that's a. Hello? Yeah, that's an interesting question. I think what we do know is that, what we can monitor is people's PTH levels and calcium levels. And some people with post-surgical hypoparathyroidism may have extremely low PTH, and there may be some improvement. And other people, have maybe a little, like just insufficiency, right? Like their PTH can go up to 20, but it can't go any higher. And so I think it really depends, but we can't really, see in the tissue, like what can, come back. It's hard to predict what can come back. I think the general teaching is after 1 year, probably it won't, that's when we consider it permanent, that it won't come back. But I've had patients who have, over time, the PTH started to go up a little bit over years or decades, So I think it's really hard to predict. It's hard to study in a really small, rare disease. But it's definitely something that I think is interesting. And, we'll see whether these glands that do remain can still be stimulated to produce even more PTH or not.
Yes, I have a couple questions from online guests. One is, if a patient has an auto transplant of the remaining parathyroid tissue, is it possible that encaleret may motivate the tissue to begin working or work more effectively?
I think it's possible. It's hard to know. I think it depends. So there's two possibilities. Again, we don't have the data for the study, so I can't really talk to whether it would work. But when I thought about what to consider, there's two possibilities. One is that the parathyroid glands that are there right now are working as hard as they possibly can, right? Otherwise, they would get your calcium up, right? But they're working as hard as they possibly can at this moment, and they can't work any harder. And even if we make them think that your calcium level is 4, they can't make any more, right? So that's one possibility. The other possibility is that, if they're really stimulated, that they could produce a little bit more. I think it's probably less likely for them to be able to be stimulated to make even more, but I think it's still an open question.
And the next question online is, does calcilytics suppress existing remnant parathyroid tissue function like parathyroid analogs do?
Oh, yeah, so no. So calcilytics actually do not suppress parathyroid function. So they actually stimulate parathyroids to produce PTH.
Okay, and I have one more online right now. They would love to discuss the APS realm with Dr. Leonikis more specifically, as they don't fit into any of the APS boxes. Is it possible to get contact info?
Yes, of course.
And one more just popped up, and then we'll see if we have any more from the audience. if someone could, up there could just speak to as how do they sign up for the encaleret study, either both the post-surgical, or is there still an opportunity to sign up for the ADH1 study?
Yes, so I think the Hypoparathyroidism Association may have links to those studies on their website. The other way to look up any clinical trial is clinicaltrials.gov. If you go to that website and you just search either the name of the drug or the disease, you can find any of the studies, any studies that are recruiting, you know, in the entire United States. So it can, that's a really good way to find out if any studies are related to you.
Hi, I'm a patient, a post-surgical patient with hypopara, and I was actually just wondering if there's a link that's been associated or if it's being studied, perhaps between, regardless of how you acquire or if you're born with hypopara, if there is a link between malabsorption and the condition.
So hypoparathyroidism is associated with a decrease in calcitriol, and calcitriol is really important in increasing the absorption of calcium. So there's definitely, you know, a link in that way. So if you have hypoparathyroidism, you're not going to be able to absorb calcium as well unless you're given calcitriol.
But I would add, you know, most people who have neck surgery or thyroid surgery, I mean, it's usually either thyroid cancer or it's autoimmune thyroid disease. So Hashimoto's hypothyroidism or Graves' disease, and they're both autoimmune diseases. So it's not uncommon for patients with post-surgical hypoparathyroidism that had a primary autoimmune thyroid problem to have another autoimmune disease. So I've seen patients with Graves' disease who then have celiac disease and they have difficulty absorbing vitamin D or other issues. Or I've had patients that have had, B12 deficiency or something else. So certainly the thyroid, the autoimmune thyroid disease can cluster with other autoimmune diseases that can affect malabsorption.
Hi, I'm Lynn Kohlmeyer. Thank you so much. That was fantastic. I'm so happy to be here and meet everybody. I have a question about our partial hypopara patients that may not meet criteria for the trials for PTH. It seems like this would be perfect if you think it would work to use a calciolytic in somebody with, you know, let's say their PTH is 25 when their calcium's 8 and they're still having symptoms and on calcium and active D, but we need to help.
Yeah, I mean, I think if the urinary calcium can be, the hypercalciuria of the high urine calcium can be ameliorated with a calcilytic in somebody with another form of hypoparathyroidism, maybe that means that it would be okay to run their blood calcium level at a higher, more really in the normal range, so they're not symptomatic either with parathyroid hormone injection therapy or calcium or calcitriol, because as I'm sure many of you know, that even when you're on these treatments, you still tend to have to run the calcium low, and you still have to tolerate some symptoms. So if there were a way to use a calcilytic as adjunct therapy, even if you can't get the blood calcium perfect with a calcilytic, maybe you could still get it. You could run it higher because you wouldn't have the renal effects.
I have another question from online real quick. They want to know the slide that was about the skull that was in, you know, the bone was enlarged. Does that only apply to patients who have ADH1, or is this something also that post-surgical patients could experience?
I don't think we know the answer to that because I don't believe that, you know, head imaging was done systematically in any of the PTH treatment trials. But we do know that intermittent injections of PTH 1 to 34 or 1 to 84 do have this sort of mixed effect on the skeleton, where in some parts of the skeleton the bone density will increase and in other parts the bone density will decrease. And we see these high bone turnover markers. So we're not sure how clinically relevant that is because it doesn't seem to be causing more fractures or or anything clinically relevant. These are just things that we're seeing on the bone density studies. We don't know that the change in the skull is clinically significant. We just know that it's not, we're not seeing a physiologic change in the skeleton with these short-acting PTH analogs. And that's why we'll talk a lot, you're going to hear a lot about long-acting PTH analogs, and certainly being able to get things more physiologic, the way your parathyroids would work normally, is going to be better for the skeleton in the long term.
All right. Well, thank you so much to the NIH team. We're so excited that you guys have been here, answered all the questions, and the continued work that you guys do every day. We really do appreciate it. Thank you so much. Let's give it up for NIH. All right, and then we're going to take a 15-minute break, so we'll be back in the room at about 11:45. Welcome back, everybody. Welcome back online. We're happy to have you guys here again. That break went by super quick, I know. So our next presenter is a pediatric endocrinologist and bone health specialist in the Division of Pediatric Endocrinology and Diabetes at the Children's Hospital of Philadelphia, and assistant professor of pediatrics at Perelman School of Medicine, University of Pennsylvania. So we're really excited. This is the first year he's presented for us, so please welcome Dr. David Weber.
Yeah, thank you, Patty. Thank you so much for the opportunity to be here. So let me tell you a bit about our practice and what we do. So as mentioned, I'm a pediatric endocrinologist. We have a large Center for Bone Health for Children in our institution, and that's really a multidisciplinary center. We care for kids with all the different types of osteoporosis, but also all the metabolic bone diseases and calcium abnormalities. So we see many kids with hypoparathyroidism through that program. And I think as we're hearing today, and we've had some great introductions to my talk from the NIH group and Dr. Schobach, I think we're starting to become a bit more interested in bone and hypopara simply because these medicines that we're going to be having are going to be potentially impacting the skeleton in different ways, and there's going to be a lot more to learn. And so we're going to talk about that today. So my talk is really skeletal development and how calcium affects bones in children. So really I consider myself something of a sort of a bone imaging methodologist, and so we spend a lot of time understanding how the skeleton develops in typically developing children, and then the effects of disease and other issues on bone. So that's what I'm going to focus on, and really just try to highlight along the way how that intersects with hypoparathyroidism. A couple of disclosures here. I've done some consulting for two companies that are not in the hypoparathyroidism space, but are in the bone space. So goals of my talk then are going to be really understand the basics. What is a skeleton made of, and how does it develop during childhood? I'd like you all to become familiar with the genetic and modifiable factors that influence skeletal development. And then together we're going to discuss the effects of hypoparathyroidism on the developing skeleton. So I'm going to first just go through skeletal development during childhood in the typical situation. I think it's always helpful to understand and think about what is the skeleton for. I think for many years we thought it was just this inert stuff that helped hold up our body, and now we know that that's not the case. Certainly it is important for strength and helps support us, helps support our physical function, protects our internal organs. As we've heard already, it is the primary mineral reservoir, right? So this is where most of our calcium and our phosphorus and our magnesium is stored in the body. It's also very important for protecting the bone marrow. You may know this is where the red blood cells and the white blood cells are made. It turns out the bone actually regulates that, and there's a lot of crosstalk, and so it's important to have healthy bones for healthy red and white blood cell function. And then finally, what's really interesting is over the past decade or 2 decades, we've learned the skeleton is actually an endocrine organ. So it secretes hormones that are involved in bone mineral and energy metabolism. You may have heard of hormones like FGF23, which helps regulate phosphorus, and osteocalcin, which may help regulate glucose. All right, so what is the bone made of? So we talk about the bone being composed of a matrix component, and this is the organic component, and that is formed by collagen, and collagen is just a protein, a special type of protein that really forms the scaffolding and helps shape those bones. And it provides the structure to the skeleton and also helps with flexibility. And then that matrix is mineralized, and this is what you probably all think about as bone. This is our calcium and our phosphorus, which makes the bones hard. We call this hydroxyapatite. This is the product of calcium and phosphorus that actually fills in between those collagen fibers and adds the strength. And it, as I mentioned, makes the bones hard, makes them dense, helps keep the skeleton resistant to fracture. Both the matrix, the organic matrix and the mineral component do contribute to bone strength. And then on top of that, we have the cellular component. So the bone is a very active organ, and so it's all the different cells in the skeleton that help the bone grow, maintain health, involved in communication between muscles and bones, and help regulate hormone secretion. I'm going to highlight a couple of these here. The osteoclast, we heard a little bit about. We'll talk more about it. This is the cell that resorbs bone and is able to liberate calcium from the bone. and then the osteoblast. This is the cell that helps form bone. We talked a little bit, you heard a little bit about the different effects of PTH on bone resorption and bone building, and we'll talk more about that. The last cell to highlight here is, at the bottom here is the osteocyte, and this is really the major communicator cell in the body. All right, so before we can talk about bone accrual, I think it's really important to understand just typical childhood growth. I imagine if any of you have had kids, you've been to the pediatrician, they plot your kids on the growth chart, and that's what I'm showing here. So the top one is the height curve, and the bottom one is the weight curve. And as endocrinologists, when we look at this, one of these things these curves do is allow us to understand how a child is growing respective to sort of the typical healthy population of children. And so each one of those lines is a percentile. The line in the middle would represent average for the population of children, and then up and down from there. When we think about patterns of growth, we have a very steady growth during early childhood. You can see that line is pretty flat there. And then during puberty, we see a big inflection up, and so growth really increases during that pubertal growth spurt. And then final height is obtained in the teenage years, a little bit early in girls, typically the early to mid-teenage years, and later in boys. And so it turns out that bone mineral accrual, or bone development, actually mimics that curve pretty closely. And so this is a curve from Jakowski and colleagues looking at just studying how the body adds bone mineral over time. And so this is bone mineral content. That's that calcium and that phosphorus. This is measured by something called a DEXA scan we'll talk a bit more about later. And what you can see is that curve actually looks pretty similar to that growth curve that I showed you, right? So we have a steady acquisition of bone mineral during early childhood. And then again, you notice that very steep incline in bone accrual during puberty. In fact, 1/3 of all of the bone mineral content that you're going to ever put on as a human is going to happen in the year before and after that peak growth spurt. So it's really a critical time for bone health and bone accrual. So right there in middle adolescence. And then this concept of peak bone mass is very important. So just like we stop growing as adolescents, we hit a peak bone mass. And so once you get up into your late teens, early 20s, that's as much bone density as you're ever going to have. And so that's really important to optimize that opportunity during childhood to get the highest peak bone mass you can, because that's going to help protect against fractures later on. I'm just going to show you some cartoons here that sort of illustrate a bit more about how bones grow. These are slides that come from the American Society for Bone Mineral Research. They have a wonderful online curriculum, and so Susan Ott made it, and I have modified them. When we talk about growth during childhood, the bones grow. We call that bone modeling, and they grow at the growth plates. And so in this schematic here, you can see that new green bone sort of growing longer at the ends of the bone. And then importantly, they also grow wider. So you can see the bones get thicker, and the growing longer helps with height, of course, but growing wider helps with strength. And then we also have to maintain a healthy bone shape, because that also contributes to bone strength. And this is actually done through those cells called the osteoclast. We call this endosteal resorption. And then the final step is that new bone has to be mineralized. Again, so this is where the availability of the calcium and the phosphorus, those two minerals, is important to sort of finalizing that bone strength. Now, on top of all this, we talk about all of the external factors that can affect how bones grow and how they develop. We'll talk about these in more detail, but thinking about the effect of muscle mass and muscle strength, thinking about our nutritional status, any hormone deficiencies or hormone excesses that might affect bone growth, any exposure to bone toxic therapies. There's some medicines, some radiation things that can affect bone development. And then finally, activity and loading. So how much exercise are we doing? How active are we? How much stimulation are we putting on the skeleton? So you're going to hear yet another look at calcium flows through the body. And so I apologize for all the physiology today. We're going to think about it in this talk in terms of how calcium gets to the bone. But as you've already heard, calcium flows through different body systems. I'm going to start here again with the gut. We heard from the NIH speakers earlier, sort of talking about the gut as the entry point for calcium, right? So this is the food that comes from our diet, and it can be absorbed. There's actually some small amount of calcium that gets excreted into the stool too, so it is a way that the body does get rid of excess calcium as well. And then the bones, we talked about during childhood, we really want to be putting calcium into the bones, right? We're trying to grow those bones and fill them up, so that's the bone formation piece. But in the typical state, that calcium is all there, and if the body needs it, it will take it out of the bones to maintain normal blood calcium levels. And then finally, the kidney, that's the hole in the bucket, right? So this is the last chance the body has to either get rid of extra calcium or to hold on to calcium. And so we call that filtration and reabsorption. And so again, in the typical state, with someone whose parathyroid glands work the way they should, the body is really going to do a great job at maintaining a normal calcium level, and it's going to do that primarily by taking calcium out of the bones. So let's go through these different cell types just a little bit more. We were introduced to these earlier today. So thinking about the gut, so how does calcium absorption in the gut work? There's two processes. One is actually passive, so this is just simply from the food that we eat. The gut is able to passively absorb some of the calcium in our food. This calcium absorption can reach up to 50% of the calcium that you're taking in. That depends on some other things, depends on what your diet is, depends on how much phosphorus you're eating. You may know that phosphorus binds up calcium, and so if you eat a lot of phosphorus, it can affect how well your body can absorb the calcium. And then it turns out maybe some microbiome differences, so different people absorb calcium differently, kind of based on all the little healthy bacteria that live in the gut. The other form of calcium absorption in the gut is this active part, and so this is the vitamin D mediated. Vitamin D is not a vitamin, it's a hormone, and it helps with that calcium absorption, interacts with a bunch of different cell types there. And this is the thing that really requires PTH, right? So in the typical state, the body is able to make PTH, which converts vitamin D into the active form. For those with hypoparathyroidism or with kids with hypoparathyroid, we replace that by giving calcitriol. And then finally, the kidney, by far, in my mind, as an endocrinologist, the most complicated part of calcium regulation. Big picture, excess calcium leaves the body through the urine, but the kidneys can reabsorb calcium sort of along the whole path in the kidneys there as needed to maintain calcium. We heard about this in the form of the calcium sensing receptor, and so this is very exciting as we hear about some of these medicines that may help target this. And then also PTH, our old friend. So PTH interacts with that PTH receptor at the end of the kidneys and sort of offers one last chance to kind of reabsorb some calcium and prevent too much calcium from leaving the body. So what does all this mean for the bone? All right, so in the bone, we have an enzyme called alkaline phosphatase. Here it's abbreviated ALPL. You may have seen it in ALP on your labs. Alkaline phosphatase is the enzyme that makes bone mineralization possible. So what it does is it breaks apart this other molecule here called PPI, pyrophosphate. Pyrophosphate is very important. This is the thing that's in the blood that keeps calcium and phosphorus from coming together and making mineral in your arteries, which of course would not be good. So it keeps calcium and phosphorus apart. But alkaline phosphatase breaks that and allows for the calcium and the phosphorus to come together to mineralize the bone. We see that again with our friend hydroxyapatite there. So calcium and phosphorus come together, and then they form these crystals in that collagen to make bone hard. All right, so let's talk a bit more about the impact of PTH. So we started to talk about this earlier today. So PTH has both anabolic, bone building, and resorptive, bone breakdown effects. That's why it's a really complicated molecule. And we start talking about how these different medicines work. You're going to hear a lot of talk about what the effects on bone density and bone turnover are. Lost something there. So on the top here, all these little red lines are talking about the bone building effects of PTH. And so in short little blast, what it does is PTH stimulates those osteoblasts, those bone building cells, to make bone. Down in the bottom here, all the black lines represent the effect on bone resorption. So long-term exposure to high levels of PTH cause bone loss. And so this is a bit of what Dr. Gaffney was starting to speak about. So some of these medicines like teriparatide we use to treat osteoporosis, that short-term bone building. And as we've moved into using some of these medicines to treat hypoparathyroidism, the question is there a chance that we can overdo it, both on the one hand leading to bone density that's too high if it's given shortly, or if we're on these medicines for long periods of time, are we going to cause too much bone resorption and lead to osteoporosis? And so we're going to hear more about that, I'm sure, today as we hear about these other talks. Oh, one thing just to highlight, the sustained low PTH levels that we see in hypopara result in this low bone turnover, and we'll talk about how the bone density does appear to be normal or even above average, but it's not clear if that bone is healthy or not. So some degree of bone turnover is necessary, and so it's possible that not having enough PTH around could weaken the bone in sort of harder to understand ways. I mentioned the concept of peak bone mass, and that's highlighted here on this graph. And so what this graph is showing is it's taking our bone accrual during childhood and extending it along the entire age range there into adulthood. Just the take-home point here is that lower peak bone mass or lower peak bone means a greater risk of fracture at any time during your life. Bone mass is stable during early and mid-adulthood. But then what happens in women after menopause is you see a sort of rapid loss of bone. Same thing does happen in men, but it happens at an older age and it's slower. And the key from my standpoint as a pediatrician, a pediatric endocrinologist, is that that greater peak bone mass during childhood is going to not only help protect bones when they're kids, but also help protect their bones when they're older. So we're really going to strive to do all we can to optimize that bone accrual and get the highest peak bone mass we can. And then the other side of that then, is there any of these suboptimal lifestyle factors like poor nutrition, limited exercise, exposure to medications? These can lower that bone mass and increase the risk of broken bones both as kids and later on as adults. So let's talk a bit more about what the determinants or the things that determine how much bone mass you're going to get. And so about 80% of these are fixed. And so you're born with, thousands of genes, and a number of these contribute to your bone density. And then sex, of course, so men tend to have higher bone density than women. And then there's the potentially modifiable things. So these are all the things that we can potentially change. And so we'll go through these one by one, but thinking about nutrition, thinking about our weight-bearing exercise, and then thinking about, the diseases that come up and the medicines used to treat them, as well as the hormonal imbalances that can develop. So let's briefly talk about genetics. And for most people, there is no single osteoporosis gene. There are some exceptions to this. So there are, of course, some people who are born with single gene type forms of bone weakness. The one you may have heard of is called osteogenesis imperfecta, or brittle bone disease. And so these people have a mutation in one gene that does make their bones very weak. But for most of us, we have a lot of different genes in the body contributing to how dense and how strong the bones are. Some studies coming out of CHOP have found that that's my center, have found at least 40 different parts of the genome that contribute to bone strength and bone accrual. And this is a graph from one of their papers. It's basically, these red bars are showing just how much of the bone accrual at a given body site is due to genetic factors, due to other factors. And the higher the bars here, the more that is due to genetics. What I think is really interesting about this is it differs by body site. And so you can see that some parts of the body, like the skull, are primarily determined by genetics. But other parts, like the spine and then the femur, this is the radius, the forearm, are much more influenced by things like diet and activity and other factors. Right now, there's no genetic test to predict bone density, so it's not like we can run a test and look at these 40 different locations and tell you how strong your bones are going to be, but that's something that maybe we will have in the future, and so this may become more of a part of our counseling as we learn more. Nutrition, think about the micronutrients like our vitamins, our minerals, pre and probiotics, and then think about our macronutrients, so carbohydrates, fats, protein. They're both important to bone accrual. In our center, every child who comes to see us does meet with a dietitian who has expertise in bone health. And really what we're doing is we're using the dietary reference intakes provided by the US government, the National Academies of Science, to sort of provide us with the baseline. These are specific to age and sex and activity level. And we're going to recommend trying to maintain sufficient intake of our calcium, our phosphorus, our vitamin D. Of course, people with hypoparathyroidism, this is a little bit different and often need more calcium and perhaps less phosphorus. One thing that we may not think about for bone health, but it's really important to maintain adequate protein intake. So as I mentioned, there's all these organic components, these fibers in the skeleton, and we need to support that by getting adequate protein, especially if we're active. And then it's also important to maintain a healthy weight. So we know that both overweight and underweight status can stress the bones. And so especially during childhood, we're really focusing on maintaining activity, but making sure the kids are eating enough calories to support that activity as well. And then the importance of weight-bearing exercise. So just a schematic here that illustrating that the muscles and the bones are closely connected. We talk about this scientifically as something called the muscle-bone unit. And the idea is that there's actually close connection between the muscle strength and pushing and pulling and bone development. And the idea here is that the bones are going to become bigger and wider and stronger as they're pushed and pulled on by the muscles. And so what happens then is in the normal state, kids are doing typical activity, they're walking, they're running, they're playing sports, all that sort of stuff. They get a normal bone development, kind of seen here in the middle. Now, of course, we have some kids who have some issues with mobility, so maybe they have a condition that doesn't allow them to walk so well or not walk at all, and they actually don't gain as much bone. And as you become an adult, it turns out that if you don't have enough activity, you can actually lose some bone. So we call that disuse. On the other end of that spectrum would be our excessive bone building, and so these would be our athletes, or our competitive athletes here. So it turns out people like runners and things like that who are very active and do a lot of weight bearing can actually increase their bone density and make it higher than typical. For children, we just have a goal again set forth by this is the U.S. Preventive Health Task Force, and the goal for exercise in children is 60 minutes a day of moderate physical activity, with a note that 3 times a week that should be weight-bearing activities. So for instance, swimming is a great activity for health and for burning calories, but there's no weight-bearing. So really thinking about running, jumping, jogging, things like that. Now let's talk about the impact of chronic disease. So you might imagine this can affect bone health in several ways. I did kind of mention this, introduce this earlier. When I think about this, we think about fracture there in the center. This is the thing we're trying to prevent, and there's 2 things that contribute to that. One is that deficient bone accrual, or the low bone mass, and the other is anything that affects bone strength, and that's bone quality. And when we walk through this, again, I'm thinking about how much mobility and activity is there. We're doing screens for any nutritional deficiencies. We're looking to see if there's any bone toxic therapies like steroids or seizure medications or hormonal contraceptions. We're looking for signs of any hormone deficiency like growth hormone or pubertal changes, diabetes, and then we're thinking about any chronic inflammation. We heard a little bit about that, in terms of the APSID, for instance. Now, people with hypoparathyroidism, generally post-surgical hypoparathyroidism doesn't really come along with a lot of these other factors, so otherwise generally healthy. But where we do see it in kids and certainly adults as well would be some of these other conditions. So if you do have, or your kid does have APS, many of these other conditions can affect the bone. And then probably where we see it most commonly is in people with DiGeorge, and so this is that complex syndrome where hypoparathyroidism is a part of it, but then they often have cardiac disease and other things that end up weakening the bone. So the medicines that we think about, so the steroids, prednisone, hydrocortisone, things like that, can be toxic to bone. They can affect hormones. Think about diuretics, so furosemide and bumetanide. These are loop diuretics, different than hydrochlorothiazide, which was mentioned earlier. These actually cause urinary calcium loss and other electrolyte issues. Some of the seizure medications can affect vitamin D and are toxic to bone cells. And then some of the contraception, so people who take Depo-Provera, for instance, this is a progesterone-only contraception, that can cause some bone loss as well. And again, if you need these medicines to treat your disease, that's fine, but it's just something as a bone health clinician we're looking at and seeing if they can be modified or take some steps to alleviate some of the harms that may come from them. All right, so for the last few minutes then, we're going to talk about how this applies to children with hypoparathyroidism. So you're starting to learn today, if you didn't know already, that the overall impact of hypoparathyroidism on bone health is complicated. You might think, oh, calcium is important for bones. We know that. So you might think that low calcium levels would mean low bone density. And of course, that's very logical. That makes sense. But as we've started to hear today, that actually isn't the case. And so if we go back to our graph of what PTH does to the bones there, it does seem that the low calcium levels in the blood, any negative impact that might have on bone mineralization is more than counteracted by this lack of PTH. And so again, in that low PTH state, what's happening is those osteoclasts just aren't as active and they're not pulling that calcium out of the bone. And so we really just don't see low bone density in most patients, most children, most adults with hypoparathyroidism. So typically, I don't think of hypoparathyroidism as a form of childhood skeletal fragility. It's very rare, so we rarely see post-surgical hypoparathyroidism in childhood, so we're mostly talking about the different genetic syndromes. There is some data out there in adults. Dr. Khan may speak about this in her talk later. I know she has presented some new data about bone density and fractures in adults at the ASBMR meeting last month. But my impression is that the data is kind of conflicting here. Generally speaking, the bone density does appear to be above average, although I think it gets trickier in some of the postmenopausal women where you can have both hypoparathyroidism and osteoporosis, and that's a difficult situation to deal with. There's been some studies that suggest the fracture risk is maybe a little bit increased in adults. Others have not shown that. We heard from Dr. Schobach this morning that in the review articles that were published, the overall feeling was that there was a neutral effect on fracture, so perhaps no different than the typical population. I think, again, the notable exceptions are people who have hypoparathyroidism in the setting of other syndromes. And so, again, the 22q kids are the patients we see by far the most of. We often get consults with them when they're in the hospital, they're in the cardiac unit, they've had heart surgery. Some of these patients do have fractures because of all of the medicines and all of the illness that's going on. So how do we assess bone density? I think it's important to talk about this. You're going to hear about bone density probably more throughout the next 2 days. So we use a DEXA machine. Perhaps many of you have had a DEXA, or some of you have had a DEXA. This measures that bone mineral content, that calcium and that phosphorus in the bones. And we use that to determine something called bone mineral density. It's a measure of how strong the bones are. I will tell you that we don't routinely do this clinically in children. So if your child comes to see me in clinic, I'm probably not going to get a bone density test. But for many of the studies that are going on, people will get this. And it's really used to research, in research studies, to understand the impact of medicines on bone health. So I'm going to just show you some of what we know, which is not much. So because we don't typically get these DEXA scans as a part of routine clinical care, we don't have a lot of information in children, but it has been included in some of these studies. So we'll go back to one of Karen Weiner's studies from 2010. This is one of the early studies looking at using teriparatide to treat children with hypoparathyroidism. And these are DEXA results. So we report DEXAs in children and young adults as a Z-score. And what this is doing is, again, comparing your bone density to what is expected for this population of the same age and same sex. And we think of anything between a -2 and a +2 of being within the normal range. So 95% of the population will have a bone density between -2 and +2. And I've put a blue box around that normal range there. And she reported bone density at the radius or the forearm and the whole body. The line in the middle is 0, so again, that would be average for the population. And so what she found in her studies is at baseline, the bone density at the radius was well within the normal range, pretty close to average, and in fact, a little higher than average at the whole body. And so the reason that they wanted to include bone density is what we had talked about, just wondering if you give PTH or teriparatide to a child, does that have a negative impact on bone density? Is there bone loss? They And these early studies did see a little bit of a decrease in bone density over time, but that sort of stabilized as things went on. And I think we're going to hear in more of the other studies that have been done in adults, we really haven't seen negative impacts of these medicines on bone density, but is something important to follow. And so what about some of these other conditions? So we heard about autosomal dominant hypoparathyroidism type 1, ADH type 1. This is the condition due to that gain of function mutation in the calcium sensing receptor. Again, of course, we have decreased PTH secretion. And so again, very small study, apologize, this is all that's out there, but so this is 6 subjects, children and adults, and what they did was compare the bone density in people with ADH1 to people who had post-surgical hypoparathyroidism. So again, we're looking at Z-scores here. So this is the spine, this is the femoral neck, which is part of the hip. This is the total hip, and this is the forearm. Again, 0 here is our average for the population. And so what you'll see, the take-home message is that both the post-surgical and the autosomal dominant, or the calcium sensing receptor, their bone density on average is above average. So again, more signs here that people with this type of hypoparathyroidism have bone density that is average or a little bit above average. And then finally looking at 22q, I mentioned, so this is by far the most common cause of hypoparathyroidism we see. Many of these children have other risk factors for bone health, including the heart disease, the decreased mobility, nutritional hardships, and the autoimmune and the inflammatory disease. Again, not well studied. I did find one case series of 8 children that showed that the bone density was actually a bit below average, but still remained in the normal range. No fractures reported. The majority did have some vitamin D deficiency and some inadequate physical activity. Oh, sorry, one more, last one. The APS, the autoimmune polyglandular syndrome. As we heard, this is the condition where hypoparathyroidism often comes along with other risk factors like adrenal insufficiency and low hormone levels and malabsorption. And as you might expect, what they found is that the sicker the people were, the lower the bone density. So this is a different way of measuring bone mineral density via a machine called a peripheral quantitative CT. And they compared bone density to controls, and then they split the people with APS into 2 groups, one who had less than 6 complications and one who had more than 7. And what they found, it was only that group who had the large number of complications that actually had lower bone density compared to the healthy controls, which makes sense. Just again, sign that the sicker you are, the lower the bone density is going to be, the higher risk of fracture. All right, so I'm going to summarize here. So childhood bone accrual and subsequent peak bone mass are determined by both genetic and modifiable factors. There's some general principles to optimize bone accrual during childhood, and these are applicable to both typically developing children and those with hypoparathyroidism. We want to make sure we are attaining our adequate micro and macronutrient intake. Certainly having an input of a dietitian is always helpful in this regard. Being careful to avoid under or overweight status, as those can certainly adversely affect bone accrual during childhood, and engaging in regular weight-bearing activity, that goal of 60 minutes per day. The impact of hypoparathyroidism on bone health is not clear. So bone density does appear to be a typical or a bit higher than typical on average. Although one thing we wonder is whether this low bone turnover state might weaken the bones separately from bone density. And it probably does vary by the cause of hypoparathyroidism. So it's not, I think, safe to assume that post-surgical hypoparathyroid bone is the same as someone with a calcium sensing receptor they've had their entire life. And we're going to be learning, I think, much more about this as we get in to these other new medicines. And I think that we're going to have to think carefully as clinicians about how we're going to assess bone density, how we're going to assess bone health, and how to collect these outcomes in our clinical trials, especially as they move from adults into childhood. And I think that brings me to the end.
Okay, thank you so much. And we're going to take, thank you. Michelle, we have one question online we're going to take, and then when we break for lunch, we can have some questions with him.
Okay, the question online was, do you see in children who were born with this disease or diagnosed at a very early age that as they go through their growth and puberty that they tend to have shorter stature because of the bone?
Yeah, it's a good question. So that, we don't see it, I wouldn't say that short stature is common amongst all of hypoparathyroidism, so I can't make that generalization. Some of these conditions absolutely do. So people with 22q and some of the other genetic syndromes often have short stature. Many of these patients actually have deficiencies in growth hormone or other hormones that affect growth. And so I think that is the importance of seeing an endocrinologist, because it does take some time to kind of sort through those issues. But hypoparathyroidism itself specifically should not affect growth.
Okay, thank you very much. All right, again, thank you, Dr. Weber, for a wonderful presentation today. And if you have any questions, you can certainly, in the room, you can ask him during lunch. We are going to break for lunch until 12:55. Out there, if you turned in a specialty order to me, you can see Karen outside. She will make sure that you have your specialty order. But the lunches are out in the lobby, and we'll take till 12:55. You can eat wherever you want, then come back in here. Thank you. All right, welcome back, everybody. Hope you enjoyed that yummy lunch that we had. Is everybody with me in the room? Thank you. All right. So our next presenter wanted to go out there and make sure that you were in here for her presentation. She's full of a ton of energy, so we're really excited to have her here. She is from Spokane, Washington, and she is also the chairman of our board of medical advisors. So please welcome Dr. Lynn Kohlmeyer.
Thank you, guys. You have a good lunch? Well, I have the easiest and the hardest topic, and that's calcium and calcium safety. Hardest to take and so important. So here are my disclosures. I'm honored to be part of the HypoPARA trials, and after this, Dr. Warren is going to tell us about trials, and you can find out where trials are available. I'd love to know where people came from. I came from the West Coast, and I know a few of my patients and colleagues are here. Anybody else from the West? Great. How about Midwest? Super. East? Of course. Okay. So that was kind of to get you warmed up because we don't have poll questions, but I do have some. I probably have too many questions, so I'll try to keep it simple. But I'd love to hear your experience as I go through calcium safety, because to me, that's what it's all about. So you know symptoms of low calcium, and it starts with just a little bit of tingling or cramping or numbness. It can be all the time. It can be now and then. It can be only when you're stressed. For women when they have their period, for all of us when you try to be more active, but tetany is where that cramping is just unacceptable and frightening. The laryngospasm or a tetany, tightness in your throat, can cause a cough or difficulty speaking or breathing. And you've already heard about the big fear of when calcium either drops too quickly or really drops below 7.5, where you can have seizures, not just all the neurologic symptoms that you can experience every day. And then the mental health and the decreased memory and fogginess, and brain fog was defined and described by you guys years before it ever was with COVID, but difficulty concentrating. And then that leads to, can you get up and give a talk? Can you do the things you want to do when this might hit you? And so then that causes an anxiety and depression and a fear and a lack of confidence. And I've learned all of this through you. We didn't learn this in medical school. We didn't learn this in endocrine fellowship. So that reduces quality of life. And this is really huge. I mean, I think we all in medicine went into this field because we want to improve our patients, our community's quality of life, and our own. And that's why we're here, whatever that takes. So we're not going to answer these questions yet because I'm going to split them up, but how do you report your symptoms? And Elena, after my presentation, she's going to help us know how to track that more, but I'm going to give you some ideas. Do you write them down? Do you give them a score or a rating? Do you share your symptoms and how you rate them with your providers or your family members or your friends? The big question, do they? Why don't they correlate with your calcium levels by the time you get your calcium level back? And how do you treat them? That's one of the main messages of my presentation. Not that I have solutions, but I'm asking you, how do you treat them? How can you help each other not only treat them, but prevent them? And then what about a high calcium? Sometimes there's no symptoms, which is why we worry about kidney safety. But it can be headache, nausea, GI symptoms, thirst, increased urination, fast heart rate, irregular heart rate, and then still the confusion, the memory, difficulty concentrating, leading to all of these reduced quality of life. We don't want calcium up and down. We want it right where it should be, and in your blood and in your bones where it should be, not in your kidney and elsewhere. So the last few years, I've shared some patient stories, but this was just a few days ago, and I just wanted to start off with, this is a quote from one of my patients. She's post-surgical after 30 years, and I heard some people saying after 10 to 15 years, it's still challenging. She says it's still hard to treat and to communicate and to explain it to others. Before she knew what was going on, she knew when she ate ice cream it was better, and she said this became a little bit of a problem, but I love ice cream too. She was treated with fatigue, for fibromyalgia, depression, anxiety, and just recently with celiac, just 5 years ago. Her symptoms affected and still affect her job performance. She has tingling of her fingers and toes almost all the time, and she knows it gets worse when it gets into her palms. Her arches of her feet start cramping, and it moves up her abdomen. She always has a positive Schwastex reflex, and it affects what she can do. She has brain fog and decreased memory. She gets tired. She thinks she just doesn't have energy to do things, and she doesn't get excited about things like she wants to. And this, I think, is really important. She tries to explain this to her providers, to her family and friends, but she feels like she's been poisoned, that her bones hurt, and that no amount of rest helps her feel better. I think that your teaching us as providers this is so important. So Danette, who's here, a few years ago, and I kind of came up with a non-validated scoring system to kind of add to the HPS, the HypoPARA experienced score that has been validated and looks at different sites. But I'm going to present this to you as an idea. So if you have a baseline score of 0 to 2, where you really feel good, you can do things you want, maybe take an extra calcium, but it's not slowing you down. That's our goal for everybody. 3 to 4 might be what most of you experience the most, but it's in a specific site, not more than one, maybe lips, toes, not extensive, and you take an extra calcium and it treats it, it goes away. Monitor severe is getting worse, and I have specific sites starred. I'm going to show you the HPES scoring system, and you can look it up as well. It's been published, but it's in more than one group, but it doesn't improve within an hour, often lasts more than an hour, and you have to take more calcium. Usually people don't take active D as needed. That's something that you kind of talk to your provider about, whether you need a higher or lower dose. And then it gets worse. A 7 to 8 would be symptoms that are severe for 10 to 15 minutes. They finally resolve, can take time, but it doesn't involve the severe tetany, shortness of breath, laryngospasm, or seizure, thankfully. But 9 to 10 would be a crisis. So you call it a crash. Everyone kind of feels differently about how they describe it, but it's for over 30 minutes. You need IV hydration. You go to the ER or urgent care. And then 10 plus, hopefully, very few of you experience. I'm going to ask you that where you actually do have a seizure or tetany and you're in the ICU. So my first question, just a raise of hands, we'll go pretty quickly, is have you ever received IV calcium in the ER urgent care for a crisis? Just raise your hand. That's too many of you. And if yes, has it occurred more than once in your life? Yeah. Thank you for sharing that. Okay, so now we're going to go to still severe, 7 to 8, 9 to 10. How many of you have had 9 to 10 or 7 to 8 symptoms? And has that occurred more than 10 times in your life? Everybody's hands going up. And do these symptoms, if you've had them, reduce your ability to be active and do the things you want to do? Yes. Okay, so now we're going down to 5 or 6. If you've had 5 or 6 rated symptoms as I'm describing it, does it happen more than once a month? Okay, there's still a lot of hands. And how about 3 to 4? That's what I think most people experience. We'll say once a month, once a week. Hands are still up. Every day? Less, okay. All righty, so this is where we want everyone to be. There's hope. That was one of our messages last year, and it's our message every day. So if you're on conventional therapy, which I'm going to re-review, even though you know it well, multiple calcium supplements, calcitriol, which I'm going to call active D, because calcitriol sounds like calcium to people that don't know HypoPARA like you do. Have you had long periods of minimal or no symptoms? I'm not expecting a lot of hands. Couple, okay. Maybe you have partial hypopara? Because that was one of my questions, which is a good thing that you've had less severe symptoms. If you're now on parathyroid hormone replacement or have been, were you able to bring your symptoms down to 0 to 2? Anybody? More hands. That is good news. And was this maintained when you tried to do more, when you were more active? Remember last year I talked about exercise in hypopara. It was maintained. Good. And if now on conventional therapy, do you take extra calcium before you exercise? Or if you're under stress for any reason, do you prophylactically treat yourself? Yes, and that's one of the things that I think is my message. I'm not giving you an exact prescription because you know best, but I think that's important. Of course, we don't want to overdo that either because we don't want to push all this calcium into your kidney if you're on conventional treatment. So this is just a 2020 abstract that kind of goes through the HPES, but look at these kind of descriptions of the scores, where they are, the site. And I'm going to kind of combine this with this SOS score system if you want to use it or if you think it would help. But what's important is this looked at physical functioning, all the aspects of daily life, well-being, and then relationships. And I think that was really important to have those 4 different separated out aspects of your experience. So this is an example of taking this severity of symptom 0 to 10, maybe SOS score, with the HPS. So at baseline, this is a patient with hypoparathyroidism. She has muscle cramping, muscle twitching, and tingling without numbness every day. So that's her baseline. But 3 to 5 times a month, it gets as bad as a 7 to 8. And you can see where it is now. Now it's the tinglings with numbness, and she has pain. Pain. People don't talk about just unexplained pain because of this. And it's affecting her ability to think, her concentrating, understanding, and thinking clearly. So then she went on Natpara. And her new worst was her past baseline. So that was fantastic, right? So now she dropped all the way to a 0-2, but when she tries to do more, she goes up to a 3 to 4, but no 7 to 8, no 9 or 10s. Do you see that? And then she switched from Natpara to Transcon. And even with illness, she only experienced a 3 to 4. So that difference to me is remarkable. That's a miracle. But she's an athlete, and she wanted to exercise. So before parathyroid hormone, when she tried to exercise, even if she prophylactically took calcium, did everything right, her symptoms would go not only go up to a 7 to 8, but then they would stay there. So her baseline at rest, days after being active, was all the way up to a 5 or 6. Unacceptable with conventional treatment. And on Natpara, it was better. She could run a few miles, better than I can do, and I don't have hypopara, so I was impressed with that. And then on Transcon, she's at her baseline even with exercise. So this is, I think, one of the messages that is so important, to be able to explain this to your providers, to your family, to your friends, as much as you feel comfortable sharing. But I think that's going to help us all learn and help you improve your quality of life. So we know that we talk about elemental calcium, and really the best calcium is the one you'll take and the one you tolerate. But there are some differences in calcium, and you guys are calcium experts, and I'm here to talk about calcium safety. But you need to split it up, and you know that 3 to 6 times a day for better absorption. You want to try to time it so it's not right with your thyroid hormone, for example. Even though your calcium takes priority, I want you to take your calcium if you're on conventional treatment before you think of anything, even if you absorb your other medicines less well, because calcium's really the most important thing. Liquid, chewable, just not those big horse pills, right? Love horses, don't like the big horse pills. Calcium carbonate, as you know, has 40% elemental, so you get more per tablet, where citrate has 21%. So maybe you might say, well, calcium carbonate, like Tums, you need less per day. Maybe it's more convenient. Maybe it's more cost-effective. I've got arguments for calcium citrate, though. So absorption of calcium is best when there's acid in the stomach, and calcium citrate doesn't really need that. That's for calcium carbonate. So that's an argument where calcium citrate might be more convenient for you. You can take it any time of day, don't have to worry about meals. And there's an issue of what happens to our acid level in our stomach as we get older, or if we're on proton pump inhibitors for reflux. So achlorhydria, I want to talk about that, low gastric acid. So it's most commonly due to gastritis or an inflammation of the stomach, or with these proton pump inhibitors, we abbreviate PPIs, like Protonix, Prilosec. And 15% as we get older have low gastric acid anyway, maybe due to H. pylori infections, stress, smoking, alcohol, poor diet, all these things can affect gastric acid levels. B12 deficiency, another autoimmune condition. HypoThyroidism, if your TSH is too high, you're trying to absorb your thyroid, but with all this calcium you can't, so you're hypothyroid, not appropriately treated. With your thyroid replacement, that can lower the acid in your stomach. So all of these are reasons why you might want to take calcium citrate instead of calcium carbonate. But question, if well absorbed, if you're trying your best, if you have celiac and you're on a gluten-free diet, you're doing everything to absorb your calcium, are they equally effective in controlling calcium for men and women with hypoparathyroidism? My answer is yes. Now, you might tell me differently, but I'm happy with whatever calcium you're getting if it's enough, and if we're trying to keep it where it should be, not in your kidney. So it's not that simple. How do you tell? So here's calcium carbonate. You look at the front, it says 750, but it's only 300 milligrams per tablet. So whatever you're taking, look on the back and say, I'm taking 2 tablets, I'm splitting them up maybe, but 2 tablets equals 500, so that's 250 each of this calcium citrate. Now this is a powder, so 600 milligrams is 1.5 teaspoons. So you look on the back again, and this calcium citrate, it still says calcium citrate on the front, but 2 tablets is 600 rather than 500 on this. And all my patients sent me these beautiful pictures of their calcium, so it's tricky. We know that calcium isn't well absorbed in the intestine without active D, 1,25-dihydroxyvitamin D. And you've heard this already, but you need parathyroid hormone to convert that D that we make in our skin, even though I'd rather you put on sunblock and take your D3. And D3 is what kind of everybody else understands D is that isn't hypoparathyroid, so what you get over the counter. But because you can't convert that into active D, you have to take prescription active D. So it's anywhere from 0.25 micrograms, 1 tablet, it comes in 0.25 and 0.5s, as you know, to as many as 2-3 micrograms a day. Some people are on 0.5 micrograms 3 to 4 times a day. We usually don't need to split it up unless your dose is higher. And then there's also 1-alpha calcidol that is 1.5 to 2 times the dose, so the dosing's different. So why do you need to take vitamin D over the counter if you're taking the active D? Well, that's because it has other effects. It has effects in muscle. There are vitamin D receptors in muscle. The Institute of Medicine thinks 20 is a good enough level. I don't think anyone would agree with that here. We really want people to be up at 30 to 40, maybe even higher. But too much of a good thing isn't good either. So you really don't want your vitamin D level, your 25-hydroxy D level to be 80, 150, even though the reference range says that often, right? It'll say 20 to 150. And we'll talk more about that when you're learning and know more about parathyroid hormone, because when you're on parathyroid hormone replacement, you need that D to convert it into active D so you can get off of active D. And magnesium over the counter, maybe more if you're genetic rather than surgical, but there are other reasons, proton pump inhibitors and other malabsorption conditions that lower magnesium. So we need that to keep levels in the normal range. And then you've already heard about thiazides and ways to really help protect your kidney. I'm surprised that low-dose thiazides can reduce urine calcium by 40 to 70%. And we give osteoporosis patients that spill calcium thiazides if they don't have a contraindication to lower their urine calcium as well. But again, we didn't learn that in endocrine training. We are now, we're teaching our endocrine fellows that if you're on conventional treatment with hypoparathyroidism and you don't have a contraindication to a thiazide, which I'll share what they are, it's well tolerated, your blood pressure's not too low, you don't have prediabetes or gout, other reasons why the thiazide or sulfur allergy, reasons why you might not tolerate it. It's a great idea, but you have to be on a low salt diet, especially if you've made a kidney stone. And as has been already explained, that high fluid intake is not convenient. I have my water here, but you don't want to be getting up a lot at night. You want to be able to do everything you love to do without having to go to urinate all the time, but that does dilute the calcium, and so that's important. Now ask your provider about citric intake, citrus intake, maybe Urocit-K. That's a prescription to increase citric acid in the urine that helps prevent stones. And then the phosphorus calcium, important aspect of kidney safety. Okay, so 3 important slides here. Please carry calcium supplements with you at all times. So how many people already do that? Exactly. So you know that. Calcium-dependent medical alert. How many people have one? Uh-oh, I see a few people that I know should have one. They didn't raise their hand. Please, please, please. How about a calcium safety protocol? Do you have one in your medical ID or your phone? Excellent. And then in your packets, there are these beautiful medical alert crises, calcium crisis cards that the HypoPara Association made. So look in your packet. It's inside the brochure. So fill that out. This is really important. It can be a bracelet. It can be a necklace. You don't want it to be too beautiful because you want someone to look at it if you're sick. Would you consider wearing an emergency button if you're alone, or if you're in Spokane and you drive up to Upper Priest, which is beautiful, but there's no cell contact and you're out in the middle of nowhere? Do you know where your closest emergency room is? Are they covered by your insurance? And really importantly, do you have a healthcare advocate? Who are you going to talk into? Are they here with you, sitting next to you? A family, a friend? You have t-shirts. We all need t-shirts. This is great. It's so important, and they can learn more as you're here through the HypoPara Association. Okay, you need a lab slip. This is such a difficult job for all of us as providers. My stethoscope are your lab results. I still like my stethoscope, and I would love to listen to your heart, but I really need to see your labs. And it's so hard to get the results, to get them done, you know all this. But I want you to have a PRN, means anytime you want, from any of your providers, ask your primary care, ask your endocrinologist. I want a hard copy so that you can take it when you travel. I want it in the EMR if that ever works. I want you to be able to get your labs anytime you want. And make sure it works. You might have it, but it doesn't mean it works. And it doesn't mean that your providers get the results or get them in time. So you know this already, but a BMP, basic metabolic panel, includes a creatinine. You don't need that every 3 to 7 days, but we care a lot about what your kidneys are doing with all this calcium. And often now, especially for trials, but not in the real world, you need a corrected calcium. You may, depending on your own protein and albumin status, a corrected calcium might be more helpful, but we don't usually need an ionized calcium like we do in the hospital, outpatient-wise. So a CMP, complete metabolic panel, includes the albumin and liver function tests. So Patty, I think you're standing, so I have a few more minutes. Okay, you're walking. Okay, I only have a few more slides because I'd love to have time for questions. So you want to know what your calcium level is. You want your providers to know. When you're sick, you can't just stick it out like maybe you did before you had HypoPara. You're tough. We know that you're unbelievable living with HypoPara, but we need to know your calcium level, because if it's really low, then you need IV calcium or hydration. And if it's really high, we can treat that. You need to get your calcium. You need to try to stay hydrated if you have any GI illness, if you also have celiac, if you're doing a prep for a colonoscopy, anything that might induce malabsorption, you have to be on the guard. And if you have increased stress, or you're planning to exercise or run the marathon tomorrow Sunday in New York, you need to take extra calcium. I would not recommend that. My sister's running it. Oh my goodness. It's so important to stay hydrated. And if you don't think you can, have a low threshold to call your provider. Go to the ER. Even if it's for hydration and not IV calcium. Just that liter or two of fluid can make all the difference. And I already mentioned a colonoscopy. For those of you who are grateful to be old enough for a colonoscopy, you want to schedule it in the morning, not the afternoon. You want to limit the amount of time fasting. You need to prepare for that. If you're on conventional therapy, you are absolutely calcium and active D dependent, and that's what I want your medical alert to say, please. So we have a great rest of the meeting. I'm so excited. So we have Elena talking about focusing and how to track your disease, and she's written a book. She's going to tell you all about it, and even more on kidney safety, which is really one of the things you can't feel like you can your fluctuations in calcium. You can if you make a stone, of course, but we have to protect your kidneys because that's something you can't feel. And then we're going to learn more about the trials from Mark, advances in drug therapy from Aaliyah, and then our keynote speaker tonight I'm excited about. Tomorrow there's going to be more on the trials and more about cognitive function with Dr. Rubin, who's coming in tonight. And then we're going to finish up with Dolores again telling us about how do you tell the difference between calcium and thyroid. It's all so confusing. And Michael and Dr. Wang talking about the kidney. And then we're going to have the Q&A at the very end. So lastly, you know the symptoms. We want to make sure we're doing everything to improve your quality of life. I do want you to report your symptoms. I want you to figure out what's easiest for you to rate them. I want you to share that with your provider. I want you to have a healthcare advocate, please. I want you to try to determine for us what helps your calcium levels, when you can prophylactically treat them. And I want you to prevent the symptoms, as do you. I want you to carry calcium with you. I want you to have this crisis card and a medical alert. And I want you to know where your closest ER and urgent care is. And thank you very much.
All right, let's give it up for Dr. Kohlmeyer. Who has questions? Here we go.
I take chlorthalidone. Is that the same thing as a thiazide?
Yes, it is. And it's longer acting, and that's excellent.
Okay.
Would you repeat again what you would have us put on a medical alert?
What would you have us put on the medical alert?
No, I heard you. I'm just trying to answer. You want it to be straightforward. You want people to understand. I like calcium dependent. You can have hypopara. They're not going to know what that is, especially if you say hypoparathyroid, then they'll immediately see thyroid. I like calcium dependent. Mm-hmm. That's what I like.
Very good. Who else? Anybody else in the room? Okay. I'm going to go here and then I'll go there.
We consistently have an issue as a population when we go to the emergency room where they don't, not only do they not listen, but even when we bring a care plan in, it's 50-50, phone a friend, whether they're going to be a doctor that is interested in paying attention and just like, woohoo, I have instructions, let's go. So
frustrating.
Versus, I'm going to, reinvent the wheel. So is there anything we can do or verbiage we can include that tells them, like, knock it off, we know what we're doing, just follow the instructions, please,
yes.
Dear God?
So it's so difficult. I would do three things. I would have your family have T-shirts. I would bring in your advocate, have somebody pushy come with you, going up there, telling him this, we can't wait any longer, And I would know who works there. I'd go in, bring them cookies, find out what their name is. Hopefully you'll never need that, but you want to know who's there, who's in charge. You got to get people to listen. It's so hard. Just be really persistent and pushy. This is so important. Great question.
I don't actually have a question, but just on the comment about a medical ID, I wear one, and in case it's helpful, thank you. In case it's helpful to anyone about what I put on mine, I put my name, hypoparathyroidism, calcium slash magnesium IV, and then I have a history of thyroid cancer, so I put that. And then I put no thyroid on meds, so they know that I'm Synthroid dependent or whatever it is that you take. And then I have ICE, so in case of emergency, and I have my mom's number. So that's what I put on mine. I got the biggest medical ID I could find so that I could fit all that. So in case that's helpful.
So mine has been tested, and I've got hypocalcemia, seizure, tetany risk, give IV calcium, consult endo ASAP.
Thank
The
you.
seizure risk, when you say that, when the medics come to get you, or you're in the ED,
Good point.
they listen to seizure. They can get that. So it's been
Excellent.
helpful.
All right, very good. And I did actually just reach out to Lawrence Hope for the bracelets after somebody gave me a little clue about it. So I'm working a deal with them to try to see what we can do to put something on our
Great.
website for that.
So a bracelet is really nice, but these actually give you lots more room if you get the dog tags.
Thank you, Vicki.
All right, let's do some online.
Yeah, we have some online questions. One of them is the scale that you put up with the calcium. Can you make that so that it's printable and give it to the HPA so they can share with, so that patients can share with their doctors?
Absolutely. I mean, I want to remind everybody it's not validated in a trial, but Danette and I kind of put that together and thought it would really help, and we'd be honored. Yes.
Okay, the other one is, why do we have symptoms even when our calcium levels are normal?
That is the question. Why do we have symptoms? And I got to tell you, when I go to meetings, that is the question I ask everybody. I ask the neurologists, I ask the scientists, and I just asked 3 people at my table this morning already, who's studying this? We're told that it's a neurosensitivity, and it might even be your change in calcium, not your actually level that is measured, that's affecting the nerves. And does parathyroid hormone replacement fix that, reverse that, prevent that? I mean, that's what we need to know, because you can have symptoms when your calcium's 8.6, even 9 sometimes. On parathyroid hormone replacement, you have the luxury of having a higher calcium because we're keeping it out of your kidney. And so maybe if you have this neurosensitivity now, but you're on parathyroid hormone, you don't have to be 8.3 to 8.8 anymore,
She said magnesium, potassium present with a similar symptom?
They do not, but if your magnesium's very low, then your calcium usually doesn't work, and so you'll have the symptoms from that. Potassium can cause some cramping, but it's a different etiology.
I think one of the other things people don't, a misunderstanding about lab results is that normal range is not, that is where they've gotten a small collection, sample size of people, and that are healthy, and their numbers fall within that range. It doesn't mean that you will feel good at every number in that range.
And I would say no reference range is right. It depends on, the condition.
Because, my happy place is
Absolutely.
like 9.4. And
Absolutely.
Anecdotally, talking to people, anybody who has calcium numbers from prior to surgery, for the surgicals in particular, if they can get back to that number, that's where they feel best. And so,
Great to know.
So the fact that it's in range doesn't mean it's at your range. And I think that's something to emphasize with our doctors.
And I think that if you feel good at a calcium here, then we want to know what's your 24-hour urine calcium. And if you're on conventional treatment, do you need a thiazide chlorthalidone or hydrochlorothiazide to lower your urine calcium so that we can keep you there? And the calcium assays are not perfect. You can have the same blood checked in the same assay and get different levels. The precision is not what we need it to be, but we're going to hear more about that.
Michelle, you had some?
I have another online one. It says, as part of our calcium safety, do you recommend that we request from our doctor standing lab orders? And if we do, what should we do if we go to the ER and the doctor in the ER says that he's the doctor and he's not going to obey those orders?
Scream. Yes, I want you to have a standing order. I want any lab you go to accept it. So maybe it has a signature, a fax number, a phone number. I mean, this is the challenge that I know you face, and we have to do better.
Is there a reason when I travel and I fly, I always have a low level that night?
Interesting.
Is that what it is?
The change in CO2?
I think this is a clue for Elena to take over.
Yeah, it's a change,
Thank you,
it's a
guys.
change in your oxygenation and CO2 levels. It happens at altitude as well.
Okay, well, let's give it up for Dr. Kohlmeyer. And we're going to resume at 1:40 with Dr. Christofides. Welcome back, everybody. We're excited for our next presenter. We were able to see her in June at our webinar, and I know we got so many fabulous comments about her. She's going to be talking about patient-focused guide to tracking your disease. I did want to really welcome her to the team here. Dr. Christofides is a physician, chief executive officer at Endocrinology Associates in Columbus, Ohio. So thank you for your time.
Thank you, everyone. It's really an honor for me to be here today. I love speaking, and you guys have probably figured that out by now. And those of you who've heard me before, but I really prefer talking to patients and their caregivers, because my colleagues, as you've already figured out, sometimes from the ER, are not always the easiest to talk to. So now, that's the exception of the people here today. I really love rare disease communities more, because rare disease communities, I think, feel that sense of need to be more attentive and more sort of just aware of what's going on around you. Now, I didn't put a disclosure on there because I forgot, and I just have an added disclosure. I am now in the Ascendus EAP program, so that is a disclosure. We literally just got started, and our first patient who enrolled is here. So yay! So the point is, that is my new disclosure, and I did not add that. That was my fault. So let's talk about, this is a patient-centric talk, so I'm going to give you the secret language, so to speak, to help you navigate providers, even providers that are well knowledgeable, that you've been with for a while, or perhaps providers who are not so knowledgeable. The goals of your healthcare team are not often aligned with your goals, right? The first one is to prevent symptoms of low calcium. Now, our definition of symptoms is not your definition, and I understand that. So it is important that you convey that you are having symptoms of low calcium when you're speaking to them. And that Lynn did a fantastic job of going through those, and I will give you even more language on what to use. The rest of it obviously has to do with blood levels and urine levels and keeping the calcium from collecting in your kidneys, et cetera. So when you're talking about symptoms, one of the hardest things to pull out of patients is, what is the symptom? How do you describe the symptom? How often is it happening? And the problem is, I see this in the patient community all the time. You come in, you think we're really busy, you know we're really busy, and you minimize. We all do it all the time. Some of us more than others. My dad, not so much. He's not a minimizer. My dad is a maximizer. The men in my life are maximizers. The women in my life are not so much. It's not a dog on the men. My son is a minimizer, but that's probably because he's my child. So he knows that if he actually says anything valuable, he's going to end up in the ER. So he really minimizes the symptoms. So that's the problem, is you have a little PTSD regarding the healthcare community. You have a fear of being told you need to go right now to the ER, you need to go to the hospital. You have this fear, and this is an innate fear. And consequently, you minimize. And you wait until, well, I'm not having like the tingling to the level where I think I'm about to have a seizure right now, but I had it 3 times this week. So I want you to think about what Lynn said, and I know that it's not a scale that's been validated. I don't care. Because when you're talking to a doctor, unless they're like on the board, they're not gonna know it's not validated. So they're not gonna know that it isn't real. They're not gonna know it's not real, so that's okay. That's okay. It doesn't have to, it's real to you, right? It's real to you. And it's language that you understand. So this is why that scale is important. When you go to your new provider then, whether, let's say you're moving, you've changed providers, you've changed insurance, we all know how that works, your provider moves, or they change institutions, these are the questions that you need to make sure that you are asking of them. And by the way, as Patty alluded to, I did write a book called Living with HypoPARA. It's on Amazon Kindle. It's available electronically. Or if you want a hard copy, just email me and I'll send it to you because I have plenty of extras. Turns out it wasn't all that popular.
There was also fights with the electronic rights. Anyway, so these are all, everything I'm giving you is in the book. So if you don't keep notes quickly, if you can't write quickly, you can't type quickly, it's fine. You won't, it's in the book. And it's really not that expensive, but I'm happy to send you a physical copy. These are questions that if your provider cannot answer to your satisfaction, find a new provider. These are questions that if your provider gets pissy with you because you asked them, get a new provider. These are questions that if your provider has no idea what you are talking about and why this is important, get a new provider. These are important questions to understand about your provider's knowledgeability about how to help you. Because when you're walking, talking, breathing fine, sitting there in front of them is not the time to worry about their knowledge in a crisis, right? Their knowledge in a crisis is going to matter to you more than anything. And if you're not having a crisis in front of them, how are you going to know that they can manage the crisis correctly? So with that being said, I also want to make a plug. We're all physicians here, I think, to speak to you today. I want to make a plug. There are a lot of areas in the country that don't have endocrinologists. There are a lot of areas in the country that are being managed or mostly predominantly by nurse practitioners. And I will tell you that I have come across so many amazing nurse practitioners that I would actually rather treat me than an endocrinologist sometimes, because they're that much more caring or they don't have the biases involved. And so do not dismiss a potential provider just because they're not a physician. That's all I'm going to say. And that also means you might need one or more of us like that to be your healthcare advocates, like somebody that the ER or a provider can call. So how they manage hypopara, what do you best see? And I would also just remind you, if they have firm answers for many of these, they're also probably not the right provider for you. Firm answers, right? So how many patients with hypopara do I treat? Well, I supposedly have 7 that come to see me. 1 doesn't like to come in very regularly. 1 thinks he knows everything, and 1's just got mental health issues. So that's the point I'm making, is it's not like I have exactly this many. Or what tests do I need, how often, how is it managed? The answer should always be, well, it depends. If their immediate response isn't it depends, they're probably not flexible enough to go with the flow. Like you were saying, you need your calcium at 9.4, cool. I want to make sure your urine is okay. But if their answer is, nope, your calcium max 8.5, it might not be somebody who's so flexible with their understanding that in case they didn't realize, patients often forget to read the textbook before they come in, and the values aren't actually the way the textbook says. Right, so there's the science of medicine. We learn the first 2 years of medicine, and then we learn the art of medicine in the next 2 years of medical school, which usually means patients thrown the book out the window. So you have to be prepared for that. So if the answer isn't, it depends, it's probably not a super flexible physician. These are questions that you take with you to every visit, because so many of you also have other autoimmune diseases like thyroid or vitiligo or alopecia or whatever, or you are post-op and you have thyroid disease. So you're like, is this my thyroid or not? It's like the roulette, right? Is this my thyroid or my calcium today? Let's spin it. Is it black? Is it red? I don't know. Because the problem is, as we age, and we are fortunate enough to be on this planet another day longer, there are other things that can be wrong with you that could be contributing to your symptom. And the worst thing that can happen is someone's just blaming calcium, 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 and never mind ignores the fact that now your blood pressure is 180, or your diabetes is manifested, and your sugars are 300. So there are other possible causes, and that goes for you too. Don't always assume that it's your calcium. Don't always assume it's your thyroid. And the worst thing that you can do is try to argue about the micro details of your calcium. And then let me give you an example. Why was my calcium 8.4 today and it was 8.3 yesterday? But why did I feel good when it was 8.4, but I don't feel good when it's 8.5? Because as Lynn pointed out, our labs are not exactly precise. They're really not. So I don't know is going to be the answer you're going to get to that kind of question. But if you come with my calcium has been kind of sort of in the same number for the last few months, but I'm feeling this way, a certain way, that's how we get to finding other things that are wrong with you. So
the two-way street here. So just like you don't want me hyper-focusing on just your calcium and ignoring your other ailments, I don't want you hyper-focusing on your calcium and ignoring the possibility that there's something else wrong, because you're human. There's other things that could happen to you. And the older we get, sadly, the more things that can be. Are there alternative treatments? And I don't mean like herbals necessarily. Yeah, be careful, be careful, be careful, because the FDA doesn't regulate supplements. And as a result, you have no idea what's in them. When I did my fellowship, my co-fellow actually did one of his papers on the amount of, I'm going to take a really common hormone that's available over the counter called DHEA. He took every supplement he could get in the store, and I see you guys are in Louisiana. I trained in New Orleans, so woo woo. We had a lot of supplement stores and a lot of herbal stores. Right? Like every other shop in Bourbon Street's an herbal store that's going to cure you of something. So he took every supplement he could get his hands on and tested it in the lab and found anywhere from 0 to like 10 million jillion value higher than what was in the label. So supplements are not the right answer. They may be, under certain circumstances, appropriate and when supervised, but not routinely, please. Alternative treatments, what I'm talking about, are things like other diuretics or other water pills, right, like chlorthalidone versus thiazide, or calcium citrate in combination with calcium carbonate. The fact that I really like Rolaids as my chewable calcium supplement because it's calcium and magnesium. It's chewable, and if they ever figure out their supply chain issues, readily available. Every now and again, it becomes unavailable. So, and then the diet, as we talked about, low sodium, increased hydration, making sure there's no gut inflammation to enhance your calcium absorption, maybe taking your calcium with vitamin C. I finally have my surgeons, after 20 plus years, giving all of my post-op thyroid patients and parathyroid patients vitamin C with their calcium when they leave the hospital to make sure that they're getting improved absorption because they're stressed. They've had surgery, they've had anesthesia, God knows what else they've been on in the hospital. So I routinely have them giving vitamin C tablets to take, chewable vitamin C tablets before they take their calcium to enhance absorption because vitamin C increases absorption. These are things that you might do, obviously within supervision and conversation, but these are what I mean by alternative treatments. These are the tests that are routine, different frequencies. I, too, have my patients have standing orders. It, too, says you better call me on there. I've fortunately been around long enough that I have quite the reputation. Most ER docs are more afraid of me than they are of the patient. So they will do what I tell them to do. Every now and again, you get a newbie, and they have to be schooled about what it means to go against my orders. But how do you ensure you get your labs done if you are in crisis is find a nurse. When in doubt, find a nurse. They will advocate. In the hospital setting, a nurse is your best patient advocate. And if you can't get any attention from a nurse, because I've met bad nurses too. If you can't get any attention from a nurse and your health advocate isn't there with you, call the patient hotline on the hospital. So every hospital has a patient hotline that goes to one of their nurse managers that's on call, that roams the hospital. And that patient advocacy line, patient line, hotline, whatever you want to call it, the hospital operators know that number. And if you call the hospital operator and say, I'm about to have a seizure in the hospital and I can't get anyone to listen to me, I need a patient advocate, I need a nurse manager, they will get one for you. The hospital operators are your other secret weapon. I love the hospital operators. They've always been my favorite people in the hospital because they truly care about connecting people with the right people on the phone. And so if you're nice to them, and yes, it doesn't hurt to take them cookies, they're always hidden in the basements of the hospitals somewhere. I always made sure I knew where they were with every hospital I was at, and I always made sure I took them food because they were my bestest friends, always avoiding the people I didn't want to talk to. They were always good at making sure that I didn't get the phone calls I didn't want, and then getting the phone calls I needed. So obviously some of them are not going to be done every lab or every office visit, like a DEXA or a kidney ultrasound. Those are not the ones that are done routinely every visit, but the other ones usually are. So this is what a tracking log looks like. This is in the book. You can photocopy it. I'm sure Patty would be happy to send it to you guys. This is what a tracking log looks like, and where you can document your labs by the date you had them. If the assay is a different assay and it's got a different reference range, obviously you can change it. This is just meant to be an exemplar. And then side by side with that, you can have your symptom tracker. I really sometimes use very simple things, right? Like, because if you're in the room and you're like, okay, is this happening like once in a while? I don't know, once a month, once a week, every day, every hour, waking you up in the middle of the night? I tend to ask very simple questions like that, but I also ask. There are a lot of providers who don't ask, and so, you know, Lynn's tracker might be a good one to do. This one is also pretty easy. We are ultimately all very simplistic thinkers as well. So if you tell me something's happening every day, that's a problem. If you tell me something's happening every week, that's still a problem. Once a month, I may not be so attentive to. So these complaints are good to use in the 1, 2, 3 method. Now, let me give you some other words. Throat tightness. You say that to any provider, and I mean, we're just going to roll our eyes. I get it. Because my mom, like, I don't wear turtlenecks because they make me choke. And I'm like, okay, Mom, I don't know what to tell you. Like, your thyroid's fine, your neck is fine. She just has a sensitivity to it. So throat tightness to you, though, is one step away from your vocal cords seizing and spasming and not being able to breathe. So the words I would use is, you know, my throat, I'm choking, I'm being choked, and I'm going to get to the point where I can't breathe, because this is a calcium-dependent thing. So throat tightness, where I feel like I can't breathe daily, weekly, monthly, where my vocal cords are spasming shut. We understand those words. Same thing with like muscle twitches, muscle spasms, muscle cramps, muscle weakness. I'm going to describe various things. I had a patient once who came to me out of frustration with his previous endo because his wife had just had delivered their new child, and he was so afraid of dropping the baby when he held the baby that he wouldn't hold the baby. And he kept telling his previous endocrinologist, I really have really bad muscle spasms and weakness. And his endo was like, you're not hypopara. Never mind that his calcium's like 7.5. That's okay. And, you know, he needs post-op. So the point is, when he said to me, my arms are so weak and they spasm so hard, I'm afraid I'm going to drop my newborn son, now that gets your attention. So use the full sentence. Voice your fear. My fear when people say things like that to me is, you better not be on the road then. Because if you're having a muscle spasm when you're driving, that's not so safe, right? You twitch and your arm twitches and your steering wheel twitches. Depending on where you're driving, you might have really narrow lanes. You might hit the car beside you. You might hit the curb and then fling off. You might accidentally hit the gas pedal or the brake pedal in your twitch. These are voice your fear. It may not happen. That may not have been something that happens to you, and I'm not trying to give you an additional fear. I'm not trying to give you another paranoia. But these are things that you can say to your provider that will get their attention. Like, my muscle spasms are so bad sometimes, I'm worried about driving because I'm going to twitch the steering wheel or twitch the gas pedal or the brake pedal inappropriately. And that could be lethal to anybody in the car with me or around me. I guarantee you every provider you're talking to is on the road too, right? They're driving or biking or whatever, so they're going to be like, oh, I don't want to be on the road when you're on the road. The brain fog, confusion, disorientation. I know everyone's talked about thyroid. I want to remind you, depression, irritability, brain fog, confusion, disorientation, the majority of hypopara patients are women. What else happens in our 50s? Menopause. Number one symptom of menopause is all of that. Estrogen is your friend. Estrogen is very beneficial to calcium. HRT is your friend. Very much affects those main symptoms. Also muscle weakness. Also, by the way, feeling slow or feeling lethargic, fatigue. So not just don't focus on the calcium, don't just focus on your thyroid. Hormones. For the men, you know, hypogonadism or low testosterone as we age is also not an uncommon feature, especially if we have any amount of obesity or diabetes. So low testosterone can produce similar symptoms in men. So these are, unfortunately, really big categories of complaints that you guys have that could be attributed to completely different things, all right? The heartbeat is not one I've seen actually be too problematic for people because you're not usually like paying attention to it. But if you have a heart rate tracker, and I forgot mine, I left it on the charger when I left home. If you have a heart rate tracker, use that information. Absolutely use that information. Everyone knows this, right? If you aren't aware of the changes in your EKG, the electrocardiogram, you may not know that there's actually a cardio device you can buy now. I think it's like maybe like $100, and you put your thumbs on it, and it connects to an app on your phone, and it actually reads your EKG. I don't know if you've seen that. I keep one at home, just because. It is actually. It's quite accurate. It's very effective, it's quite accurate, and it will tell you it can't detect AFib, which is not necessarily what we worry about, but you can put your doctor's info in there, and you can have it sent to them on a regular basis. So, and you can show it on your app, like when you come into the office. So I use that for people who have more cardiac issues, or maybe they're older and they have more cardiac concerns. I definitely use that cardio IQ thing. It's just basically like it's literally smaller than this, and you just put your thumbs on it, and it tracks your heart rate and your EKG. I forget. I took my estrogen, I swear to God. I will. I'll send it to Patty and make sure she can disseminate it. I can visualize it. You know what, I can find it on my phone, because I have the app on my phone. So I can like shout it out later after the break. Absolutely. So I know Lynn made a huge point about this. I'm actually going to go one step further. I have had more than a dozen, almost 24 medical emergencies in flight when I'm traveling on a plane. Not me personally, attended to. I have the most of anybody I know. I don't know why, I'm clearly the magnet for it. And everything from people passing out to people with chest pain to women miscarrying to babies with rashes, you name it. The baby I definitely gave to the pediatrician that was on the plane. Thank God there was a pediatrician. I don't do children. So I'm going to give you another piece of advice. Please put it on your phone. Every phone has a medical alert first aid app. Every phone has the capability of putting it on the lock screen. Every phone has the capability of having it on the front screen, on the back screen. I would really advise you to do that, please, because if you are passed out, do you know what we're not going to be looking for? I'm not digging in your shirt in the winter to look for a medical alert necklace. I'm going to look on your wrists, potentially, but I'm going to look for your phone. Why? Because I'm going to call someone on your behalf. I'm going to look for mom, dad, husband, whatever nicknames. I'm going to look at your favorites list. I'm going to look for people to call, all right? Well, what's the first thing I'm going to see, though, is I'm going to see a medical alert. So I would encourage you, yes, get a medical alert, like physical item, but put it on your phone. I actually would encourage you to hang it on your car as well. So hang dog tags. I love the dog tags because you can put a lot of information on them. Hang them on your rearview mirror. Because if you wreck, I did have a patient who had his wallet stolen from the asshole that ran him off the road. His medical alert was in his wallet. Yeah, I know, right? Like, that's Ohio for you. I don't know. I'm just kidding. I live in Ohio. So the poor guy had his wallet stolen, and he had his medical alert in his wallet. He had a card. So yes, a card in the wallet's good. Yes, a bracelet's good. Dog tags on the rearview mirror better. On your phone app is best. If you are an exerciser, if you are a workout person and you are now more active because you're on some form of PTH, there are actually they're sporty ones. There's like rope ones. There are climbing ones, and you can tag them on. There are actually ones that you can also tag onto your backpack. You can put them on your tent. You can put them anywhere. So there are many, many systems and apps you can choose from. I really would encourage you to use it. And I wouldn't put it past you, like shove it in the doctor's face if you go to the ER. You're like, I have a medical alert for a reason. I love the idea of putting your doctor's number on there. Most of my patients who have rare diseases actually have my cell phone number. Because if you have something this rare, I want you to call me when you're in the ER so I can yell at the ER doc. I'd love nothing more. Nothing more. Nothing more. It comes with age. You know, once you pass menopause, you're like, don't
Don't even cross me. So shove the medical alert in their face. Like, I have a medical alert for a reason. Like, do you want me at calcium to go so low that I'm seizing, and then you won't be able to actually save me because you won't be able to get an IV in me because I'll be in tetany like this, and you won't be able to get an IV in me. So, threatening them with the worst case scenario usually gets their attention too. Use your fear and your PTSD to your benefit. And like I said, have the medical alert in your hand. That also helps, as I said. That might get their attention. So that's the end of the presentation. I hopefully got us back on time and on track, but obviously I'll take your questions. So thank you for your attention.
All right, thank you. All right, who has questions? Give a raise of your hand. Oh, Michelle's got some online questions. She had me all panicked there. I'm like, where'd she go? Where'd she go?
If you go to the ER, what calcium level should they treat you at?
Whatever calcium level you think is a problem. If you go to the ER and you think your calcium is a problem, it isn't going to kill you to get an ampule of calcium gluconate while you're sitting in the ER to see if it resolves your symptoms. So in the acute setting, I'm not worried about your 24-hour urine. I'm worried about you not seizing. So, if you think your calcium's a problem, then treat the calcium and see what happens, see what's left. I'm all in favor of treat first, ask questions later when it comes to calcium. There's some questions up here in the front, yes.
Yeah, less a question, more a comment. When you talked about having a twitch on the gas pedal, I had my cramp and my foot was pushed all the way down to the floor of the car. And I was actually at a conference for a different thing, and I was following someone home because I was staying at their house, and I almost hit their car because I physically had to hook my arm under my leg and yank it off the gas pedal and drive with my other foot. So if you're doing long car rides and stuff and you're doing a road trip, let's take extra calcium beforehand and make certain you're stopping for breaks when you need to, because, don't be me.
Yes, so I'm so glad that you brought that up, because I used to think that I was being overly paranoid about making this recommendation because no one had ever told me that it actually happened. But if you're holding your foot constantly in a certain position, you're depleting the calcium locally, not systemically, locally. So that's why your foot seizes, because calcium, remember, you need calcium to relax the muscle in order for it to contract again. But if you've contracted it consistently, constantly, there's no calcium left to relax it. So absolutely correct. It isn't the whole body calcium, it's literally localized phenomenon in the leg or in the hand. So for those of you who have maybe not contemplated getting a new car recently, please think of it. Please think to do so. Almost all new cars have adaptive cruise. So adaptive cruise, if you don't know what it is you can set the speed on your car to whatever speed you want to go to, and it will slow you down and speed you up according to the distance to the car in front of you. And so it is brilliant. Some cars have a little bit more aggressive. The German cars are very aggressive. Adaptive cruise, just warning you, they'll whip your head back. But the Japanese cars are a little bit more gentle on their adaptive cruise. So adaptive cruise is a way around drive fatigue or car fatigue. So if you're taking long drives, and obviously it doesn't work for traffic lights unless you're driving one of the Teslas, which is it can drive itself. And then I would make a plug for that. If you are that bad, think about getting a Tesla with the auto drive mode. So there are cars that can have adaptive features for you to make you safer and make you feel more safe on the road. Adaptive cruise being one, self-driving cars being the other.
One up here.
Sir, you had a question, I think? No? Okay. Oh, yeah.
Anybody else? Questions?
Could that relate to bedtime? I get leg cramps at night in bed, but my calcium is 9.2.
So cramps that are localized at certain times of the day always make me think about blood flow. And if you're getting cramps at night when you're laying down in bed, that makes me think you might have poor circulation. So maybe wearing something that warms, like a warming blanket in your bed that increases circulation might help. Maybe taking some increased liquid with like calcium, like a calcium drink or a liquid drink. My favorite are the coconut waters. Actually, that might help before you go to bed at night. But if you're doing that, that makes me believe that might be a circulation issue in your legs. Yeah. No?
So one of the questions is it possible to have low calcium symptoms when you are on PTH therapy and your calcium levels are normal?
Of course, it's always possible you can have low calcium symptoms because the symptoms typically are coming from the ionized calcium, which is the free calcium. And when we measure your lab, it's actually usually the total calcium or the bound calcium. And there are many conditions that can lower the calcium level, the ionized, without touching the total, one of those being hyperventilation. So we were talking about that earlier in the break after Lynn's talk. If you're flying in a plane or you've gone to altitude and you don't live at altitude, the lower oxygen level may cause you to hyperventilate and breathe faster, which blows off carbon dioxide. When you blow off carbon dioxide, it actually lowers the pH of your blood a little bit, and it actually causes calcium to be bound more. It moves ionized calcium to the bound form instead, and so lowers the free calcium in your blood and can precipitate low calcium symptoms temporarily for that reason. So it's a hypoxia thing. Now, when you're on a plane, planes are actually pressurized to about 10,000 feet, even though you're flying at 30,000 feet. So 10,000 feet is twice the height of Denver. So for those of us who are, 2 miles roughly, in that regard. So if you're used to living at sea level or below sea level, then you are going to be really affected the minute you go to anything close to 3,000 or 4,000 feet, which isn't even a mile high. So if you are in pain, if you are upset, you might hyperventilate. If you get anesthesia, you might hyperventilate. All of these things can lead to a lower ionized in the moment. So the way to fix it is hold your breath. I mean, you can't hold your breath for the whole flight, but if you're having a moment, try holding your breath.
The next question from the virtual audience is there a hormone replacement therapy you would recommend for hypopara patients?
You mean for like female hormone?
Yeah,
so
the menopausal ones.
Yeah, so a menopausal female, straight up estradiol and progesterone, not any of the other stuff, and don't do horse piss, that's Premarin. So that's what it's called. It is, it's pregnant mare's urine, horse piss. So you could do estrogen and progesterone, straight up estrogen and progesterone. Obviously, there's patches available because you're already on so many pills. And then for men, there's testosterone as well as other forms of testosterone, not testosterone therapy, generally speaking, yeah. So it's pretty straightforward. HRT is not hard, although people make it hard.
Is hydrochlorothiazide a good choice to lower calcium spillover?
Yeah, it's one of our preferred drugs to use for urinary calcium problems, and obviously chlorthalidone is another one that we use as well. Yes.
When do we need to have ionized, or is corrected calcium always equal to? I've heard two different answers.
So the corrected calcium is a estimate of the ionized, but we almost never draw ionized unless we have a real question or a concern in the immediate time, because to do a proper ionized calcium, you have to actually draw it in a special syringe that is pH stabilized. And it's called an ABG syringe because that's how we draw arterial blood gases. And so you have to use an ABG syringe on venous blood because it's pH stabilized, and I assure you no one would do it right except the person who actually cares about it, which is never the person actually drawing the blood. So from that perspective, the corrected calcium is our best estimation. But again, same thing, is it's not going to capture an immediate or urgent sort of fluctuation due to, say, hyperventilation or whatever. So it's an estimate at best. So it's always best to assume the ionized is a problem if someone's having a symptom and their total is okay. Because there's no downside to assuming that. There's only downside to not assuming that.
Thank you, Elena. That was fantastic. Can you explain, if we know, why muscle cramps tend to occur more in some people when you're swimming, when you're in the water, not a good time to have them?
Yeah, oh, great question, Lynn. As a competitive swimmer, I can tell you, I know that answer very easily because it happens even to people who aren't hypopara. Water is an amazing heat conductor. So water conducts heat extraordinarily well. So
pools are typically not at body temperature. They're typically about 10 degrees lower than body temperature, usually maybe 5 at minimum, but usually 10. So when you are in the water, and that's in a pool, not just a normal body of water, you're actually withdrawing heat pretty aggressively. So you're actually losing heat very aggressively. So you're activating non-direct muscle action for thermogenesis. So you've heard of, whatever, you shiver, right? So everyone knows you shiver when you're cold, and that's non-activity thermogenesis or non-activity muscle contraction, designed to increase thermal energy internally. So when you are dropping your body temperature because you are in the water, you are then consuming more calcium than normal because your body's trying to shiver in order to increase your body core temperature. So you're chewing through more calcium than you have a right to because your body temperature can't keep up with your surroundings in that setting. So it has to do with shivering, and you may not be shivering in the water, but it has to do with non-directed muscle contraction. So it's a real problem. It's a real problem because you live in a northern climate, I live in a northern climate. Our waters are not, our fresh water, fresh bodies of water are not at temperature till September, if at all. So that's a plea to move south and go to the southern waters, just kidding. But it also means, though, that if you are somebody who likes to swim for exercise, they may not be the best choice for a hypopara patient for that reason, unless you can find a gym or a facility that will heat the pool to appropriate temperature.
Our next virtual question is there a recommendation? How do we prepare for surgery because fasting seems to trigger hypocalcemia?
The best preparation for surgery for a hypopara patient is admission to the hospital before surgery or the night before because you're fasting. So I, generally speaking, will ask my hypopara patients to go into the hospital the night before when they have a surgery that they'll have to be fasting for because of that limitation. And then, of course, you can monitor your calcium with IV and blood draws very quickly and very, very on top of it. So I usually have a conversation with my surgeons in that case.
All right. One more question, then we're going to move on.
You've mentioned several times the corrected calcium, but on your list of tests, you didn't list albumin, and I fight with my doctor to include that because I have noticed that I can be at 8.5 and feel terrible, and I can be at 8.5 and be well, and if you actually look at albumin, you can see the difference.
Yes.
And
yes.
they don't seem to pay attention to that.
Yeah, and that's because a lot of people don't know how to do the calculation for corrected calcium. And so it's interesting that you pointed that out. I actually left it off for a reason. I believe my patient when they tell me they feel bad. I believe you when you tell me my calcium's the same when I feel bad. I don't need the corrected calcium to know that you're feeling bad. So I personally, and to the point that's been made earlier, when you're doing research trials, they need to know that, and I understand that. And I'm doing albumin and other testing. I'm doing comprehensive testing and other lab work, like when I'm doing your cholesterol and your liver and so on. So I guess it's really just a matter of, do I really care that your calcium is 0.1 lower than last time for you to tell me that you feel bad today? I don't know that I really care. I care more about how you're telling me how you feel rather than the actual calcium level today, because today you feel fine, so it doesn't help me. Does that make sense? Yeah. Touche. Okay. All right, touche.
All right, let's give it up for Dr. Christofides. All righty, so we're going to move right along, and we have two presenters that are joining us that are actually sisters. They're the Liang sisters, which some of you guys are familiar with. Dr. Kelly Liang is an associate professor of medicine in the Division of Nephrology and Hypertension at the University of Kansas Medical Center and is Kim's twin sister. Dr. Kimberly Liang is an associate professor of medicine in the Division of Allergy, Clinical Immunology, Rheumatology, also at the University of Kansas Medical Center. So we welcome them in online.
Hello?
Hello, Liang sisters, welcome, and you're ready to go.
Hi. Well, it's a pleasure for us to be here virtually. I don't know if you all remember, I'm Dr. Kim Liang, and I also have my twin sister, Kelly Liang. I'm a rheumatologist who's living with post-surgical hypoparathyroidism, and my sister Kelly is a nephrologist, and we're really honored to be here to speak with you today about basically labs, imaging, and tests for kidney stone monitoring. Okay, so we have no financial or other conflicts of interest, and just want to give the caveat that we're physicians, but obviously not endocrinologists like the other esteemed presenters here. Like I said, I've been living with hypopara since December of 2009, and so a lot of what I talk about here today will be based on my experiences both as a patient and a physician, mostly a patient perspective for a lot of about how to talk about the labs to your doctor and such, but also in terms of the lab work knowledge that is from my own experiences as a physician as well. I also want to mention that, remember that every patient's case is unique, every physician is unique, every practice style is different. So, what we say here today, you still have to kind of just work closely with your own individual physician. So just a little outline. First, we'll go over why we need lab tests to monitor hypopara, what they are, how to read them, and then I'll turn it over to Dr. Kelly Liang for the urine studies and also testing like imaging for kidney stones. And then we'll finish up with just kind of how to discuss with your doctor and some other kind of lab tests that might be relevant when working up the symptoms of hypopara. So first, why is calcium and lab monitoring so important in hypoparathyroidism? As you've probably heard earlier today, normally PTH functions to keep the serum calcium and phosphorus levels steady on a continual basis. So when you lack PTH, that's going to lead to a decrease in serum calcium and an increase in serum phosphorus. And if the calcium biphosphorus product goes high, that's usually more than 55 in general, then you're going to be at increased risk of soft tissue calcifications, what we call calcinosis, and especially things like nephrocalcinosis, which can lead to renal failure. Now, that leads to talking about the urine so much later today, that if the 24-hour urine calcium goes high, like more than 300 milligrams, then you're going to be at an increased risk of forming kidney stones, nephrolithiasis, and the kidney failure from nephrocalcinosis. And if the calcium drops dangerously low, and that's usually anywhere around like less than 7.5 or so corrected calcium, that will increase the risk of tetany, seizures, and arrhythmias, and can be potentially life-threatening. So in hypopara, as we all know, calcium levels can drop very quickly because we don't have the ability to secrete the PTH to keep that calcium in tight balance. There's a lot of various triggers and stressors that can contribute to these fluctuating levels. Dietary changes over time can affect the total daily calcium needs. The 24-hour urine calcium levels may change over time. So even if you're good on one check, you still need to check it again over time. And phosphorus levels, if you have high phosphorus levels, then that may require a change in the diet to reduce phosphorus-rich foods. Potassium and magnesium are also important for calcium absorption. Low potassium, which is hypokalemia, and low magnesium or hypomagnesemia can also cause muscle cramps and weakness, which really mimic a lot of hypocalcemic symptoms. Vitamin D is very important for calcium absorption, for bone health, and also for immune health. We'll discuss this a little bit more later, but it's kind of a little controversial what the level should actually be, and also where we should keep it in hypopara. Now, remember that calcium levels don't always correlate perfectly with symptoms, so you may need possible additional tests and other workups sometimes, like don't always only assume that it's from the calcium levels. So in post-surgical hypopara, especially early on in the first 3 months post-op, it's extremely important to be monitoring these labs very closely because there is a possible outcome of a return of parathyroid function, meaning your parathyroids may just be stunned, quote unquote, and within 3 months it should return to normal and your hypocalcemia may become basically normal. So you need frequent checks to ensure that it's safe to wean down on the calcium supplements. Usually the surgeons for some reason use Tums all the time, but any calcium supplement that they put you on post-op, as you wean it down, you need to be having the regular calcium checks. And you need to watch for hypercalcemia as well. So, and then when you're a late or long-term hypopara patient after 6 to 12 months, then you're going to need regular checks to ensure that no dose changes are needed in the calcium supplements or the calcium trial doses, et cetera. And you're going to need the 24-hour urine calciums to monitor to reduce the long-term risk of kidney damage. So what kind of labs are the most important? So I usually think, on a lab slip, you should be having or asking for the serum calcium, albumin, phosphorus, creatinine. Early on, when you're like in the early post-op period, you should be monitoring the PTH to see if it's returning function. Ionized calcium is sometimes really helpful. We'll get into that in a little bit, but that's more like the actual calcium that kind of you don't need correction for. Potassium, magnesium, and then probably not as frequently, but periodically, the vitamin D levels, like 25 hydroxyvitamin D, and perhaps the activated vitamin D level sometimes. And then if the creatinine level is high, or like you basically have renal dysfunction already, then you may want to be checking BUN and other sort of renal labs. And then like sodium, if you're on hydrochlorothiazide, that medication can actually drop the sodium level sometimes. So kind of everyone always asks, like, how often should it be done? And there's sort of different monitoring intervals for every patient for each of the tests. And it really depends on how stable you are individually. And it changes over time. Within the first, these are just general suggestions, within the first 3 months post-op, I would say you should be getting these, at least a calcium and albumin check every 1 to 2 weeks as you're tapering the calcium or trying to. And then if the calcium is low or you're feeling hypocalcemic, you should also be checking the PTH and phosphorus in conjunction with that. And you're following the PTH trends early on to see if it even is returning. And then you also want to check potassium, magnesium, and vitamin D and monitor these regularly if your calcium is low. Now, if you're permanent or long-term, which I feel like most of us are at this conference, basically when you're having a medication adjustment, that's when it's really important to be checking things more frequently, like weekly or monthly. That would again be the calcium, albumin, phosphorus, creatinine. And if you're stable, these can be spaced out. If you're extremely stable, maybe twice a year even is okay. But that's if you're extremely stable and you haven't had dose adjustments for a very long time. And then if you're having symptoms and your labs are not correlating, then you should kind of check things again and maybe check the ionized calcium, because that, again, especially for me and personally, I've found that correlates better with my symptoms. And then for the 24-hour urine calcium, if you're sort of 3 to 6 months out and you're sort of, again, a long-term hypopara patient, you should be asking for that to be done. And again, that's going to vary whether if it's abnormal, probably every 3 to 6 months for the first couple of years or until things are stable. And then, if everything's stable and your urine calcium isn't high anymore, you haven't had kidney stones, then maybe yearly would be sort of the maximum interval, I'd say. In some states, you can get this basic metabolic panel. I think Dr. Kohlmeyer mentioned this. Remember, it does include all the electrolytes, but it does not include the albumin on the basic metabolic panel, and also it does not include the magnesium and phosphorus. So those would have to be ordered separately. If you order a complete metabolic panel, that will include the albumin, but you'd still have to order magnesium and phosphorus separately. And then vitamin D levels should usually be checked every 6 to 12 months, especially if it's low. If it's low, it's going to be replaced most likely, and you'll be checking it 6 to 12 weeks after replacement. So just again, realize that calcium levels fluctuate throughout every single day, really every minute. But you, like, when should you check it? Like, what time of day should you check it? I think ideally you should check the calcium levels in the morning before you supplements to see kind of, or at least to me, that would be like, quote, the lowest, the lowest level of the day is before you start taking all your supplements, etc. But, you know, is that practical depending on your job, your feasibility of doing it? You know, it may not be practical, but just remember that if you take your calcium vitamin D supplements before measuring something like a PTH level, for instance, then if you took it right before, that may actually also, you know, suppress the PTH level. And consistency in the timing of lab checks is key. So if you check it at a regular interval, regular time, like you always check your labs at this given time, that would be helpful to compare from one lab check to the next. And then PTH levels in the immediate post-op period may be useful. There was a study that showed that those with low but detectable PTH levels in the immediate post-op period had a higher rate of parathyroid recovery compared to those with undetectable PTH levels. And then, of course, like I said, following the PTH levels in the immediate post-op period is really helpful. Now, just a little bit on how to read them, and I think we've probably gone over this before. We don't have to go over it too much more, but just remember that the reference ranges will vary between labs. So a given level, you have to look at it relative to that specific lab. Those are just some examples from Quest labs. And then same with basically all the different labs I mentioned, they're going to have their own specific reference range depending on what lab you got them checked at. So the most important thing, I think, in terms of, like, you know, for the serum calcium, you do have to remember you have to correct it for the albumin. So, and this goes whether the albumin is higher than 4.0 or lower than 4.0. I mean, I think a lot of times doctors only do this when the albumin is less than 4.0. But I mean, a lot of us are, you know, especially if you're post-surgical, you know, from thyroid cancer, for instance, you're somewhat young when this starts, and you know, your albumin may not be low. It's going to be greater than 4 a lot of times if you. And so basically, if your albumin is greater than 4.0, the corrected calcium is going to be lower than it actually appears. And if your albumin is less than 4.0, the corrected calcium is actually higher than what it appears on the lab. And it's based on this formula that I have up there that you plug it in. Just give an example here, like, so this is from myself. You know, I had an albumin of 4.5. My serum calcium was 8.9. It was reading as 8.9. The corrected calcium, when you plug in the numbers into that equation that I said, my corrected calcium is actually 8.5, which is mildly low according to the reference range for that lab. So 8.9 sounded like it was so good, but 8.5 was, you know, actually I was feeling kind of low. And then if your albumin is 3.5, which is a little bit, you know, on the low side of albumin, then as calcium 8.5 actually corrects up to 8.9. So actually, then that's in actuality, your actual calcium level is in the normal range. So, you know, obviously, you know, putting numbers into the equation is kind of complicated. So we have this. You can just kind of Google all the time any calcium albumin correction. Just type that into Google, and this is just an example of one. There's many different ones where you just plug in your actual calcium from your lab and your albumin level, and they'll tell you what your corrected calcium is. And that's what we should always be talking about when we say, quote, calcium levels. It's the corrected calcium levels. Now, there is this ionized calcium, which is basically, it doesn't need a correction factor per se. Like, it doesn't you to, you know, look at what your albumin level is or whatever. It's kind of how much actual calcium you have available to your tissues. The reason sometimes some doctors don't always order is because the handling is like, you need special handling. It's not always possible at all outpatient labs. It's a little more expensive. But I have found myself that Quest actually is pretty reliable on this. If you go to Quest labs, hospital labs are always reliable with it. It comes back with one of the very first things. It's like automatically run almost like a stat lab. It's very quick turnaround, so it's going to be the first thing back. I think it's very helpful, if you're having symptoms that don't seem to correlate, even with your corrected calcium levels. So kind of when you're looking at how to interpret or read them in hypopara, if you're not really sure, like, are you hypopara, you're trying to figure out your post-op, you look for these expected abnormalities in the disease. Is that you're going to have a low serum calcium corrected, you're going to have a high serum phosphorus, and then low or low normal PTH level. And if you're long-term and if you've had high urine calciums, you might have elevated creatinine that would indicate kidney dysfunction, which is not good. And then if you have a high serum calcium level but a low PTH, that could mean either that you're taking excessive amounts of calcium supplements, but you are still hypopara, but you're just taking a lot of calcium supplements, it's gone high, or that perhaps, the PTH might just be low because of the high serum calcium level. So this gets a little tricky when you're immediate post-op, because you're trying to figure out whether your PTH is recovering. And if you're taking too much calcium for what you actually need, that may lead to a continually suppressed PTH, and you sort of have to see as you wean it what kind of happens. If you have elevated creatinine level, like kidney dysfunction, then you're going to need the full BMP, I would say. Kidney doctors always like to see the entire thing. Kidney dysfunction itself can cause hyperkalemia, high potassium, and itself leads to high phosphorus. And then in the BMP, you're going to see whether your potassium or magnesium are low, whether you need to replace with supplements for those. Because again, hypokalemia and hypomagnesemia, it can cause muscle cramps and weakness, very similar to hypocalcemia. And vitamin D, just a little thing on this that, I think Meyer actually just showed a slide that said the Institute of Medicine says that, greater than 20 is, quote, okay, but I think we all agree that the 25 hydroxyvitamin D ideally should be over 30. That's what's considered more optimal or sufficient. I think people who have some immune dysfunction, I'm a rheumatologist, so I take care of a lot of people with autoimmune and immune issues. And I think, there are a lot of times they'll do better if it's 40 to 60. A lot of people with fibromyalgia also feel better when it's 40 to 60. And again, you don't want to go too high, of course, on it though, because then that can lead to hypercalcemia. The 125 dihydroxyvitamin D is the activated form of vitamin D. It's the form that is calcitriol. That's the form that's needed for calcium absorption from the gut. PTH is needed to convert the 25 hydroxyvitamin D or parent vitamin D to the 125 dihydroxy, the activated form. And so if you're hypopara and you're on calcitriol, this becomes sort of very difficult to interpret, because it's going to depend on how recently you took your calcitriol. You may sort of just be measuring your calcitriol dose in a sense. So I think it's not generally checked. But I think, if you're having, for instance, I don't know, like high calcium and you're not really sure why, and, it might be worth checking this as well. I did mention hydrochlorothiazide. There's a blood pressure medication that's used to help lower the urine calcium level in hypopara patients. And potassium can go low from this medication. It's just a side effect, basically, of the medication. So you may have to replace the potassium, either take potassium supplements or eat potassium-rich foods to help combat this. Or you may, like me, go on to a combination. And there's a triamterene hydrochlorothiazide, which is called diazide, that can help that help bring up the potassium level down. And then other potential side effects of hydrochlorothiazide include, like, it can actually, cause high calcium in normal people. For hypopara patients, I don't think it ever caused out true high calcium, but it will help with the calcium reabsorption from the kidney, so it decreases the urine calcium level. Like I said, it can cause low sodium. It can sometimes cause low magnesium. Actually, it can increase the uric acid level, so it might increase your risk of gout to some degree. Okay, and then I think I'll pass it over to my sister now, the nephrologist, to talk about the urine test and imaging for kidney stones. So. Okay. Hi, so I'm happy to just go over some of the urine tests and imaging that we would recommend to either look for or monitor people who have kidney stones or who are at risk for kidney stones. So what urine studies should you monitor? Well, first of all, as my sister mentioned, one of the main things is the 24-hour urine calcium and creatinine. It's very important to know and monitor periodically in long-term hypoparathyroidism, especially if you've never done it before and or you're still with symptoms despite calcium levels that are at goal. Reference ranges vary by labs, but for example, reference ranges from the Mayo lab suggest that a 24-hour urine calcium should be between 20 to 275 milligrams for females and 25 to 300 milligrams for males. Ideally, you want to keep that urine calcium level less than 300, and actually even less than 250 for the most part. Sometimes we'll accept up to 400 milligrams, but that's kind of pushing it in order to prevent the risk of kidney damage or kidney stones. The main recommendation that I always make to all patients who are at risk for kidney stones is to just keep really well hydrated. So I recommend drinking at least 2 to 2.5 liters of fluids per day. And a good rule of thumb is that when you look at your urine color, it should be very light to clear in color. If it's becoming sort of darker yellow, it's basically an indication that you're not drinking enough. So you want to just keep drinking, if you see it getting darker. In certain situations, for example, in hypomagnesemia, checking a urine magnesium may also be helpful. So other urine studies we get oftentimes is a simple urinalysis, and that gives us sort of a crude estimate that whether or not you have blood in the urine or certain crystals that can be picked up. If you have kidney dysfunction with an elevated creatinine, we'll also oftentimes order a urine protein to creatinine ratio, which is basically a crude estimate of how much protein is in the urine, or a 24-hour urine protein, which is sort of a more accurate measurement of that. If you have a history of kidney stones, I always usually recommend getting a formal 24-hour urine supersaturation analysis, which is also called a litholink study. And it's also just a 24-hour urine collection, but it's usually done by a special company called Litholink, where they actually do a whole slew of different chemistries that give us information about what kinds of kidney stones you're at risk for, and helps guide me as a nephrologist as to what we can do to help you prevent further kidney stones. So this is just a table that shows kind of a breakdown of all the different kinds of kidney stones, or like the main types of kidney can get. Calcium oxalate kind of leads the list there. It's actually the most common type of kidney stones, and then followed by calcium phosphate stones. There's also uric acid stones, struvite stones, and cystine stones. Uric acid stones are often people who have like a history of gout, for instance. Struvite stones are oftentimes people who get UTIs, like urinary tract infections, kind of cause these struvite stones, usually from a bacteria, special bacteria lead to that kind of stone. And then cystine stones is almost like a genetic form of kidney stones. People will often have a family history of stones if you have that type. It's very rare. So in hypoparathyroidism, the main kind of kidney stones we worry about is the calcium-based stones, obviously. So calcium oxalate, as I mentioned, is the most common. These are stones that actually form in acidic urine. So acidic urine is like low pH, low urine pH, meaning around 4.5 to 5.5. You also get an increased risk of these stones if you have low citrate levels in the urine or hypocitraturia. Calcium phosphate stones is the other major type of calcium stones. These form in basic urine or high urine pH, typically greater than a pH of 6. These can be classified as either bruchite stones. These are really hard, brittle stones that are not easily treated by lithotripsy. Hydroxyapatite stones. Hydroxyapatite is actually the same crystal phase that you see in bone. And then calcium carbonate phosphate. So if you see, like for instance, if you have a stone and they analyze it and they list it as either bruchite or hydroxyapatite or calcium carbonate stones, like these are all classified as calcium phosphate stones. And this is a little picture of what a calcium oxalate stone might look like. As I mentioned, the most preventable cause is dehydration and low urine output. But other factors can also increase a person's risk for calcium oxalate stones, including a high sodium diet or high oxalate intake or high protein intake. So general recommendations to prevent calcium oxalate stones are not only drinking lots and lots of fluid, but also kind of limiting your salt, protein, and oxalate intake. So these comprise 60 to 80% of all kidney stones. So if you don't know what kind of stone you make, this is probably the kind most likely you're making. And then these are examples of calcium phosphate stones. As you can see, there's a whole bunch of different kinds. They all look a little different. And then here are crystals that I wanted to show you in the urinalysis. So if you give me a random urine sample, I can look at it under a microscope and see whether or not you're forming these crystals. And this also gives me an idea of, what kind of stones you might be prone to making. So if your urine shows crystals like on the left-hand side, these are calcium oxalate crystals. We call them like envelope shaped. And then on the right-hand side, the calcium phosphate crystals kind of look like almost needle shaped or large flat shaped plates or wedge shaped prisms. So moving on, like what kind of imaging do I need to look for kidney stones? Well, first of all, we can get a kidney ultrasound that provides detailed views of the kidneys and is actually the safest kind of imaging study to get because there's no radiation exposure at all and it's very non-invasive. It looks for hydronephrosis, which is swelling of the kidney due to obstruction due to stones. And then it can actually pick up on actual kidney stones and calcifications in the kidneys. And also we assess for kidney sizes, whether there's cysts in the kidneys. We also look at the density of the renal parenchyma and cortical thinning. These are things that, if you have reduced kidney function, these things might be abnormal as well. You can also look at a CT scan, especially if you have kidney stones. A CT abdomen and pelvis without contrast is kind of what we would recommend. It provides evidence of kidney stones along the entire urinary tract, meaning the kidneys all the way down, including the ureters and the bladder, to see if there's any stones along the entire urinary tract. It is the most sensitive test for detecting kidney stones, approximately 95% sensitivity, and can detect as small as 3 millimeters, 3-millimeter stones on that kind of scan. Sometimes we'll get an abdominal X-ray, like oftentimes we can start with an abdominal X-ray or a KUB. Only really reveal calcium kidney stones, but not other types, such as the uric acid stones I mentioned. So here's an example of a stone that we see on an ultrasound. It'll look sort of more bright white on it with shadowing behind it. And then here are examples of what stones would look like on a CT scan. They're also, as you see, the arrows are pointing to these bright white, like calcifications. These happen to be, within the urinary tract, not even in the kidneys per se. And then here are how stones might look on an X-ray. So like, as I mentioned, these would be calcium-based stones that you can pick up on X-ray, and they're also like the white little tiny stones that you see on both sides there. So what imaging is preferred for kidney stones? I kind of touched on it, but initial screening for kidney stones, if your urine calcium is high, might start with an abdominal X-ray or a kidney ultrasound because they're the easiest, cheapest, and sort of simple and safe to do. If you're symptomatic though, and you have like flank pain or back pain that is just excruciating and there's a high suspicion for kidney stones, that might be a time that we actually just start with a CT abdomen and pelvis without contrast. Also, if you have high stone burden or recurrent kidney stones, we oftentimes can even just monitor with a CT abdomen and pelvis because that immediately tells us is your kidney stones in the kidneys and along the entire tract. And generally, I recommend monitoring every 1 to 5 years. If you have active stone disease, I'll check it usually even more often than that, like every 6 months, like if you're an active stone former. So the last thing I sort of wanted to talk about is a 24-hour urine supersaturation test. And what exactly is this? So it measures a panel of chemistries in the urine that are important in kidney stone formation. As I mentioned, the most common form is the litholink test. It assesses for risk factors for calcium oxalate versus calcium phosphate versus uric acid stones. And on this panel, it basically gives information on whether or not you have a high risk for calcium oxalate stones. And that would be if your results show a low urine pH, like less than 5.5, high supersaturation for calcium oxalate, a high urine calcium level. As I mentioned, on the litholink tests, they say that greater than 200 for females or greater than 250 for males is actually considered high or a higher risk. And then hypocytraturia. If you have results that show the following, you'll have an increased risk for calcium phosphate stones. These would be high urine pH, greater than 6.0, high supersaturation for calcium phosphate, a high urine calcium again, or high urine phosphorus. So how often do I need to do a urine supersaturation test? Well, basically, if you have no kidney stones ever and you've never had any, no one in your family even has any, you may never need to do it. However, if you do have like even just one episode of kidney stones, or especially if you have a second episode, I generally recommend doing this test at least once, and then you may want to repeat it yearly, just to make sure that you're kind of doing well on your fluid intake and your preventative measures. And then if you're an active stone former with multiple stones or more than 2 episodes, you may need to repeat this every 6 months or even more frequently if you're changing therapy. So if you're somebody who, your nephrologist has put you on Uracit K, for instance, you may need to be checking this even every 3 months, if you're making changes in that Uracit K dose. So this is just a list of the urine litholink test parameters that actually is included in the test. It gives you the total volume that you made, the calcium, creatinine, citrate, phosphorus, pH, sodium, urea nitrogen, the actual oxalate level, chloride, ammonium, magnesium, potassium, uric acid, sulfate, and then it gives you a cystine screen, and then saturation calculations for the most common kidney stone types, which would be the calcium oxalate, calcium phosphate, and uric acid. So I would say that the supersaturation calculation is kind of a nice perk for the litholink study in particular, because sometimes you can have like a normal uric acid or a normal phosphate level, even calcium level in the urine. But if you have a high supersaturation for that type of stone, that's kind of even more important actually than just the actual, say urine calcium alone. So the process of doing a 24-hour urine litholink test is that basically your doctor will order it, and then the company will actually send you a urine collection kit to do at home. You view or read the instructions on a proper collection method. I've included a link here for the actual video that they give. It's pretty straightforward. I've never had patients say that they didn't understand how to do it. And then you send the urine sample back to litholink by mail. And now I'm going to send it back to my sister to finish up about how to discuss these tests with your doctor. So like I said before earlier in the talk, that there are different, practice styles of different doctors, different endocrinologists, and certainly different experience levels of endos with hypopara specifically. Also depends how your doctor speaks to you. They may use more medical language versus less medical language. If you understand a lot of medical language, I guess I would encourage you to, let your doctor know they can actually talk in a more sophisticated manner with you. And then to me, the biggest thing is, are they sort of rigid algorithm type people, or are they going to be more flexible in working with you, considering you know your body the best? Your body's constantly in flux with living with hypopara, and are they going to engage your patient preferences? Of course, I think this latter is the better way to go. Find a doctor who can work with you. Don't be afraid to ask questions. They shouldn't make you afraid to ask questions. You shouldn't feel that way in your appointment. If you're uncomfortable, you should consider second or third opinions, especially with endocrinologists who have more experience with hypopara. However, I will give a caveat as a doctor myself that I don't think you should give up after one visit. I think you should at least probably give a doctor a chance of 2 visits at least, to kind of get that sense of like, maybe on that first visit, they were just really preoccupied with trying to gather your history. Depending on how much history you have, it can be overwhelming. They may be time crunched, whatever else is going on that given day. And so if the next visit and you're following up and, you just get a better sense if you can click or not, right? Doctor shopping, like if you go to too many doctors, that doctor will see, oh, you've been to like 3 other people. And, then that doctor might think, well, this patient is just completely too hard to please. She's going to be, quote, high maintenance and things like that. So just be careful in terms of how many opinions you get. But at the same time, I do think, especially with this rare disease, that it's worth considering if you're not comfortable with your current endocrinologist. I'll just share that I did, of course, go to a second endocrinologist who's a hypopara expert after my initial one. I wasn't happy with. So, I mean, that's me as a doctor, So, and then you should establish what kind of is going to be your acceptable goal calcium level. I think that's probably one of the most important things in discussing what's going on, what you're going to do, how you're doing, quote unquote, because, there's this quote ideal goal calcium level, which if you're not on PTH replacement, I mean, that para's off, is not easy to get anymore by and large. And so if you're just on the standard, calcium constant trial, they're going to say your goal level is something like 8.0 to 8.5, quote, low, normal, or mildly low. That's kind of because they want to help protect your kidneys and, they want to have your urine calcium be less than 300, and keeping your calcium in the quote low normal range oftentimes allows that balance. But if you're having too many symptoms, as I did, as a lot of us do, I think, at that sort of low normal level, you have to balance that with what is your actual 24-hour urine calcium level. If your 24-hour urine calcium level is okay, less than 300, maybe you can go ahead and push the supplements, et cetera, to let your goal calcium, serum calcium ride higher. If your urine calcium is more than 300, then, kind of maybe there are other things you can do to help get it down, like hydrochlorothiazide, et cetera. And I think I definitely agree with whoever said in the audience and earlier that a fair number of hypopara patients, especially post-op hypopara patients, will feel better when their calcium level is where they were pre-op, right? Like, so it's going to be higher than 8 to 8.5 because that's not actually a normal person before they went for surgery. That's not usually where they sat. They usually sat around 9, 9.5, et cetera. So, and that's kind of what I just said there. And then you should discuss your symptoms with the doctor, before talking about lab work. I think it should be really important to share with your doctor what kind of symptoms you're having. They may be hypo or hypercalcemic symptoms. You can see here that a lot of them overlap. Usually like the tingling, the paresthesias, the numbness, muscle twitching, those are going to be hypocalcemic symptoms. Fatigue and feeling weak is going to be, you don't know, like, is that hyper or hypo? If you're feeling nauseous, vomiting, constipation, that's usually hyper. If you're feeling brain fog, like bone pain, that is probably hyper, but brain fog can also occur with hypo. So a lot of times the symptoms don't tell you completely, but at least they'll know kind of what you might be experiencing more likely. And like I said, I think you'll want to talk, if you're feeling hypocalcemic, you'll want to ask the doctor kind of, can you take extra supplement doses, extra calcium? If so, how many, how often, and how long? What about the calcitriol? Like if you're on a given calcitriol dose, should that be increased? Could you take an extra calcitriol dose or not? Calcitriol is very potent. Be careful. It can raise your calcium a lot more than just taking an extra calcium supplement. But if either of the above are permitted, then kind of the next question you need to remember to ask, because they might not automatically tell you, you have to ask, like, when should I next check my 24-hour urine calcium then? If we're going to increase these things and try to help me get out of hypercalcemic symptoms, when should I get my labs checked again? When should I get my 24-hour urine checked again? If the doctor is absolutely unwilling to hear you out and acknowledge that these symptoms are in fact hypocalcemic symptoms, regardless, depending on wherever your level is, that's again where I, like if you're hitting a wall, that's where sometimes you may consider a second opinion. You may consider going on off-label therapies at this point, like Futeo, like clinical trials, like the TransCon trial, et cetera. So obviously in the past, that would be the point to put people on NatPara, but NatPara is not readily available anymore. And then you kind of want to discuss and observe what things trigger hypocalcemic symptoms for you. When you're under sort of duress and things that trigger your symptoms, then sort of ask to have those labs ready to have to be checked, quote, as needed. And usually that could be even like weekly as needed or whatever. And for me, things like illnesses, infections, exercise is a huge one. It's really difficult to do heavy exercise anymore. Menses is a huge one. I think I've heard this from many women. Stress, whether it's physical or emotional, travel, for me, like time changes, even weather changes I've heard for some people. I don't think it affects me as much, but these are all things that can trigger symptoms for people. And again, asking kind of, is it okay to take extra calcium for these events and how much, et cetera. When the hypocalcemia is really severe and it's an emergency, I think Dr. Kohlmeyer touched on this, so I won't go too much, but basically it's tetany, like full body. You yourself are not able to communicate at that point. You need to have that, quote, advocate or somebody helping you, taking you to the ER, et cetera. This includes seizures, arrhythmias, laryngospasm, all of these things. And this usually occurs when the calcium is severely low, again, usually less than 7.5, maybe even less than 7, and that's when you need the calcium level stat, you need the IV calcium infusion immediately, et cetera. If you know this has happened to you before and you know what your prodrome was, quote, something that you felt right before this happened, that is helpful to keep a track of and like communicate that with your loved one, your providers, et cetera, so that if that happens again, action can be taken even more quickly. So if you have serum phosphorus level being high, that's where dietary changes, and this is where sometimes even nephrologists are helpful just for this because they deal with this all the time in chronic renal disease patients. But basically, you want to get information on low phos diets, and there's even like phos binders. Again, these are in CKD, chronic kidney disease patients often take things like phos, Renagel. Sometimes these things are used in hypopara patients to help bring down the phosphorus level. PTH replacement therapies definitely lower serum phosphorus very well. So if you're able to get on one, like Futeo off-label, or if you're on the NatPara, SUP, et cetera, that'll help. I just listed some of those foods there that are high phos foods, so you want to avoid those to be on a low phos diet. And then it's important to keep the diet consistent with regard to calcium-containing foods. So like, your doctor may even ask you, you might want to share with your doctor, like, you always usually eat this many dairy products, et cetera. And so if I think for me, this is a thing when I'm on travels, I can't get dairy products as easily. And I think that's partly why I end up feeling more hypocalcemic, et cetera. On average, each dairy serving has about 250 to 300 milligrams of elemental calcium. So kind of you can think about that in your head, I guess, like if you're not eating your usual yogurt or whatever, then maybe it might be reasonable to take that extra little bit of calcium. So just finally, some other lab tests that I do think is important to kind of mention here, because a lot of us, especially post-surgical hypopara patients, came into this because of thyroid. I know we always say hypoparathyroid is not the thyroid, but a lot of us do actually have hypothyroidism, either post-surgical induced or autoimmune, et cetera. And so these symptoms can also overlap. So hypothyroid symptoms include fatigue, weight gain, weakness, cold intolerance, dry skin, hair loss. And hyperthyroid symptoms would be like palpitations, anxiety, increased heart rate, but it can also cause fatigue. I think a lot of doctors assume that hyperthyroid, you're going to have increased energy, and that's just absolutely not true. I mean, I've been both ways, of course, with my TSH numbers, and when I'm hyper, I'm also feeling more fatigued and kind of just not right, feeling sort of weak and not myself. And then you'll also be sweaty and heat intolerance, increased bowel movements or diarrhea. it's unclear whether hypopara itself interacts with thyroid symptoms. I think a lot more studies are needed on this. Hopefully we'll hear more about it later in the conference. So you do want to get these thyroid labs checked, especially if you're post-surgical. So TSH, and then also the free T4 and free T3. The TSH is the most sensitive marker that shows kind of, if the TSH is low, then you're relatively hyperthyroid. If your TSH is high, that's like you're hypothyroid. This is like the first thing. And then free T4 and free T3 are important to see kind of, if they correlate with where the TSH is sitting. And the free T4 and free T3 are probably a little harder to interpret because they probably fluctuate more depending on when you actually took your last thyroid dose. So I know sometimes people aren't checking this, or the free T4 only gets reflexed if the TSH is abnormal, but I like to have all three checked. I ask for those. If you have any question about autoimmune thyroid disease, you could get the thyroid antibodies like the TPO and thyroglobulin antibodies checked. If you're a thyroid cancer patient like myself, you will want to be monitoring your thyroglobulin and the thyroglobulin antibodies on a regular basis because they are actually sort of disease markers for the thyroid cancer. Now, as a rheumatologist, as you can imagine, I get a lot of consults just for fatigue or feeling weak, muscle weakness, and these are symptoms that happen in hypoparathyroidism. And so if you have any family history of autoimmune disease, or you do have some question of an autoimmune or rheumatologic disorder, the basic labs you'd want from that standpoint are actually muscle enzymes, CK and aldolase. That as a first pass will tell you whether you have sort of inflammation in your muscles. If they're normal, it's very unlikely that you have inflammation in your muscles. Same with SED rate and CRP. These are inflammatory markers. They're very non-specific though, but you could ask for those. Vitamin B12. So vitamin B12 deficiency can also cause numbness, tingling, paresthesias, fatigue. So I think that's important to rule out in everyone. The vitamin D, we've kind of talked about that. And then iron studies, if you're a woman, heavy menses oftentimes causes iron deficiency. That will cause fatigue. And the CBC, of course, to rule out the anemia. And then just finally, of course, I can't help but talk about this as a rheumatologist. Fibromyalgia syndrome, like, do hypopara patients have fibro? Is fibro just, part of being hypopara? Is it, can you just have both? I think you can just have both. Fibro is extremely common, and it's going to kind of mimic a lot of the hypopara symptoms. And it's again, quite common in women, young, middle-aged women. It's a syndrome of widespread pain, a lot of times muscle pain, fatigue, poor and unrefreshing sleep. And then on exam, it's actually very easy to diagnose. It's like you just have a certain number of soft tissue tender points on exam. One thing I always like to ask patients is like when someone presses you or say your cat, gets on you, does it feel like it leaves a really prolonged bruise? It's really painful. And that kind of a thing is sort of, that's what we hear in fibro. There's no one lab test that's diagnostic with fibro. Actually, labs are served to exclude other diagnoses. By definition, they usually are normal. And primary care physicians can manage this just as well as any rheumatologist. If you have a lot of accompanying conditions like migraines, irritable bowel syndrome, anxiety, depression, TMJ syndrome, that oftentimes will correlate with having fibro. And then to treat this, you often do like a low impact aerobic exercise program. Things like gabapentin, Lyrica, Cymbalta, Savella can be used to treat it. So, and again, these are just tender points that people usually, will press on when they're examining you to help diagnose the fibro. So just in conclusion, we want to impress upon you that monitoring calcium levels regularly is very important in hypoparathyroidism. When measuring the calcium levels, you want to correct for the albumin level and or measure the ionized calcium level. It's also important to remember to check your phosphorus. If you're immediately post-op, the PTH, also the creatinine, potassium, and magnesium. The 24-hour urine calcium should be kept less than 300 to 400 milligrams to prevent long-term kidney damage. And when you discuss your lab results with a doctor, include a discussion of your symptoms and goals, as well as your long-term risk based on the results. And you may want to consider other labs to rule out thyroid or other contributions to muscle weakness and fatigue symptoms. I do want to acknowledge Dr. Bart Clark and Michelle West, who've been instrumental in this talk in the past. So
All right. Let's give it up for the Liang sisters. Thank you. All right, Kelly and Kim, if I could have you guys kind of scooch together so we can put you up on the screen and ask some questions. Hey, there they are.
Hi.
Everybody's waving to you. All right, so who has questions out there? Where's Michelle?
Okay, I'll start with one from our virtual audience. Will kidney stones cause permanent kidney damage or failure if left untreated?
They have the potential to, like if it gets blocked. So that's where the imaging becomes really important. If they're just sitting in the kidneys and they're like really small, they don't by themselves cause kidney failure.
Anybody in the room have questions? Bob? Let's get your microphone there real quick.
Hi, I'm John. When you do a 24-hour litholink panel, as a hypopara person, do you interpret that differently than the general public? I mean, how would you adjust for being hypopara?
Yeah, I mean, the interpretation isn't really different from the general population, but kind of thinking about balancing that actual urine calcium level with your symptoms, as my sister talked about, is probably where the management becomes a little different. So if we have to accept, for instance, a urine calcium that's a little higher than like the 200 or 250 in order to keep your symptoms controlled and to keep your serum calcium levels adequate, then we might do that, especially if your kidney stones aren't like a major issue. So I might be a little bit more strict in terms of where I keep those urine calcium levels in a hypopara patient, in a non-hypopara patient compared to somebody who is hypopara. So.
Thank you. That was great. I just can't believe you're twins and you know so much about this. This is fantastic. We're all going to be asking you. So we learned that in ADH1, 47% of patients have kidney complications with normal urine calcium, which to me is surprising. So do we know that? I mean, I know when we follow surgical hypopara patients long term, we know how frequent the kidney problems are. But what would be your explanation why it would hurt the kidney if the kidney's not spilling a lot of calcium?
Yeah, but do you know if like the serum calcium levels are high or low or normal?
No, so this would be surgical hypopara patients with fluctuating calciums like we all know, but without a urine calcium over, let's say, 250 milligrams, should we still worry about kidney problems? I mean, I would think that's the etiology of why it happens. We shouldn't worry as much, but what I'm being taught and what I've learned in the past is we still worry, which is why they need why we need parathyroid hormone replacement. But what would be the other explanation? Why would it hurt the kidney if the kidney's not spilling calcium, I guess is my question.
Yeah, well, anytime that you're hypercalcemic, that can cause like volume depletion and basically cause kidney damage and kidney failure in a sense, like hypercalcemia. So if you're having
over-treating by mistake, that makes sense.
Right. Like if you're sort of intermittently over-treating with hypercalcemia during large portions of your life, for instance, getting dehydrated because of intermittent episodes of hypercalcemia, I can foresee that as causing kidney damage even without like 24-hour urine calciums being abnormal at all. I don't think that.
Would you be okay with me letting my patient's calcium, let's say, be 9.4, like some people really like, if their urine calcium's less than 300? And should I do 24-hour urine on those patients more frequently to make sure I'm not hurting their kidney without knowing it?
Yeah, I think that would be reasonable, like if the 24-hour urine calcium is less than 300 and the serum calcium is like 9.4. That's still within normal, so I would accept something like that. It's when the serum calcium gets actually higher than normal that we start to worry that by itself can cause kidney damage. It by itself can cause kidney failure, to run the calcium levels in the blood too high. So that example that you gave sounds like a reasonable sort of balance, if somebody is sort of running that kind of urine calcium being low enough, but keeping their serum calcium higher than, that 8.5 range that, the guidelines might suggest. I don't think that by itself would be, dangerous for the kidneys per se. But you just have to kind of monitor things over time and make sure that you're not accidentally, going over like 10.5 or whatever, sometimes.
Okay, Michelle, you have one more?
Yes. How much can what a person eats within 24 to 48 hours before their blood and urine tests impact the results?
Well, I think from the serum calcium standpoint, like it can affect it quite a bit. Like I think if you just took your calcium, and you went to the lab, within a couple hours after that, you're going to have to take that into account. Even like dairy products, like if you just eaten a high dairy thing. So I think it can affect the serum calcium quite a bit. And then for the urine, I think the urine ones are more long-term, kind of reflects your diet over time. I don't think you can change it that much just in that one day, for instance. It kind of is more reflective of what you've been doing. That being said, like I don't generally recommend doing like a litholink study, for instance, in the hospital when you like not eating your usual diet, for instance. So I mean, it can affect it to an extent, but I think it's more reflective of just kind of overall what kind of calcium levels you've been running and how much how much calcium you're spilling in the urine over time.
Okay, and then we have one more in the room, and then we'll have to call it.
I'm just wondering, because one of you's a rheumatologist and one of you's a kidney doctor. I have chronic kidney disease and I have autoimmune disease and I'm post-surgical. I have a big problem getting my doctors to communicate with each other, no matter how hard I try or what information I give. Any advice?
Yeah, that's a really, really great question, actually, because it's relevant to so much of medical care in general. I think as a patient, you should just point blank ask your doctor to, call or, talk to the other doctor, whatever, and get back to you, so-called, on what was the upshot of that conversation. Because if you sort of ask for that to be done and then that's sort of on their to-do list that they have to do it, then it'll get done. If it's not something that is a thing that you specifically asked for, then what happens as a doctor is that you are super busy. You finish your clinic, then you do your notes. That is an extremely long day. By the time you're done doing your note, of course, it's not time. You will not be talking to another doctor. That's way after hours. You don't even know if they're awake. So then all you do is you send your note to them. Like you just say send the note to them, and then your secretary may send that note or not. I mean, you don't know when that's going to happen. If it happens, sometimes glitches happen, and then you never know if that communication ever happened. So I think if you sort of ask your doctor to communicate, kind of say, I'd really like if you could talk to my nephrologist or whoever, or my rheumatologist, and have that conversation happen, and then either in a couple of weeks, do you mind if I check back to see what you found out, or at least by the next visit, can we discuss what you all what was your conclusion after talking? Just kind of point blank ask it. I don't know if you have any other thoughts. How did you? I think that that is a common problem, and like she said, and I think that just actually asking each of those, your nephrologist and your rheumatologist, each of them, to don't even just trust like, okay, well, I asked my rheumatologist to, ask your nephrologist then to also reach out to the rheumatologist. And then if you have both of them, hearing your wishes, then at least one of them hopefully, will come through and you'll get some connection between them. And then if you do have the ability to send messages through like an online portal or something, you can easily just within a week or so, just message either or both of them asking, so did you get a chance to talk to the other doctor and what did you decide? Do you agree on the plan? And, that usually works. Yeah, I've actually had some patients do that where they send me the same exact portal message that they sent, say, their pulmonologist, or, they want to know the same question from both perspectives, right? And they literally send the exact same message to both. And then I can see in the portal, what did the lung doctor write back to her? Oh, that's helpful for me, and so that's kind of a nice way to kind of communicate without making the doctors find the time to somehow connect by phone. I don't know if that's helpful.
All right. Thank you, ladies, so much. It's so great to see you. Thanks for your presentation today.
Thank you. Thank you. Nice to see you. Thank you.
Okay, so we are going to take a break until 3:30 for our next presentation, and the hotel does have a sweet snack out in the lobby if you want to grab something and then come back in. Thank you. Welcome back, everybody. Hope you enjoyed that little break we had. I'm really happy to present to you our next medical advisor speaker. I got the pleasure of spending some time with Dr. Warren this year. He is an endocrinologist at the Greenville, North Carolina Physicians East site. This is a multi-specialty group where he serves as Director of Clinical Trials and Director of Laboratory Services. And I was really excited to bring him here because he has participated in all of our clinical trials for HypoPARA. I thought he would be a great asset to be able to hear about the different things from a patient perspective and from a physician perspective. So please welcome Dr. Warren.
Thank you. When she asked me to speak, I said I would be glad to, but then I didn't realize I'd be following Dr. Kohlmeyer and Crucifidis. It's a little harder show to follow. My disclosures, I receive support from Ascendus, Amulet, Calcilytics, and Takeda, and maybe MBX in the future. We'll see. As you said, I do clinical trials. I've done all the trials, the HypoPARA in the last 10 years, which is great because you get to learn about this community, and I think you have a great association here. So again, I was asked to talk about clinical trials. This is a pretty nebulous thing to talk about, and so I thought what I would do is, talk about what they are. Why do we have them? Why should you consider participating? And then how to participate. But first, I'm a little bit of a history buff, so if you'll indulge me a little bit, we'll go back a few years, back to 1796, when there were vaccinating against smallpox. Edward Jenner was vaccinating this boy. He doesn't look very excited about it, and of course, he was not giving much assent, and the parents were getting much consent either, but those were the days. And then the first randomized trial was ascribed to James Lind. He was a Scottish physician in Edinburgh. And after the first circumnavigation of the world, they lost about 1,400 sailors. After 2 years to go around the world, 1,400 sailors from scurvy. That's about half of this number of sailors. So imagine that. Go around the world, you lose half of your sailors from scurvy. And so they didn't really know how to treat it. There was some indication that perhaps ascorbic acid would be good. But so he did a clinical trial with 12 people. So he had 6 groups of 2 people. Some of them get barley water, some of them got some vinegar, some of them got rum. And then then a group got 2 oranges and a lemon. The trial ended after 5 days because this fruit was consumed. But nonetheless, by the next week, the two sailors who got the oranges and the lemon, their scurvy was cured, and they were able to go back to work. So after that, of course, so now we have every ship would have limes in their hold, and that's why we call sailors limeys. So fast forward now to the 20th century, and one of the most infamous trials of there was a Tuskegee study of untreated syphilis in black men. This was a 40-year trial by the Public Health Service. They took 400 impoverished black men in Alabama and who had syphilis, and they wanted to see what's the natural history of syphilis. So it wasn't really recruiting. They weren't really told why they were in this study. They weren't really told anything except that they were getting treated for some disorder, and they weren't really told anything. And this trial went on for 40 years, and even after penicillin was discovered in 1947, these people were not treated. So after 40 years, one of the new scientists said, it sounds like a long time not to treat anybody. So he went to the director of public health and said, shouldn't we stop this trial? And they said, no, we shouldn't. We still want it to go on. Well, he leaked that to the press, and of course, the trial was shut down. And of course, now that's why there's a lot of distrust about public in the black community about clinical trials, but this led to a big brouhaha and led to new laws and regulation to protect subject rights, and that's where we are today. Now we have something called the ICH, which is the International Council for Harmonization of Technical Requirements for Pharmaceuticals for Human Use, ICH. And that's the basically playbook we all go by, so all the pharmaceuticals are going to have the same guidelines. And in that publication, it specifically says that the subject safety is responsibility of four groups. One is the principal investigator. That's the person at the site who has signed a form with the FDA, said they're responsible for everything goes on that site. So that would be me at my site for that particular study. So I am the principal investigator. He or she is ultimately responsible for the safety of that person. So if I see something's going on, or I have to break protocol, take them out, or whatever, the safety is ultimate. That's really the most important thing we're looking for. But also there's the institutional review boards. Institutional review boards are, they oversee these trials. They may be part of the institution, especially an academic institution. At a private practice, they're probably using a central institutional review board, but they're looking at the safety issues. And usually on the informed consent, you'll see that the institutional review board name will be on there, and if you have any concerns about your rights being violated, you can contact them directly. Also the trial sponsor, meaning the pharmaceutical company, of course, they're responsible, and also the FDA. Of course, the FDA is going to look at, point fingers down the line if there's a problem. But the FDA is really want to make sure that the drugs are not only effective, but safe. And I think that and they've done a really good job. I think we have a really good system now. So I think it's come a long ways from the Tuskegee days. And as a result of that experiment, 100 people died of syphilis, 100 of those men that started, and you had many wives who had it, and several children who had neonatal syphilis. All right, so what is the purpose of a clinical trial? Well, it's to evaluate the safety and the efficacy of a medication or a device. So everything you have and all the prescription drugs you have or using has gone through the same process to get the approval by the FDA. You have to have this. The FDA mandates it to be able to market your medication or device. There are different phases, clinical trial phases, 1 through 4. Phase 1 is usually a very small trial, 20 to 80 patients, addressing the safety of the medication. And if that looks safe, they go to the next phase, looking at dose finding, look at the dose effectiveness. So again, a small trial, usually less than 100 patients, establishing preliminary safety and dose effectiveness. Now, once they do that, they say, well, it looks pretty good. Let's go to the next phase, and we'll enroll a much larger study. So it's a final confirmation of safety and efficacy, and that's required by the FDA for approval. Usually, those trials can be as many as, it can be tens of thousands, or it can be, depending on the disease state, 100 to 200 patients if it's a rare disease. And there's a phase 4, which is a post-FDA approval. So if you have a drug, you want to expand the indications for that drug, you may want to do a phase 4. You want to look at other properties of the drug, you can do a phase 4. So those are the 4 phases. Most of the time, you're mostly be involved if you're going to be involved in studies, either phase 2 or 3. And I forgot to actually show, with a show of hands, how many people have participated in clinical trials? So a lot. Good. So hopefully this is nothing new for you. All right. So what kind of types of trials are there? There are observational studies. That's to help learn more about the natural history of condition. There's also randomized controlled trials when the investigational product is measured against an active comparator or a standard of care, like with HypoPARA. Since we don't have a active comparator available to us, the standard of care would be calcitriol and calcium, so that's the comparator. They're also classified by the purpose, either preventative, interventional, diagnostic, screening, genetic, quality of life, epidemiological, or expanded access or compassionate use. So why should you participate in a clinical trial? Well, you might want to learn a little bit more about your condition, perhaps. Maybe you want to help develop new medications and treatments for you and your posterity. Or I have a lot of folks that, I have some folks in calcilytics trial that doing it because their kids, to help their kids, that would be a treatment available for them. Or you might want to do it because you have an early access to a new medication. So, for example, Sendus has that available in the early access program. So it has to be, because it's not approved, it's part of it's still considered part of a clinical trial, and it goes through IRB approval, et cetera. So you should always have some concerns when you participate in a clinical trial. You should think about the side effects of the treatment, the time involved and travel required, often, and especially in rare disease states, you may have some travel because there are not but so many sites. And so there might be some travel involved. Now, usually your travel expenses will be reimbursed to you by the sponsor. There will be a small amount of stipend for your time, but not enough, obviously, to make up what you would have lost at work. But there is some traveling required in most studies. And also there is some responsibilities you have of taking the medication, doing what's required in the study, where they're keeping a diary of your calcium intake, your symptoms, et cetera. So there is some things you have to do when you agree to do this. Also, it's a placebo versus investigational product, and for hypoparathyroid studies, there's usually a time when it's placebo control versus your versus calcitriol and calcium, and then you'll become an open label after that, which everyone gets the medication and the investigational product. And the nice thing about that, if you were in the NAPARA trials, you got it ongoing, and if you're in the Ascendus trial, you're getting that as well. So it allows you to get the medication for a long time, and sometimes before or until it's eventually approved, and sometimes beyond that. I know with NAPARA we had 5 or 6 years of therapy, so it allows you to do that. So, but there are concerns, are you willing to do this? Of course, you don't know if you're getting placebo, but most of the time you'll know because you'll not be able to come off the calcium. But it is double blind, meaning blinded, so neither the site nor you will know what you're getting. All right, so how do you identify a trial? You can go to clinicaltrials.gov. You can search for a condition, whether interventional and recruiting, and it helps you identify that site so you make contact with that site. Also, if you go to the Hypoparathyroid Association site, there is a link to this as well, so it makes it a little bit easier for you. So this is a little screenshot that I did. I went in clinicaltrials.gov, I put in hypoparathyroidism, and I put in, I wanted USA, and I wanted the recruiting and not yet recruiting studies. I didn't want all the studies because it would be all the studies completed as well. So I put that in there, several came up. So you can do more filters, you can do it by state, you can do it by region, other things you can put in there. So in this case, you click on a study. This is the Amulet study, and I'll give you a little, I know you can't see this, but it gives you a study overview, what's the study about. And you can toggle down and scroll down and find what's involved in the study, what are the entry criteria for the study, what's involved. And you can also look at the sites that are included and see what's available to you near your region. So that allows you to find out what's going on. Again, you can easily get there from the Hypoparathyroid Association site. So what is the process? Well, if you're not part of the site, you're not getting your medical care from that site, we'll need to get your medical records. So you usually have to request that to review. And then there's something called an informed consent, which is the most important process of the clinical trials. That means there's usually a very thick, maybe 20 pages or so, discussing why are you doing the study, what the medication is, what are your obligations in the study, what are the potential side effects of the medication. and how often you have to come in. And usually I like to have this sent out before the person comes in, so they have plenty of time to read it and make notes, and so they can ask me questions. And we want to make sure that all your questions are answered before you sign this. So once that is signed by the participant and the principal investigator, then we can do our other things. We can't do anything, we can't ask you to do anything before that, even can't even tell you to fast. We can't tell you anything, you just come in and we'll discuss it. Once you do the consent form, then we can do the next step. And don't worry about memorizing anything in there, because you will get a copy of the signed document. And I always think it's great because it cures any insomnia. You just read through it and you'll quickly go right to sleep. So keep it by your bedside. So then we can do some screening procedures, which often includes lab work, EKGs, medication, and medical history, directed physical exam. And then after they do that, we'll determine, get all that back to see if you would qualify for that particular study. And then you're brought back and you're randomized. And the way you randomize, we put the number of the patient in the computer, and it tells us what we're supposed to pick. And of course, it's blinded to us. We don't know what it is, but it's randomized, and then we get started with medication. You'll have follow-up appointments, and again, we get labs, etc. And finally, the trial will end, and usually might be a follow-up after that. Now, if you're doing studies for HypoPARA, there's a fair amount of lab work involved. Once you change the medication, you have to get a calcium level done. Often we can do that in a local lab for you, so that makes it a little bit easier. So you don't have to keep coming back and forth so often. So that's the process, and it's important that you understand what's involved, and it's fairly straightforward. So just to conclude, I think clinical trials are certainly necessary to ensure the safe and effective treatments, and I think in the U.S. we've certainly got that, and the rest of the world as well, they've followed suit. FDA does regulate the drug development process, and the subject's rights and safety are paramount, which of course I think is spot on. So I'll stop there and see if there are any questions.
Who has questions for Dr. Warren? Clinical trials.
Yes.
Is there any chance we can work with the FDA to get the entry requirements around the PTH trials changed? I don't think it's safe or appropriate to have us have to drop off of our PTH medications for 30 to 60 days prior to the start of the trials. I've gone looking on the clinicaltrials.gov, and not one of the insulin trials I've looked at of the first 25 ask diabetics to drop off of their insulin for a month.
Yes.
So why are we being asked to?
Well, the FDA is a strange and mysterious place.
Yeah. Mark, I actually have a comment about this. Yeah,
we
Mark,
got-
I actually have a comment about
Yes,
this.
please.
So about a year to 2 years ago, the FDA changed their requirements for rare disease and actually did make it unethical to actually have people come in off of drug. I just don't think that they pay attention to the hypopara world in the same way they've paid attention to other rare diseases and endocrine. So I would strongly, strongly suggest that the way you're going to get them to change their mind about that is you protest as a patient care organization, as an advocacy group, because that's how it got changed on the Cushing's groups and the acromegaly groups. That's how they get changed, because the FDA is a strange and opaque beast, one of which I simultaneously loathe and love. So for those reasons, because they don't change unless you make them change, and they don't really listen to us, and they definitely don't listen to pharma. They absolutely could care less what pharma has to say to them. But they do listen to patients, especially if you are strong in your resolution, and also many of you. So I would suggest that you plan to go when sponsors are going and plan to go when there's reviews, because that's the only time the committee is all together. Because if you go individually, the committee won't be there, and they need to hear from all of you, because the biostatisticians are the most non-humanoid people I've ever met. And so they need to see you en masse protesting this issue because of a safety concern, because you got to get the biostatisticians, and they're never going to be there unless there's an actual meeting. So it's not the doctors, it's the biostats people, because they just look at numbers. So I would suggest that you treat it like the other rare disease companies have treated it, which is basically get the patient advocacy groups in there to make that change demand, because it happened about a year or two ago for the rest of endocrine, and for whatever reason it's not happening, and like there's not the same committees, because it's not the same committees. Yeah.
So Michelle has gotten us set up with a patient-focused drug development meeting with the FDA. So we'll be doing that on March 5th, and she'll tell you a little bit more about that tomorrow. What other questions?
Well, we have the table back here. That was great. I learned so much every time. 2 points. Since a lot of us are doing the trials, I would say that except in hypoparathyroidism, there's a 30 to 40% placebo effect when you believe in it, but not in hypopara, right? 3% or less. I mean, it's just scary to have to take you off your active D and calcium when you might be on placebo in a trial. But the good thing is the safety, like you say, Mark, is so, you just go right back. You do what's best for you, not what the protocol says if you're not on PTH. I asked the same thing when I was asking the investigators, why do people have to be off for 3 months? But that's partly because of what happens in the bone and kidney. When you come off your PTH, it will be impossible to know what's going on if you're starting a new PTH when you've just come off that PTH. And so it wouldn't be an accurate trial. Now, I don't know about 3 months. We might be able to ask the people that decided that in the trials, because I was pleading for 2 weeks, but it's just not long enough. You need that time.
But it seems like instead of having them go cold turkey and go back to conventional treatment, oral treatment, you could do a transition period where you put them on the new medication for anywhere from 30 to 60 days before you start taking study data. And that would provide the same thing, because they don't do that with anything else. If you look at the rest of the trials that they have for life-sustaining medications, which this is one, they don't do that. They give you a transition period.
All right, question? Bob's coming to you.
I was in your study for NatPara, and they allowed, at first they were saying if you were on something else, when you got out of NatPara and you went into TransCon, which I'm in now, they waived that time frame for.
Yeah, it just depends on the protocol, yeah.
Yeah, because I was in at your study for NatPara, and then TransCon said they waived that.
Questions? Do we have questions online, Michelle? So the only other question I would ask is if somebody was wanting to get into the clinical trial, you mentioned they need medical records if they're not there. How long? What type of medical records do they need to bring? Is it just about hypopara, or is it about other things?
Mostly it's about the particular condition, and I just would like to know, having some records that said they've had it for at least a year, for example, that they've had a PTH level done in the last year or wherever, and just to confirm, because what will happen is if you get audited by the FDA, they're going to go and see, okay, where is the evidence that person qualified for the study? So you have to have that available. So I just need enough records for 1 or 2 years. Usually it's not hard to do now with electronic records. I can just quickly send it to you. So it's not that difficult. Now, if you're an Epic, sometimes we can get it that way. If your records are an Epic, we can sometimes do it that way. Other times we just have to get you to write for it. I'll just usually ask for 2 years worth of maybe the treating endocrinologist, perhaps. I don't need all the medical records, just enough so I can verify that you have this condition.
All right, very good. Dr. Colmar?
Thanks, Mark. Can you explain how important it is to try to have your thyroid stable? Because we know how hard that is if you're going to enter a trial? Because once you have your first screening day, you only have so long, and you'd think that that wouldn't be a problem, but we all know it is.
Well, particularly with the AMULET study you and I were participating in, you have to have the TSH in a certain range, and it can't be below 0.2 if you have thyroid cancer, and it's got to be within 10% of the lower limits of normal otherwise. And so if we know that if your TSH has been too low, we just need to change your dose perhaps, and it's got to be stable for 6 weeks. So that may delay things as well if your TSH isn't right. So once you're in the study, it doesn't matter, but they don't care so much. But it's part of the entry criteria. You may screen fail. That's a good point. That's been part of the hardest part of that particular study, is getting the TSH right.
Okay, we have a question about, can you give an approximation of what kind of time commitment it is for these type of studies?
It depends on the study, of course. The calcilytics is not that difficult. Usually once a month or even twice a month or every 2 months, depending on what part of the study you're in. Usually if you're doing a PTH study, it's going to be probably initially a monthly, sometimes maybe twice a month or the first month or two. But often we can make the adjustments and just see you once a month. And after the beginning of the study, once you're on stable dose, those visits started getting less frequent. And what you have to do is look at when you look at the informed consent, it'll tell you that and give you more detail. It varies from study to study, but every study has initially you're going to have more frequent, maybe I said every 2 weeks sometimes, but it does get less frequent. Okay, thank you.
All right, very good. So let's see. So our next presenter is going to be virtual as well, but we'll be bringing her in for Q&A after. This is Dr. Khan. She's a clinical professor of medicine, divisions of endocrinology and metabolism, and geriatrics at McMaster's University. She is the director of calcium disorders clinic as well as fellowship in metabolic bone disease at McMaster University. So let's pay attention to Dr. Khan.
Thank you so much for asking me to speak about advances in drug therapy. And I will be presenting what's new in the treatment of hypoparathyroidism. And it really is my pleasure to speak to everybody today at the HypoPARAthyroidism conference. These are my disclosures. And I wanted to begin by reminding everybody that normally the serum calcium in our blood is very carefully sensed and regulated, because calcium is essential for every single cell in our body. And so when the serum calcium goes down, when the blood calcium goes down, the calcium sensing receptors on the surface of the chief cells in the parathyroid glands, and these receptors are in other tissues as well, most notably also in the kidney. And this reduction in serum calcium is sensed by the receptor on the parathyroid gland cells, and it increases the synthesis and the secretion or the release of parathyroid hormone. And the calcium sensing receptor works like a thermostat. So in our house, we have a thermostat, and when the temperature in the house goes down, the thermostat triggers the furnace to go on to generate heat. So in the same way, when the blood calcium goes down, it's sensed by the receptors on the surface of the chief cells, and they increase parathyroid hormone production. And what parathyroid hormone does is it will bring that calcium back up, just like the furnace will elevate the temperature in the house because the house was too cold. So how does parathyroid hormone bring that calcium back up? The immediate next step is increased calcium reabsorption through the kidney. And every day we filter 10 grams of calcium through our kidney. So if someone is taking 1 gram of calcium, well, we filter 10 times that amount. It's a lot of calcium in a 24-hour period that is filtered through the kidney, and then we reabsorb 9.8 grams. And we need parathyroid hormone to do that. So if we don't have parathyroid hormone, then we have a major leak of calcium through the kidney. And why is that a problem? Well, that is a problem for the kidney. It can cause kidney damage. It can cause calcium deposits through the tissue of the kidney. It can also cause kidney stones. So it's very bad for the kidney to be filtering all this calcium and not reabsorbing that calcium. So high urine calcium is detrimental for kidney function, and it contributes to kidney stones and calcification of the kidney. And also, it's a loss of calcium. And so this is one of the reasons why that calcium is contributing to the low serum calcium. So parathyroid hormone brings that calcium, it increases the absorption of calcium, and that will help to bring that calcium back up. The next thing that happens with parathyroid hormone, so this happens within minutes. The next effect of parathyroid hormone over hours is increases in bone resorption. So our skeleton is a reservoir or a bank for a number of minerals, calcium and phosphate and magnesium. They're stored in our skeleton. And parathyroid hormone will cause osteoblasts to release a signaling protein, which causes the osteoclast to dig out more bone and release calcium and phosphate into the bloodstream. And then if that serum calcium is still low and parathyroid hormone is still elevated, the third effect of the high PTH is to increase the activation of vitamin D. So vitamin D will become activated in the kidney to become 125 dihydroxyvitamin D, which is calcitriol. And so these three effects bring that calcium back up into the normal reference range. So if someone does not have parathyroid hormone because the parathyroid glands were removed, and 75% of people who don't have parathyroid hormone, enough of it, will have this post-surgical because of damage to the parathyroid tissue. Or it could be because of other reasons. And the most common cause is autoimmune. And this could be in isolation or as part of a syndrome, autoimmune polyendocrine syndrome 1, where we can also have fungal infections in the mouth, and they can also be adrenal gland damage as well as other tissues can be damaged. So there are many other symptoms and signs of autoimmune polyendocrine syndrome and other conditions associated with it. So there could be many reasons why the parathyroid glands aren't functioning, but the effect of inadequate parathyroid hormone is a low serum calcium. And because we don't have parathyroid hormone, we don't have the ability to correct this low serum calcium. And we're losing calcium through the kidney. We're not able to get the calcium out of the bones. So it's staying in the skeleton, and we're not able to activate vitamin D. And activating vitamin D helps us to more efficiently absorb calcium and phosphate in the bowel. And active vitamin D also helps us to get the calcium out of the skeleton. And so people who do not have adequate parathyroid hormone have these features. So we recently had a major consensus conference, and we did review the entire global literature, and we developed new guidelines for the evaluation and the management of hypoparathyroidism. And there were 8 papers that were published looking specifically at hypoparathyroidism, and this is the summary statement. And all of these papers were just published in December of 2022 in the JBMR, and these papers are now available online for everyone to review. And we confirmed that we make the diagnosis of hypoparathyroidism in the presence of a low serum calcium and a low or an inappropriately normal parathyroid hormone. Because if calcium is low and if the parathyroid glands were functioning normally, then parathyroid hormone should be elevated. It should be elevated. So if it's not elevated and it's just sitting in the low normal reference range or the middle normal reference range, then that's inappropriate. It's just like if the house is cold, the furnace should be working excessively, not just coming on and off every now and then. If the house is cold, it should be working continuously to elevate that temperature. So in the same way, parathyroid hormone should be elevated. So if it's inappropriately normal or low, then that confirms that we have inadequate parathyroid function. And we had a large group of co-authors. This was a huge global effort, and we had approximately 100 experts from around the world helping us to develop these guidelines. And Michael Manstad was leading one of the teams that was looking at the diagnosis of hypoparathyroidism. And in this paper, we confirmed that a low serum calcium confirmed on 2 separate occasions, at least 2 weeks apart, in the presence of a low or inappropriately normal PTH, confirms the diagnosis. Another important point to remember is that parathyroid hormone will increase calcium reabsorption, but it eliminates phosphate. So if we don't have enough parathyroid hormone, phosphate levels start to climb. Why is this a problem? Because calcium binds with phosphate and it can calcify tissues that should not calcify, such as elements in the brain, such as blood vessels in the heart, cardiovascular calcification, such as kidney tissue, such as the lens in the eye. And we can get cataracts, we can get heart disease, we can get kidney damage. And so it's very important that we keep that phosphate in the normal reference range. We should not allow it to be high because this will contribute to calcium deposits in the brain, the basal ganglia, and deposits of calcium in tissues that are not supposed to calcify. And we also know that if we are not able to activate vitamin D, our ability to absorb calcium from the bowel will be impaired. And this will also contribute to low serum calcium. And active vitamin D helps us to access the calcium in our skeleton. And as I mentioned, there are many reasons for developing inadequate parathyroid hormone function. 75% are post-surgical, but 25% are autoimmune. And then we have genetic variants. So the genes that are necessary to form normal parathyroid tissue have a mutation in them. And there are many genes that are required to form normal parathyroid tissue, and the function of the parathyroid glands is also determined by genes, various genes, and the effects of the parathyroid hormone on the end organs is also going to be affected by various genes. So there could be genetic variants that will have an impact on the synthesis and secretion and the effects of parathyroid hormone. And these glands can, in some people, be infiltrated with granulomas. And it's important for your doctor to evaluate granulomatous disease because this could be the cause, such as sarcoidosis or amyloidosis. This can be a cause for an abnormal parathyroid function. And the glands can also be damaged because of deposition of copper or iron or aluminum. Some patients who have cancer that has spread to other tissues can develop inadequate parathyroid gland function. And the cancers that can do that include skin cancer, breast cancer, leukemias, lymphomas can do that. Radiation, the glands could be radiated and therefore not be functional. If magnesium levels are high, high magnesium can turn off parathyroid function. And we also need magnesium for the actions of parathyroid hormones. So there can be a tissue resistance to parathyroid hormone if magnesium levels are not normal. So it's important for physicians to evaluate magnesium whenever calcium is evaluated. In the presence of burns or severe acute illness, we can also see that the parathyroid function can be affected. And pregnant women who have an overactive parathyroid gland can have babies born with underdeveloped parathyroid tissue. So there are many reasons for inadequate parathyroid function, and doctors need to evaluate this, determine is it post-surgical or is it non-surgical. These are all the non-surgical causes, and then find out why our patient has hypoparathyroidism. And we also recommend that we look at other features to see if there are other diseases that need to be evaluated in determining the underlying cause of the hypoparathyroidism. Now, what are the complications of hypoparathyroidism? And looking at all the global literature, what we found was that these are the common complications of hypoparathyroidism. And 24% of people with hypoparathyroidism can have cataracts. People with hypoparathyroidism can have infections because the immune cells need calcium to function. They can get kidney stones and calcification of the kidney tissue. Kidney damage can happen. Kidney function can be impaired. They can develop seizures because the brain cells need calcium. They can be depression. They can develop heart disease because there could be calcification in the blood vessels. And there can be arrhythmias because the QT interval, the electrical circuitry of the heart can be affected when calcium levels are low. And so these are how the manifestations of hypoparathyroidism present today. So how do we treat hypoparathyroidism? Well, we can give back calcium. And usually we have to give large amounts of calcium. And we can give 500 milligrams 3 times a day. We always give calcium with food. The reason why we give calcium with food is because then it does 2 things. First of all, we're giving the calcium with the meal, and then it will also bind the phosphate in that food. And so it will bind the phosphate and get rid of it through the stool. So all my patients, I tell them, be sure you always take your calcium with your food. Take it with breakfast, take it with lunch, take it with dinner. And we start with 500 milligrams 3 times a day. If that's not enough, then we can go up higher and higher. Some patients need 3 to 4 grams 3 times a day or even 4 times a day. Large doses of calcium may be required. We always emphasize taking the calcium with food so that it will bind the phosphate and help to bring that phosphate down, because phosphate, when it's high, it causes ectopic calcification or calcification of tissues which are not supposed to calcify. Patients can take calcium carbonate or calcium citrate. Either of those are good options. We also want to correct vitamin D. Vitamin D should be normal, and we give active vitamin D because parathyroid hormone is a value in forming active vitamin D. So it enhances the activation of the vitamin D, and patients with hypoparathyroidism will need active vitamin D. Now, some patients have mild hypoparathyroidism. They still have some parathyroid functioning tissue, and they just need some calcium supplements 3 times a day. But if there is hypoparathyroidism, patients might just need 0.25 micrograms once a day. I have some patients who just take it 3 times a week. But then we have other patients who need higher doses of calcitriol. Now, the half-life of calcitriol is 5 to 8 hours. And so it's ideally given twice a day, or sometimes it can be even given 3 times a day. So you can begin by 0.25 micrograms once a day. And if we need to go up higher, we can go up to 0.25 micrograms twice a day, because it doesn't last the 24 hours. So it's best to give it in divided doses. Alpha calcidol is available in Canada, but it's not as powerful as calcitriol. It's only half as powerful as calcitriol, and it can also be given in doses that are built up. And we also can give thiazide diuretics. And what these drugs do is they increase calcium reabsorption through the kidney. But they can be a problem because they can cause magnesium to be lost and potassium. And patients who have autosomal dominant hypocalcemia already have a problem with magnesium. So we do need to be careful about thiazide diuretics. They can also, in young people, cause the blood pressure to go down and cause dizziness and lightheadedness. Now, we looked at all the world literature and looked to see how effective parathyroid hormone was in comparison to conventional therapy, calcium and active vitamin D. And we found that the NET para drug, PTH 1 to 84, in comparison to calcium and active vitamin D, was of value in increasing serum calcium, so allowing the amounts of calcium and active vitamin D that were being taken by patients to be reduced significantly. And it was helpful in keeping serum calcium in the normal range. And what was seen was that the calcium phosphate product, combination of those two, and the serum phosphorus did go down. So that was a good thing. But urine calcium went down in both the PTH group and the active therapy group. So the reason why we feel that it was not as effective in normalizing urine calcium could be that this molecule has a half-life of 3 hours. So it doesn't give us 24-hour protection for the kidney. And there are other studies as well that have been done showing that there was no reduction in urine calcium with this molecule. And we feel that this is a reflection of the fact that this drug does not have 24-hour coverage. There is teriparatide, PTH 1 to 34, and this has been evaluated in a number of trials by Karen Weiner and her colleagues. And these studies have shown that we can maintain normal serum calcium, but when we give the parathyroid hormone in multiple doses or as an infusion, then we're more able to reduce urine calcium. And so it confirms again that just giving a single dose of PTH is not enough, because PTH 1 to 34, its half-life is 1 hour. And so again, it doesn't give us that 24-hour coverage. It has to be given at least twice a day for us to see an impact on urine calcium and to provide an impact on patients' well-being and reduce the complications that we're seeing. There was a phase 2 study looking at TransCon PTH. And what TransCon PTH is, palopeg teriparatide, it's PTH 1 to 34, but it's connected to a polyethylene glycol molecule that protects this and increases the half-life of this drug from 1 hour to 60 hours. So it gives us that full 24-hour coverage. And what we've seen with this drug is that it will maintain serum calcium and it will reduce the urine calcium losses. And we've seen that in the phase 2 and the phase 3 studies. And we've seen a dramatic improvement in patients' well-being and reductions in the need for calcium and active vitamin D and reductions in urine calcium. And so this is what it looks like. We've got the PTH 1 to 34, and it's connected to this molecule. And when we give it, when we inject it, and it's injected subcutaneously into the abdomen, or it can be given in the thigh, then what happens is that the linker is cleaved and the drug is cleared through the kidney, and the PTH will have an effect on the PTH receptors, but its effect is over 60 hours. So the effect is over 60 hours, and it provides stable levels of PTH over the 24 hours that we need for our patients. And this TransCon PTH in the phase 3 study was evaluated 18 micrograms in comparison to placebo at week 26, looking at how many people were able to keep the serum calcium in the normal range and stop their calcium supplements and be able to stop active vitamin D. And stopping calcium supplements meant that they were taking less than or equal to 600 milligrams of calcium just as a nutritional supplement. And these patients were very closely followed. And what was seen was that 79% of patients were able to meet all of those criteria. And you can see that 98%, so basically all of them except for one person, was able to stop completely active vitamin D. And 93% of patients were able to reduce their calcium supplements so that it was less than 600 milligrams a day. So that's really very impressive. And if we look at their serum calcium, it was in the normal range off calcium supplements, and all of them except for one person was off active vitamin D as well. And this is the placebo group. And we can see that calcium doses were like less than 500 milligrams, and everybody was able to stop active vitamin D except for one patient. So that was really impressive. And what we saw was a dramatic improvement in patients' well-being. And my patients who have been on this medication, they've been able to come off disability, they've been able to go back to work. Young students have noted a dramatic improvement in their scores at university. They've been able to get jobs. Some of my patients have begun to travel. They're climbing mountains. They're building houses. Their life has changed. And many patients have told me it was like going from a dark room and coming out into the open air. So this is the benefit of giving back the missing hormone, not just for a few hours of the day, but covering 24 hours of the day, every day. Make sure that we have that parathyroid hormone impacting on the brain, making sure that parathyroid hormone is going to normalize serum calcium, drop that phosphate, drop that urine calcium. And very recently, we've seen that TransCon PTH can actually reverse, it seems to reverse the kidney damage that we've seen in patients. And this is a very promising treatment, resulting in major benefits in patients that we've already seen. And we're expecting with our long-term data, even further impact on reducing these complications of hypoparathyroidism that we were talking about. Now, in the new global guidelines, we said that patients should begin with conventional therapy, which is calcium and active vitamin D. And if it isn't enough, if serum calcium is not properly controlled, calcium levels are going up and down, or patients don't have enough impact on the brain fog and the ability to think clearly and function like they were before, or if phosphate levels are high, or the urine calcium is high, then we do recommend going on to PTH therapy. And we recognize that we need longer and larger studies to evaluate this further. But we do recommend normalizing the phosphate levels and dropping that urine calcium into the normal reference range and improving the symptoms and bringing that serum calcium just below the normal reference range or in the lower half of the normal reference range. And we recommend normalizing magnesium and vitamin D. In pregnant women, we recognize that a woman is pregnant if they have hypoparathyroidism. We know that the breast and the placenta also secrete PTHRP, which is like parathyroid hormone. And this can help to get calcium out of the skeleton. And this can help to form active vitamin D. And it acts like PTH. And pregnant women, we need to monitor their serum calcium very closely. And we need to ensure that calcium is in the normal reference range. And this is essential for the fetal parathyroid glands to develop normally and to ensure that the pregnancy outcomes for both the mother and the baby are ideal. Now, I wanted to say a little bit about new therapies as well for this presentation. And some patients have autosomal dominant hypocalcemia type 1. And this condition is caused by a mutation in the gene that encodes the calcium sensing receptor. And it's a gain of function mutation, which makes this receptor super sensitive. So what is happening is the receptor is thinking that the calcium levels are higher than they really are, and it's turning off PTH. So it's like our thermostat thinks that the temperature in the house is higher than it is, and it keeps the furnace off. So that's a problem, and there's nothing wrong with the furnace, but the problem is with the thermostat. So if we could give a drug that can normalize the function of the calcium sensing receptor, then the parathyroid gland can function normally. And this drug that is being evaluated is called encaleret, and it can normalize the sensitivity of the calcium sensing receptor. And it can normalize parathyroid hormone and serum calcium. And it can normalize urine calcium in people with autosomal dominant hypocalcemia. There's another drug that is being evaluated, and this is called eneboparatide, and it's a long-acting PTH-PTHRP analog. And what it does is it binds to the PTH receptor, and it stays bound to the PTH receptor even after it's been cleared through the bloodstream. So it stays bound to the PTH receptor, and it allows the PTH receptor to continue to have an effect. And this allows the drug to have a long-acting effect on the PTH receptor. And this has been shown in patients with hypoparathyroidism to reduce the requirements of active vitamin D and calcium. And it also has been shown to decrease urine calcium. And this drug is also undergoing clinical evaluation and phase 3 studies. So I'd like to conclude by saying that hypoparathyroidism is a condition which is a serious condition, and it is associated with long-term complications, which without parathyroid hormone therapy requires high doses of medications given in multiple doses throughout the day. And this is not an easy condition to treat. And patients are severely affected by this. It can affect the clarity of thinking. It can affect vision by causing cataracts. It can cause seizures. It can cause anxiety. It can cause depression. It can have an effect on lung function. It can cause bronchospasm. It can cause heart failure. It can cause cardiac arrhythmias. It can cause kidney damage, kidney stones. So it has a major, major effect on an individual's quality of life and their function. And By giving back the missing hormone, we can correct this problem. And research is advancing very quickly in hypoparathyroidism, and we anticipate that our ability to treat patients with hypoparathyroidism is going to dramatically improve when teriparatide becomes available, which is expected to happen in Europe very soon, and also in the US very soon, and hopefully in Canada next year. And we also have other molecules that are being evaluated as well. And so the treatment for hypoparathyroidism is really going to be revolutionized. And I've seen this in my patients who are on teriparatide, a dramatic improvement in their quality of life and their ability to function on a regular basis, on a day-to-day basis. I tell my patients, if I had this condition, I wouldn't be able to do my job as I'm working today if I didn't have access to PTH. I don't think I could be taking all those doses of calcium and active vitamin D and still be working at the rate that I'm working if I didn't have access to PTH replacement therapy. So with that, I'd like to thank you for your attention, and I would be happy to answer any questions as I will be taking them live. Thank you so much.
All right. Dr. Khan, always a pleasure. Hello. We're happy to see you. All right, so we're going to have some thank you so much. Your presentation was absolutely wonderful. So questions from the audience first, and then we'll go online.
A few years ago, I saw a doctor at Chicago University, Tamara Vokes. She's retired now. She did a lot of the clinical trials for NatPara. She told me to get as close to 7.5 in my calcium. I only have one kidney and stage 3 chronic kidney disease. And everything I've heard today says 8.0 for like the lowest spot. So should I be trying to run it closer to 8 or keeping it in the mid-7s?
So that's a really good question. And we do aim for the calcium to be at the lower level of the normal range or just below it, because we don't want to run patients too low, because that can affect your ability to think clearly. It can increase your risk of complications. So that's the goal. And it's important, that is our target, we want to also keep phosphate normal and the urine calcium normal. The more calcium and active vitamin D we give, the higher the urine calcium will be. So if we can keep your calcium a little bit closer to the normal range while maintaining a normal serum calcium, then that would be ideal, and a normal phosphate.
And
So
I just had one other quick thing. Did I hear you say that TransCon can reverse kidney damage?
Yeah.
Wow.
Way.
That's all. Thank you.
Yeah.
All right, anybody else from the audience, and then we'll go online. Michelle?
Okay. If one is on a potassium-sparing drug for hyperaldosteronism and has to watch their potassium in their diet, is thiazide recommended?
Well, if they might not need it. So I would recommend that such individuals simply continue with the calcium and active vitamin D. We can certainly combine spironolactone with hydrochlorothiazide as well, but using higher doses of diuretics can cause blood pressure problems, as we discussed. So if the blood pressure goes down, it can be a bit of an issue. So if you're already on a potassium-sparing diuretic, then it may be adequate to just go ahead with the calcium and the active vitamin D instead of adding hydrochlorothiazide.
Okay. And the next question from online is, what is a clinical sign that you should increase your calcitriol instead of your calcium?
So basically, it depends on a number of factors. If the phosphate levels are high, we prefer to increase the calcium and always give it with food because calcium binds to the phosphate and gets rid of the phosphate. If the phosphate levels are high and we increase the calcitriol, that'll make the phosphate levels even more high. So it's better that we're careful with what we're trying to achieve. So if the calcium levels are low and we want to normalize the calcium, we look at the phosphate and the urine calcium. And if the calcium is low and the phosphate is high, I prefer to give more calcium. If the calcium is low and the phosphate is normal, then I would give more active vitamin D. But I also look at the urine calcium and I also look at the doses that the patient is on right now.
Go ahead.
Okay. What is the effect of TransCon on the bones?
Okay, so what we know that patients with hypoparathyroidism, we have done bone biopsies on these individuals, and we've seen that there is more dense bone structure. And this is an area that is being investigated further. We don't have any prospective data looking at the risk of fracture in patients with hypoparathyroidism. What we've seen so far with TransCon PTH is that patients who start TransCon PTH start with a higher bone density, and that bone density comes down towards the normal reference range. And we are seeing that there's an increase in the rate of bone removal and bone formation. And then this comes down and is established at a level that is closer to the normal reference range. But we will be looking at long-term skeletal data and we will be evaluating this further.
Okay. If we don't have a parathyroid anymore, why do we need calcium supplementation in addition to the calcitriol?
So we do need calcium because just giving calcitriol, what calcitriol will do is it will increase the absorption of calcium and phosphate from the bowel, and calcitriol increases the formation of osteoclasts. And so the osteoclasts can get calcium out of our skeleton and shift it into the bloodstream. But we also need to make sure that our patients are getting calcium because we need the calcium from food sources. Otherwise, we're only getting calcium out of our bones. So if patients don't have PTH, then they're not able to form their own active vitamin D, and they need active vitamin D to increase the absorption of calcium and phosphate from the bowel. So they need to be taking calcium. And we also supplement it with calcitriol because they don't have enough of their own endogenous calcitriol. So we like to give both. Just giving calcitriol will not be adequate because we'll just be accessing the calcium from the skeleton. And we want to be able to ensure that patients are taking calcium as well.
Okay, thank you. Is there a standard dose of magnesium you recommend?
Well, the magnesium has to be measured. And we know that if we have very high levels of magnesium, it can bind to the calcium sensing receptor and turn off PTH. And we know that if the magnesium levels are low, it's a cofactor to adenylate cyclase, which affects the function of PTH. So magnesium has to be normal. And we measure magnesium and then we adjust the supplement based on the level. So for example, patients who have autosomal dominant hypocalcemia, they can have a leak of magnesium through the kidney. And these patients need high doses of magnesium. And in these people, giving them hydrochlorothiazide can make that magnesium leak even worse. So we have to be very careful with magnesium levels in these individuals. But we have to measure magnesium and adjust the dose accordingly.
Okay, thank you. Someone is asking if PTH is, wait a minute, let me go back, I'm sorry. PTH is not enough to absorb calcium from the gut. How come calcifications might occur from the calcium supplements?
Right. So coming back to that initial diagram, which I showed, so what PTH does is it helps us to reabsorb calcium from the kidney, right? Because every day we filter 10 grams of calcium. That's 10 grams of 1,000. So that's a lot of calcium. That's 10,000 milligrams of calcium. So we filter 10 grams and then we reabsorb 9.8 grams, or 9,800 milligrams of calcium is reabsorbed every day. And that is dependent on PTH, amongst other hormones. And the other thing that PTH does is it increases the formation of active vitamin D. And so this active vitamin D helps us to absorb the calcium from the bowel with the phosphate. And then PTH also helps us to get the calcium out of our bones. So those are the three effects of PTH. And by those three effects, PTH is able to bring that calcium back up into the normal reference range. So if someone doesn't have PTH, just giving them active vitamin D isn't enough. We also want to be able to give them calcium, and we want to ensure that they're absorbing that calcium. So we do give them active vitamin D. And because they're not able to access the calcium from their bones and they're not able to reabsorb the calcium from their kidney, there's going to be this loss of calcium through the kidney, and the calcium in the skeleton is not being accessed. So that is the problem that we have. That's the dilemma. So we want to be able to ideally give back PTH. And once we've got a molecule that is going to provide 24-hour coverage, then that's what we want our patients to be on.
Okay. The next question asks, if we don't have enough PTH and calcium is not absorbed through the gut, how come it ends up in the kidneys instead of the bowels?
Right. So why do we get the ectopic? Why is the calcium deposits in other tissues, right? So what happens is that the calcium binds with phosphate and it deposits in other tissues if this calcium phosphate product is high. So if phosphate levels are high, it will bind to the circulating calcium and it deposits in the brain. This is why it's very important to keep that phosphate normal. It's absolutely critical that the calcium phosphate product not be high. We don't want phosphate to be high because phosphate will bind with calcium, and there'll always be calcium in the bloodstream because we need calcium in the bloodstream. So if the phosphate is high, the phosphate will bind with the calcium, deposit in the lens of the eye, deposit in the brain, deposit in the kidney, the parenchyma of the kidney tissue, and cause damage to the kidney. And high urine calcium will contribute to kidney stones. And high urine calcium also declines renal function. It's detrimental to renal function. This is why we have to drop that phosphate. We have to drop that urine calcium loss, because high urine calcium will contribute to further decreases in kidney function, and it will contribute to kidney calcification. And we don't want that. We want to preserve kidney function. We don't want the patient's kidneys to calcify, and we don't want patients to have kidney stones.
Okay, we have 2 audience questions.
Hello, I have a question. My phosphate is a little high, 5.3, but my endocrinologist is not worried because it's just a little over the 4.5. So at what point do we need to be worried about these too much phosphate forming these deposits in tissues we don't want them to be in?
Oh, we don't want the phosphate to be higher than normal.
So 5.3 is something that you would already be treating?
Yeah.
Okay. Thank you.
Yeah. And if you ask your endocrinologist to review the new guidelines, we clearly said that phosphate has to be normal.
Hi, doctor, this is John. We saw you in Buffalo a few years ago and left a great impression then, and you're even better now, kid.
You're too kind.
I hear you on the phosphate. and I've got high calcium phosphate. What's the best way to address it? How do I get it down?
Well, it depends on how well controlled the serum calcium is. And if we can drop the calcitriol dose, then that would be good. And so I would increase the calcium, start dropping that calcitriol, because the goal is to drop that phosphate. And we always give calcium with food, so it will bind to the phosphate in the food. Also, going on a low phosphate diet can be helpful. And if there is still a high phosphate, then sometimes we add in other phosphate binders like sevelamer. But there's lots of strategies to lower phosphate. And it's based on the diet, go on a low phosphate diet, make sure that the calcium is always taken with food because it binds to the phosphate and gets rid of it in the stool. Try and reduce the calcitriol dose. And think about PTH. You know, you might want to try PTH, teriparatide, even just once a day can be helpful. Because it will help to reduce your calcitriol dose. And if we reduce the calcitriol dose, the calcitriol is what's causing the phosphate to go up. So the calcitriol is a double-edged sword. You know, it helps you because it helps to increase the calcium, but it hurts you because it increases the phosphate.
Okay. All right. Well, Dr. Khan, thank you so much for all your time and attention to the HypoPARA community. We just appreciate all the work that you do. Let's give it up for Dr. Khan. Thank you. All righty. So there we are. We're at the end of our very informative day today. I hope you guys have enjoyed it. Have you enjoyed it? Yes. All right. Very good. So we still, tonight, we're going to have our buffet dinner will start at 5:45. We're also going to have a keynote speaker in here. We know how hard it is to live with a rare disease, so we wanted to make sure that we touched on that emotional, mental part that happens with a rare disease. So she's going to be talking to us about how do we live with a rare disease. So when you go for your buffet dinner at 5:45 in the lobby, you can bring it back in here, and she'll get started at 6:20. We'll have her for about 45 minutes, and then we actually have s'mores by the fire pit later on. If you want to join us, we'll be outside. Bring your coats, of course. We got some really long skewers to do some s'mores tonight, so that'll be fun as well. And I think that's probably it for today. Thank you guys so much for everything. Thank you for being here, and we'll see you in a little bit.